Hello. Hello, Yasir. Hello. Yasir. Hello, auditorium. Hello. 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 Can you get audio from OT1? Audio from OT1? Audio from OT1? Yes, sir. Audio. Dr. Yasir? Dr. Yasir? Hello? Yes, sir. Yeah, the audio is clear. You're able to hear very much clearly. Yes, sir. It's clear, sir. Uh, sir, is the wing box clear? Hello? Hello? Sir, is the view box clear? Yeah, yeah, it's very much clear. Huh? It focus there till you intubate the patient and give position. Once you start the cystoscopy, at that time we have live streaming of the case. Okay? Okay, sir. Okay, sir. Bye. Thank you. Sir. Can we get OT2 now? OT2? बेटा तू रिव्यू पर थोड़ा समय काथे से तू बोझान हाँ OT2 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 बेटा कहाँ रिव्यू बोझ रही कैसे जरूरत अलर्ट पर रिव्यू OT2 दियो ऑडियो OT2 OT2 हेलो हाँ अस्सलाम वालेकुम डॉक्टर जफर एंड डॉक्टर जावेद एक्चुअली व्हाट इज द स्टेटस ऑफ ऑडियो इट इज ओके द साउंड इज ओके टू वे ऑडियो इज ओके अरशद भाई वालेकुम अस्सलाम yeah you are very much clear but we are concerned that whether the audio from our side is clear in or okay yeah you are in hello yeah you are very much clear looking very smart today okay okay what about in please go to another OT for just checking out the audio okay we want yeah walaikum assalam yeah very clearly you are in clear view yeah very much clearly but what about our side are we able audible there so this is a piloplasty for you yes you are extremely clearly audible are we audible to you okay done yeah it's a crystal clear image Okay, we'll be starting OT2 at the start, huh? Okay, good. Best of luck. Okay, bye. Arshad, Arshad, Dr. Kiptia from Department of Surgery, Sher Kashmir Medical Science Medical College, and Dr. KC Sharma. Hello, sir. A big hello. We welcome you, sir, on behalf of the organizing committee, sir. You reached yesterday, sir? Okay, sir. You are feeling comfortable here or a bit chilly? Okay, sir. Be comfortable, sir. Enjoy yourself. अरशद भाई, अरशद, हमको ना इस पे OT3 चाहिए. How much boz नहीं भाई? You say chairman से तुम इसमें बोल. Three, three. Yes, sir. Yeah, very much, sir. Is some imaging available for this case, sir? हेलो, वालेकुम सलाम. हाँ, देखो अगर अपने होंगे तो भी डालना, अगर नहीं होंगे तो मेरे निकाल देंगे. लेकिन थोड़ा इनको रिस्पॉन्सिबिलिटी बोलना है लेने के लिए, ठीक है चीजें अभी. ओके डन भाई. May I know who is a registrar in OT2? Registrar in OT2. Registrar in OT2. Daughter Neha? Daughter Neha? Okay. Can someone show the imaging as the imaging of this patient? Yeah, Assalamualaikum, madam. Please keep this laptop at very much in front of the camera. Uh, yeah, now it's very much clear. Excellent. things in DTP are available in the yeah. Okay. Okay. Thank you, Doctor, Shah, for narrating the case very well. Okay, please show the external view of the patient. Okay. Sarat, क्या? No, no, before no. Phone. Okay, Zafar sir, you are live now. Your audio is working. Your audio, you are connected. Very nice, sir. I welcome you, sir. Okay, thank you. Okay. Can you get the audio of OT3? Good morning, everyone. We start the first session of this live operating workshop. I'd like to call the chairpersons. Dr. Kiptia from Skills Medical College, Nagina. Dr. Kulwant Singh Bau, GMC Srinagar. Dr. KC Sharma, sir. Dr. Javed Qazi, sir. Uh, Professor Mufti Mahmood, sir, please. Open chairpersons. ये तो थोड़ी दो देखो थोड़ी थोड़ी तो ये कर्टन ब्रोट क्या जावेद when you put the OT this audience OT3 off for the time being till things are settled down. ये बैठे डॉक्टर ये बैठे ना Good morning, a very warm welcome to all of you. I'm so grateful that things have settled down after a very Herculean tasks for the last few days. I must compliment the team surgeon and the students who have done so many conferences to break back to back. We have been on 10 conferences for the last 2 years. And the live operating workshops, you know all that is very difficult to arrange the logistics and online system, more or less. We are able to maintain our legacy of holding such workshops uninterrupted and without you it will not be possible. And let's interesting things are settling down. Let's go to OT1 and do I have in OT1? Please. Hello. Go ahead, Dr. Rahul there. Hello. Hello, can you hear me? Yes, sir. Yeah, we can hear you. I don't know when you asked me now. Welcome, Rahul. I'm so glad that you have finally made it up. Come on, thank you. It's a pleasure for all of us, and believe me that it's going to be a learning for all of us, knowing your skills and caliber and the kind of training that you have received. From Nadia, from the important legacy of Nadia, whatever you have done. For the benefit for this, let me tell you that it is senior urologist and to having acknowledged that influence human being in Council of Lords Medical Society of India. And not this is a dynamic, thing in faculty for so many modules. He's demonstrated his skills so nicely, and which we compliment all of us. And he's good to let me tell you. And for his values, his respect for seniors, elders, he has all the virtues of a great teacher. And some message to the youngsters, people. So, Sure. Now, my teacher person, she's a senior consultant in Skills Medical College. Dr. Kulwant Singh Bhan. Hello, sir. He's the associate professor. Uh, do you know? I know him. Yeah. Excuse me, sir. So, Dr. Yasir is also here. He's also going to chair. Dr. Yasir, consultant in Senior Hospital. Okay. Skills from the schedule. So, let's see, start the case and send case. Results of the service. So, and we keep on. I hope everything is in place in your OT. It's taking place. And my team is there to look after you. Thank you so much. Thank you so much. Thank you, sir. Thank you. Let me go to OT3. Let me go to OT3, please. OT3. बस कितने लोग देखे ना ये घबरा देगी यार Then we have OT3, please. Then in OT3, Dr. Zakir Khande, who is associate professor and well-acknowledged pediatric surgeon, and his aptitude and training in pediatric urology is well known to all of us. He's been doing a lot of pediatric urology in SMHS hospital, and he is going to demonstrate uh, and a child of who is suffering from congenital pulmonary with junction obstruction with hydronephrosis, and I guess he's preparing the case for a laparoscopic transperitoneal pyroplasty. Yasir, let's give his comments. Dr. Yasir is there.
Hello, sir. Assalamu alaikum. Uh, Mr. Mic me up.
छोड़ो बेटा कोई बात नहीं। आना नहीं क्या आना चला बस कोई फर्क नहीं सरस बात इसको वाइट हेलो हेलो yes excellent आप ये इनको check one.
Well, till the things start getting ready, I must welcome Dr. Shafiq. Shafiq is a well-known urologist, robotic surgeon par excellence. He's been practicing urology for quite some time in Delhi. Basically, he belongs to the state, UT of J&K. He's done his post-graduation in MCH in urology from CMC Vellore, CMC Ludhiana with Professor Kim Menon. And I welcome you, sir. I'm so happy to see you. We'll have a good interaction for the next 3 days and work together with the promotion of Kashmir Urological Society.
Since a lot of many students are also in the audience, so pre-operative optimization and preparation of the patient is very important, which is being done in the current OT on screen. Like since the laparoscopic surgery is going to be performed on a small child, so you need absolutely perfect conditions to put in various needle input. So that is like catheterization, and sometimes infant feeding tube is also inserted so as to decompress the stomach and bladder so that adequate space is available for the insertion of various needle inputs.
ऊपर से इसको खिंचवाओ पहले ये फिर मोड़ उठाओ अच्छा
हाँ एक दो राउंड मारिएगा बस हो जाएगा
चलो बच्चे शुरू हो जाए
The next important step is going to be the position of the patient. And that will depend upon the site on which the surgery is to be performed.
बंद करा it's very hot here it's very hot here AC करने के बाद लेकिन
Can we have audio with OT2? OT2,
चलो बच्चों
audio with OT2, please.
pressures
Hello, audiovisual, please. OT2 audio. We need OT2 audio.
मैं वॉश कर देता हाँ जी
OT2. OT2 audio. OT2 audio. I take this. Okay. 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 You push it? Audio is ready in OT3. OT3. Dr. K.C. Sharma, I think you were not here. You were called to be the chairperson. Please do the honors, sir. And we have audio from OT3, Dr. Samun. OT3, Dr. Samun. Uh, can we have Dr. Anil Tharoor on the line? Good morning. Good morning, Dr. Anil Tharoor. I am Professor Mufti Mahmood. I'm head of the Department of Surgery here. I'm so glad you have accepted our invitation and you have made it on time. All of us are looking forward to a very interesting and thought-provoking surgical techniques that you are going to demonstrate. We'll contact with you shortly and the senior surgeon, Professor Sharma, to my right, and Dr. Kulsison, and we have Dr. Kit, who is senior consultant in surgery at Skills Medical College, and still Dr. Yassin has cases also from the meeting. I extend sir. I the linguistic issues and glad to see you doing a wonderful surgery. Sharma, please take over. Dr. K.C. Sharma, please take over. Hello.
Hello.
Am I audible, sir, from
Yes.
Dr. Samun, yours is OT3.
Okay, sir. Okay, sir.
Okay.
Share the clinical details of case which is being operated at OT3 right now. Am I available, sir?
Yes.
Yes. Yes, sir.
Am I available, sir?
Dr. Sharma,
Yes, sir.
आप interact कर लीजिए.
How am I? Let him.
He's asking you whether he's audible.
Yes, yes, you are audible.
Good morning, sir.
Yes. Morning.
Right now, you will operate on the case of too many Dr. Amit.
वो है ना नीचे में.
And sugar today,
Blood sugar.
blood sugar.
Sir, what is the modality for screening this small gut? Sir, you have used any modality for screening the small gut? Okay. Okay, sir.
And what is the HP of the patient?
Yeah, Professor, you should have been
Yeah, most of the times these right-sided growths, they present with anemia, pallor and anemia. And left-sided, they present with obstruction.
emergency हो जाएगी आप लोग आ जाइए
Thank you, Doctor.
Can we connect to OT1?
Hold on. Hello?
Hello? Hello, sir. Hello?
Hello?
Are you audible in OT1?
Yes, yes. I'm Dr.
Oh, sir, this is on the class here.
Sorry, I'm a... Hello?
Yes, sir. Are you audible, sir?
Yes, 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 I'm on.
Can you just can you just throw light upon the port placement and what all organtum you use for this pyeloplasty in pediatric patients?
So,
That is present करना.
OT1 is and
you have to say one, yeah.
once you
Can we have a on-screen display of the number of the OT1 or 2 or 3 and procedure being done? That will make us the audience very convenient to appreciate.
That's it. कोई बात नहीं सर तो देखिए श्योर है वो तो चीजें सर वो तो यूज करा कोई नेक्स्ट का स्तर में उसमें कुछ भी यूज करा दो सिस्टर वॉट एवर यू लाइक जो आप जो कंफर्टेबल यूज करा मुझे प्रेफर नहीं करता आई वांट टू दिस वॉट एवर कंफर्टेबल यूज जो सिस्टर क्लीन करा देते तो पेशेंट को हमने किया लेट्स स्टार्ट
It appears that in OT2, the pyeloplasty being done, the umbilical cord, that is telescope cord, has been worked.
hello OT2
Now the working ports are being placed.
hello yes sir you are audible.
सिस्टोस्कोपी कौन करता है
Sir, can you just throw light on the port placements? What port placements you prefer in pediatric patients for the and ratios you keep there?
So ideally, a pioneer would have been more than sufficient, but since the workshops we want a better visualization, better resolution, so we have opted for an amendment and we are using it in the street. And the other code I have put it in the which one I'm putting now is the epigastric one.
Okay.
Dr. Zafar, it appears that the gut appears to be distended, most likely because of the nitrous being given. Can you ask the anesthetist to please stop the nitrous so that access is easy?
I already requested them
Yeah.
for the name. Thank you. So I'm through with my epigastric code. Now, since the female giant can see the epigastric code is quite higher, so in future it will come under graph. And other code, what I have done is normally I take the midline just below the pubic area, so it comes under 20. So that part of this pain in the children in the child. But the infra with the pubic cord makes Pardon? Doing surgery and but for a lifelong no scar for a child is worth it. But since it's a workshop, we have to be quite and being the host, we have to be quite fast. So I'll just put a left pararectal in the pubic area so that will save us time also.
Yes. You prefer a linear approach, the linear placement of trocars.
You are ready to appreciate?
Yes, sir.
Yeah.
Yes, sir.
Yes, sir.
I have to try, but I planned the study there. So I'm coming through this area, getting a little bit of which maybe combination. I
Are you planning a transmesenteric or you will reflect the colon?
yeah, just let me just put
Okay.
focus in
Yeah, that will guide your placement of trocars.
Yeah, just let me switch my guidance.
So, till you put up the code, a simple query is there. So, you what kind of pre-op investigations you do in these pediatric patients? Just a radionuclide scan or some?
It means it's a combination of air pumps. It will be more than enough. And we don't do routinely MCU with 5% of patients with UJ have a reflux. Ultrasound showed no dilated reflux, not have breakthrough UTIs. So now I assess between us. ठीक है आपका लेफ्ट में क्या लिया आपने ओके ओके
But that is still what is standard, sir.
now see let us identify the anatomy first. Let me go to the pelvis please. You don't mind? Just a minute. So the forehead, when you do the pelvis, fine. So the bladder there. Yeah,
So are you using 5 instruments or 3 5
this is going up. Anything is protruding colon here. The feeling here, fine. Out. Down to you, still better.
This appears to be something distended.
This looks like a cortex of the
Skin.
fine.
Yeah, absolutely.
Cortex. So here I'm able to appreciate.
Vein vessels,
Now let's go after. One
transmesenteric or
goes major colon.
yeah.
That's the window of the shit. Yeah. The way just to reflect it.
Reflect the colon.
Did you recover?
It's already almost reflected, only a flimsy.
Yeah.
I think trans mesocolic is going to be little cumbersome. Better would be to reflect the whole colon. Already it is pushed down.
So to reflect the colon more medium, this is already reflected. That will save me a lot of time. I'll just go through it, reflect it. I'm able to appreciate this with the reality of pelvis. Yeah.
Which energy source are you going to use?
See, we have almost everything already had. Later, they have given me the sonogram from Fovidian.
Wonderful.
I think things are getting ready in OT1. Can you please connect to OT1? Hello?
OT1.
Hello, everyone. This is everyone.
Hello?
Hello.
Yeah, you are.
So, I'm going to join. So, how to start with should since I look much Understand very much is the same. She especially subjected sorry, no, sister, no. And we should stand as well. Suspicion for social alliances, special position of syndrome, that is something Virginia. She, so, one of the so, this person, shall we start? Okay, we just get getting on. Messaging surprising. So, my side was okay. See, I have seen the case. I think Chalmers has explained you the case. I don't think there was relation was classmate one. Oh, whatever. You would sit me links to this. वो करेंगे तुम बताओ autofocus and continuous focus. The continuous focus automatically focuses. You are decided. Saya tadi ni saya mana pula website with you. मैं ले आऊंगा मेरे को शायद वहां दिखा सिस्टम में खोलना और फिर हम में खोल दें मुझे वहां से दिखाना तब यूरोलॉजी इंस्टेंट होगा ना टीयर की सीट देखने का उसमें नीडे भी होगा सिस्टम वो निकाल लेना ये नीडे है ये नीडे है ना प्रिक करने के हाँ वो खोलेंगे वही खोलेंगे वही सिर्फ आ जाओ ये बता दो टीयर पे वो लगा लो ये निकालते ना वो लगाना पड़ेगा लो सिस्टम में दो उसमें फर्क उसमें क्या फर्क है उसमें क्या फर्क है बिकॉज हमारी ट्रेन बहुत लेट चल रही है सबसे पहले नहीं आया था इसमें डाल दूँ चलो यार मैं डाल देता हूँ उसमें क्या है कोई नीडल एक नीडल मेरे को पकड़ा दो बेटा ऐसे भी नहीं पूरे दूसरे लगा उससे कंटामिनेट हो जाएगा ये बात कल यूज कर लेना चल हाँ तो अनुमति सर अब picture to me. He's not able to see anything, no? Your screen is to me. इस तरफ कर दो व्हाट्सएप की तरफ कर दो करेक्ट परफेक्ट हाँ आई नो इनका आवाज आ रही है बच्चे वहां पे 12 5 मिनट हो रहा है आज फिर रात को यहीं पर रहना सबने जिस स्पीड से हम चल रहे हैं ना चल थैंक यू ये तो बोलो ये तो बहुत सब खोलो सिस्टम अच्छा होगा ना एक बहुत बहुत यार
लाइव स्ट्रीम हो रहा है लेकिन ऑडिटोरियम में स्क्रीन का मसला हो रहा है बाहर नीचे
कोई बात आप सिर्फ यूट्यूब कहते करना बंद खोल दीजिए स्ट्रेट एक स्कोप करे तब तक हम देख लेते हैं क्या फर्स्ट हैंड अप देन हैंड डाउन ना हैंड डाउन वापस आ जाओ बस बढ़िया जिंदगी को इतना बड़ा देखने की आदत नहीं है ऊपर से जाओ हैंड डाउन फिसला ऊपर ये है सब बिग फिसला इट्स मोर टुवर्ड्स द राइट साइड यहाँ पर ये 12 o'clock पे लगा बचे विंग से 12 o'clock है तो डिसोरिएंटेशन हो जाती है इट्स मोर ऑन द लेफ्ट साइड नो यार स्क्रीन सेव करो उसको व्हाट्सएप को पहले भी बोला उसने ये लेफ्ट वाला यूरोटिक ऑफिस ये है वो राइट है वो राइट है ऊपर दिखा दी चल थोड़ा बहुत डिस्टेंस है लेफ्ट वाला इस फार आउट सो इट्स मोर टुवर्ड्स द राइट साइड ओके चलो करो डालो के हाँ सो बिग फिश एक ग्लव सिस्टम मिलेगा मेरे को 6.5 no small surgeon need small glove 6.5 gloves only this looks endoscopically but there is hardly any distance for some distance from this to this बड़ा इसका छोटा लगता है so you know have place it will be close close आस लेके यहाँ तक
ये पूरी कंटिन्यू हाँ यूट्यूब
बस ठीक है चलो स्टार्ट बस ठीक है चलो एक ग्लव देना मैं पूरी करना 6.5 Because आप करेंगे? नहीं करो आप करो. You carry on with the things. ये तो तीनों ये तो डालो. शिक्षण आप वाले पे भी खोल देंगे. एक उसको भी तुम्हें काम करना है. एक बार फोटोग्राफ करना कि मैं कर रहा हूँ जो लोग हैं. If you are doing anything, you should comment. मतलब साथ. अच्छा. Okay. ठीक. इसकी समझ में अच्छा. सीधे बिना तो गंदा वाले में. एक सिल्क काट कर रखना है, एक को सिल्क लगाएंगे. ठीक है. छोटा सिल्क ले लो, रिव्यूल होती है ना. एकदम छोटा सिल्क ले लो. एक सिल्क सिलाई लो. तुमको जितना जाता जाने दो. Okay, fine. That is good. Good enough. So,
Space to
just hold it like this. Should be.
most likely this is the dilated pelvis and
Sure.
it is proximal extra.
Take it out the guard. Take out the guard. नहीं निकाल दो. थोड़ा सा निकाल दो. फिर flush कर दो. इसको छोड़ दो. Do not burn any more. Give me another one. Irritate the system.
Techniques being negotiated to created at the junction of the dilated pelvis and the urethra.
Irritate the system. नहीं इसको काटना पड़ेगा. सिस्टर गंदा प्लास्टिक.
And on the right of the middle
So can you show them? Can our theater be on?
They actually feels like it's
और अंदर. This is the way.
Yes,
sir.
तो बोलो यहाँ पे एडिट कर देंगे so that we can just show them the session when we can go. Just hold this one. छोड़ दो.
Yes, sir.
Let's see this. इसको एक सिल्क टाई बांधेंगे. हल्की से. बस तो no, this is the left side. Just this is left side. हम आके because both are same, no? So we don't know which is which one. बाद में जब निकालना है क्या करना है. That's all again. That's it. This is my. छोड़ दो बेटा. Now give me a guide rope. वो भी है ना.
Yes, sir, it's visible.
Yes, sir, it's visible.
उसको एक लेटर स्वागत करो. लेकिन तब आप क्वेश्चन हो. Order one. So we would be considering so we'll show them the fishing.
You can go ahead.
I will have a look at the fish leg and the damage. First we'll show them the fish leg that's all.
OT2.
This is order one now.
Hello.
Just tell them that just put some
OT2.
right on. One visit. See, it was going. That was going back. It was or road. फोर्सेप्स का सिस्टम हमारे को फोर्सेप्स चाहिए होगा. हाँ नहीं इसका बिगेस्ट वाला फोर्सेप्स. बिकॉज स्मॉल फोर्सेप्स. हाँ ये इसको पकड़ लेंगे. पकड़ लो तीनों पकड़ लो. एक बार वाले से रखो.
Dr. Zafar. Hello.
Hello. Hello, are we connected to OT2?
Forceps. हाँ साइड से लगा दो कोई इशू नहीं चलेगा
I think we are connected to
ऐसा होगा तब भी चलेगा कोई प्रॉब्लम नहीं this is all forceps because this is not a visible vagina fistula, this is a visible uterine fistula. So once you put something into this walks up into the uterus. So it's not going to come down.
OT2? Yes, but no response. Are we connected to
This is
OT2?
lap forceps or easy forceps?
Hello, sir.
Yeah, sure.
Fantastic.
Sir, you have started the case? Yes, sir. Yes. Sir, yes, sir, you are audible. Sir, could you please
Push the bed there.
sir?
चल हमारी सिस्टर कहाँ गई चलिए सिस्टर आदमी दिखते हैं तो मैं परेशान हो जाता हूँ तो ऐसे रखिएगा 1 मिनट से छोड़ दो बेटा सिस्टर सिल्क दे दीजिए प्लीज मेरे को इसको खींच के रखना पड़ेगा तेरे को क्रिकेट फोल्ड दिस इज रेडी
Sir, can we see the external view of the patient position and port position?
give me a silk
one palm and try करेंगे.
silk and a catheter उस पर संभाल लीजिए
Sir, we can see.
सिल्क मेरे को दे दीजिए आप गाइड संभाल लीजिए सिस्टम if they want to come here I just want to show them this thing then they can start सिर्फ 2 मिनट लिए हमारे पास आ जाएंगे और फेलिस ये अपना फेलिस कहते हैं रेडी रखो
So that is your personal choice. Okay, sir, the port placement just for the students.
16 18 whatever you want no issues इतनी डाल डालेंगे एंड में डालने के पहले 16 दे दो हाँ अभी सिंपल मत खोलो ठीक है 16 सिंपल वाला खोलो हम निकाल देंगे वैसे हाँ ठीक है वो नहीं चलता है वो रैप्सन का है कोई भी अरे कोई भी 16 में क्या दे दूंगा ये तो मसला है सबसे रिमोट में भाग लेना एक ना स्ट्रॉन्ग पुलिस फोर्स रख लेना ठीक है पहले ये वाला बैग दे दो बाद में नहीं हाँ अभी नहीं बाद में लेना बाद में नहीं तो सब फाइनल हमारे को चाहिए को दिखाना है इनको उनको बुला 1 मिनट तक दिखा दो हमारे को फिर हम स्टार्ट करें यार सिर्फ एक फिशर दिखाना है मैंने दिखाएंगे क्या ठीक है आप
There's
और okay
on the surface of the lips, it appears to be a little irregular nodularity is there. No.
so go on
okay. Maybe it's a cirrhosis.
फिर उसको देखना बस now you open up next
Yes, take me turn in this patient.
are we on for the OT1 are we on for the OT1 कब चला चल
Okay.
just for 2 minutes we can now go
Okay.
I have to attend this.
We want to have an overview of the case here.
Motivators and you are in such
just sorry for the interruption something goes wrong we can't control that so this is a cystoscopic view and we put in fistula this fistula this is not a vesical fistula so we must in forceps to put it outside so there's a protocol so this is already pre-standard sort of the stuff I was so since the captors. So it's only for 2 minutes. And if you see the extended view, I don't know if you're able to see, this is part of the fistula.
No, no, say the external view, sir.
So can you see this external? Show this external view. So this is the we have tied it.
Can you zoom it, please?
So we have tied the fistula part with the silk knot so that we can know what is happening. And this can be turned into to show what the fistula is exactly. And we have the captains and the right side connected with the silk and the right side. And all are seen, so nothing so we take the position of the person and you explain the position after time you can go to the
Okay.
question most welcome.
Yeah, sir, a simple query, sir. This is Yasir, sir, your student. So, do you use same number of ureteric catheter on both sides or you use different size?
No, see what I'm saying. So we can simple feeding good also. So you can see this is most valid entire it's not suturing when you use especially when the goes close to the baby orifices. So you can do any of the pumps. You can use size, size, so you must keep the silk knot and not to move its which is good. If you with the grace of God, we can remove the end of the procedure. I'll take you along with the issue.
So, just one thing, they said it's a vesical uterine fistula, na? But in the history they mentioned that the patient was incontinent, not continent.
She was a psychic injury also, and
Bacteria, but not she is incontinent. So, exact location of the opening.
it is just about if I can see once I can cross the cervix. And it's just about the hospital. And when the diabetes was coming in, I cannot take the fistula. So this once we put the diabetes, it went into the uterine cavity. So I did the hysteroscopy also to see where the ureteric catheter is and the stent forceps.
Okay, sir.
So let's see what comes up later. We'll see for how to see.
Catch you shortly, sir. Till then, we are in OT3. Can
Okay.
we connect this OT3?
God bless you. Sister, phone there is something with you. बता वापस उनको दे दो. We will start.
Yellow, blue.
Sister, वो बात दे दीजिए. लाइट सोर्स ऑफ करना पड़ेगा. थोड़ी देर के ऑफ कर लो. कैमरा पकड़ लो. Make some space so that we can start the things now. See, the amount of urine in the bladder shows that she is not vesical vaginal fistula.
That is usually preferred. And
एक चाहिए होगा हमने को.
and for the sake of the students, I would like to
आप इसको इसको ऊपर आप इसको ऐसे उठे दिन निकल से
type
बात
of fistula and very famous syndrome in it, which is UROSURG syndrome. Cyclic hematuria, we call it amniotic. Patient is continent, not incontinent. That is classical of this vesical uterine.
थोड़ा पीछे लेना पड़ेगा हमको. पूरा फोन बजना शुरू हो गया. बोल बजी बोल सो. यहाँ पे बुला लें आप इसकी पोजीशन बनानी. 14 उसको अच्छा रहेगा क्योंकि हाँ असिस्टेंट के पास उनके पास यूज होना है.
Go to OT.
आप उसके बाद क्या चाहिए? उसके बाद इसको पेशेंट पोजीशन बनाना है हमने. नॉर्मल थोड़ा सा उसको नीचे करना. मैं बताता हूँ आपको. आप कर लेते हैं. आपको करूँगा. समझता आपकी जिंदगी में सिर्फ नहीं हो सकता नहीं है ना. चलो. Somebody will have to hold the legs. अब लड़की इतनी है वो पकड़ नहीं पाएगी. So आप ऐसे रहिएगा. So we'll just adjust according to that. Yes. बस 3 बेहतरीन.
OT
बस. आप इस तरफ आ जाइए. पहले मेरी तरफ आ जाइए. आप लेग पकड़ा ना आपने. इसको खोल दीजिए. निकालना पड़ेगा. लेग निकाल के आपको पकड़ना पड़ेगा. ये बात है ना. पहले तो इन घूम के just for 4 minutes. That's all.
What are you planning at science?
Once again, repeat from that side.
First class. You are the best.
Yes.
Sister, map down. So can we destroy this? First map down.
It's redundant kind of pelvis. Are you planning a reduction?
अब आप इसको उसके ऊपर रख सकते हैं. एक आप इसको ऐसे सामने रख देते हैं. जो स्टेराइल है सारा.
So, just for the sake of discussion, what's your expectation?
पता नीचे लगा वो 5 मिनट. तो नीचे इसको नीचे रखो. ये ऐसे नहीं होना चाहिए. ये जैसे गया ना नीचे. जैसे ये हाँ बस ठीक है बराबर है. ठीक है कोई दिक्कत नहीं. जितना होगा. हाँ से कितना
So you hook the pelvis every time, sir? So you
इसको कर दो थोड़ा टेबल डाउन करना
Table down, please. Table pull down.
फिर डाउन कर आप तेरे पे टेबल डाउन डाउन फुल डाउन फुल हाँ लो
Head low. Head low.
कुछ ऑलमोस्ट टच द ग्राउंड बस अभी 2 मिनट पहले पेड़ डाल लेता हूँ इसके बाद पेड़ नहीं करना पड़ेगा मैं आपको क्वेश्चन लेट्स स्टार्ट करो बिस्मिल्लाह करो तो करो प्लीज सिस्टर एक वजाना पैक करने में सॉरी मैंने किया नहीं ये डाल दो इसको पूरा पूरा पैक कर दो ऐसे पूरा इसको बना दो ना बॉल बना के देखो बॉल ऑन इट एंड पैक इट बस इसको ग्लव चेंज करना है उसको विदाउट डिस्टर्बिंग दिस थिंग आप फिर ग्लव चेंज कर लीजिएगा आप खुद भी कर लीजिए पैक स्क्रब करेंगे
You will not be able to mask.
मास्क ऊपर नहीं है जब ये पहनेंगे फिर मास्क नहीं पहनेगा फिर
Clear or audible? Yes, sir.
लाइन कहाँ है अंदर
Picture.
बाहर कहाँ वहाँ
नहीं बाहर बाहर बाहर.
उधर
Please come.
अच्छा यहाँ पर रखें बहुत गंदे जाने वाले हमारे को हॉस्पिटल सप्लाई नहीं हुई है ना ये है हाँ हाँ नहीं नहीं हाँ कल शाम को आ जाता हूँ टाइम है ना इधर हाँ तो इधर मैंने देखा नहीं सेकेंड में तीसरा ये कोई गिर नहीं गया यहाँ पे हाँ उसको ड्राई करवा लो कोई गिर जाएगा यहाँ पे शिक्षा हाथ का ग्लव दे दो मेरे को एक ड्राइंग आप देना सिस्टर प्लीज दो सभी के टेबल स्ट्रेट कर दीजिएगा when I'm putting my this thing ना टेबल स्ट्रेट हाँ
Focus.
करो 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 हार्मोनी प्ले करा दो यार वो हमारा ज्यादा दोस्त है क्या मैं फैन बहुत सुनता हाँ आप मुझे सामने बोलिए सिस्टर ये तो 20 किलो नहीं बस
So we can easily appreciate its time.
आप ये बोलते हो अच्छा CO2 सबसे पहले CO2 सबसे पहले CO2 बेटा और गर्म पानी मंगा के रखें कितने परसेंट वो कुछ करके लेना
Camera lens you dip over that please for us.
पहले सबसे पहले ये लेना है this is going to just look into us एक बस टीम में कौन है हमारे पास
Yes, sir.
आप ये this is going to be very थोड़ा पीछे करना पड़ेगा दोस्त इसको And very
पीछे पीछे पीछे
हाँ क्यों नहीं करेंगे हम वीडियो कॉल से क्वार्टर में कैसे काम चलेगा हम ये करें कि क्वार्टर सिस्टम माइक्रो लगा लीजिएगा माइक्रो प्रोसेस है ना अपने पास
Sir, you are on.
सीओ हाँ डन चलो वो अच्छा है
पीछे पीछे
सीओ किसने लगाना है बस ठीक है दो मिनट बाद बैठते फिर देखते हैं ह्यूज इट्स नॉट गुड
Start will.
ये फर्क है मुझे बड़ा not used to this thing but they said that in workshops they should not be doing something not appropriate right
मैं एक काम के साथ क्यों करेंगे
सेपरेटर ऑन करो हो गया एक मिनट
सबर इस हाँ ये पोर्ट खोलना है यार ये पोर्ट बेटर है एक्सेल लगा
एक्सेल को
स्टार्ट नहीं हुआ है ऑन कर दीजिए फैंटास्टिक फ्लो रेट सिस्टर कितना रखना है फ्लो रेट थोड़ा 7 या 10 पे रख दीजिए फ्लो रेट माइनस में है प्लस तो नहीं
पेंटिंग
नहीं बड़ी नहीं कम कर दीजिए फिर कम कर दीजिए बस दैट्स ऑल थैंक यू सीबल ऑन सजेस्ट सीबल ना बस कुछ मत करो बता दूंगा कीजिए करो जो करना पड़ेगा ये बता हाँ चला सकते हो रिकॉर्डिंग मुझे कोई प्रॉब्लम नहीं है इसको सिर्फ ऐसा रखना जस्ट फिंगर डाउन दोनों मेरा बस जस्ट कीप इट मैंने पॉइंट खोलना है वो अंदर बाहर हो जाता है फर्स्ट पोर्ट छोटा बोलना हाँ
यही नाम है सेम
सेम उसका फ्लो राइट साइड
11 mm और एक
क्या ओपन कर दिया हाँ फैंटास्टिक है नो इश्यूज उसे सेक्शन रेडी करा दीजिए सेक्शन चेक करा लीजिए सेक्शन नंबर हमारे पीछे रहते थे लेकिन आप लोगों ने नाम सुना कि नहीं नजीर खान साहब वेरी गुड सर सेक्शन सर पूरी सर्जरी सिस्टर सबसे इम्पोर्टेंट पॉइंट ये होता है ये गया इसमें मसला हुआ then you start getting this thing balance rate कर दो ये इंसर्ट होते हैं इसको फोन करना चलो पकड़ो इसका प्रेशर क्यों नहीं बढ़ रहा पीछे आ रहा है सबसे 10 पे है इसको प्रेशर कितना पे सेट है 15 so that is not increasing CO2 इसमें इसी पे सेट है तब से क्यों
नोट
वो तो बात नहीं है CO2 खुला हुआ है
You have found nodes intraoperatively. Are you going to change your procedure from lead 2 to lead 3 based on the effective visibility of the
रोशन जी
कुछ मसला है यहाँ पे
हाँ
CO2 नहीं आ रहा है. CO2 is not working. ये नहीं हैंग हो गए. हो जाता है हैंग स्टोर्स में. वो होता है स्टोर होता है. चल नहीं रहा है. अच्छा.
Light source on. Light source.
Protein process बराबर. Absolutely comfortable. चलो जी. करें इसको बारे में डिस्कस करें. आपके ऊपर जाना पड़ेगा तो ये दोनों दिन. As soon as possible. Only then we'll be able to do the surgery. That's all. Protest? फिर क्या हाँ पक्का बोलना पड़ेगा ना उसका बिना कैसे रहेगा ये फोकस नहीं है.
Can you please connect us to OT1?
इसको बंद ले लो बंद ले लो.
Please.
I'm on. I'm on. Hello. Hello. Can somebody on the yes, we just want to show the position of this one.
Hello, sir.
Hi.
Sir. Sir, after now,
Now, can you show the surface? Sister,
just throw some light on the port position and the patient position, sir.
So, this is the third position I use. We need to access towards the vagina, sometimes better. And we have position, and you can see that. This is the head, and this is the fitting of the patient. The first port is just above the umbilicus.
Okay,
The remaining ports I never predetermine depending on the patient habitus. But the person is and secondly, in what atmosphere I'm working, what's more and this atmosphere and my knees being served to it's in a good position when you have to stand on the table and stuff like that. Training the suture should be suture. So if you're able to suture nicely, then things go very comfortably. So you don't have to points to be so I'm still to reports. When we have
Can you zoom in, sir?
oh, can you show in the scene side? This is a new this photo camera. I think they are coming in competition with Vina from stores. So we can see the things very nicely. The big looks so good first time. And luckily with the grace of God, we don't have much of that business there. So let's see how the things will go. I'm just going to start to put the books now. Okay, let me start. I'm going to start 11 mm port first.
5 mm, carry 2.
Rather 3.
5 mm,
On the audience, I think on the screen of table OT took the ileocolic vessel vein has been claimed and now artery, ileocolic artery is
By this. जोर वाला आदमी नहीं हूँ कोई मेरे को चलो तो मसल भी नहीं है फिर क्यों जोर करना है चलो स्टेज में को ग्लास पे दे दीजिए बाल ग्लास पे दे दीजिए उस वन बाल ग्लास पे ठीक है ये लुक कर रहा है यार पोट It's not good for this week. So I'm asking after what you know, you will learn and the wash will week. You know, when for Excel learning, 12 and Excel learning, 5 and learning, you will put some, don't worry. आप सबसे प्लीज इसको थोड़ा सा सीधे से काटो so that we can see this thing moving in front of us. आप मेरे पास आ जाओ आप एक आदमी स्टेप होना पड़ेगा यार इस सब के लिए what a scene doing the and not a sister, surgeon to strong. Sister आप आ जाइए आप सामने आ जाइए see I can host you आप एक काम करो sister
43.
आप वो increase
That is
आप
the
आ जाइए इस बच्चे को ध्यान
so as to make it compatible for the anastomosis.
आप सिर्फ खड़े होना और work so this is the फोकस क्यों ऐसा होता था बीच में यार? चलो ठीक है, अगर मैं जब बोलूंगा तब करेंगे आप, ठीक है? तो एक छोटे वीडियो में आ जाओ। तो दिखा दीजिए मेरे को। या परफेक्ट। ये भैया आप क्या करेंगे इसको, जस्ट पेपर पिंडो पे जाएंगे। सो तो मैं बोलूंगा तो इसको सिर्फ ऐसा पुश करेंगे आप, बस 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 ऐसा ऐसा दैट्स ऑल। वो होता रहेगा, यू कैन स्टैंड राइट, स्टैंड लाइक दिस, आई बी वेरी, थोड़ा पेशेंट मेरी तरफ आ सकता है कैसा? कैन जस्ट पुश द पेशेंट टुवर्ड्स मी, थोड़ा सा करेंगे, पूरा पकड़ लीजिएगा, पेशेंट आपकी तरफ है थोड़ा सा, बस थैंक यू थैंक यू थैंक यू। आप बाहर आ गए, पूरा फोकस बार बार क्यों आउट ऑफ फोकस हुआ था?
कंटिन्यूस ऑटो
कुछ स्टेलिंग शब्द है, क्या हो रहा है बताएं? इसको बस आप इसको इसे बैठे हो ना, बस छोड़ दीजिए, आप इसको आप पे बदलने बढ़ाएंगे हम, बस हेलो लाइक सिस्टर इन 5 मिनट सर, मेहमान सर सामने कनेक्टिंग हो गई, नंबर ऑन इन yes, so we can hear you. So we wanted to know about your experience with seeing the vessels, what are energy sources and frequencies. Yes. Yes, sir. It's just a night vision. Super green. कश्मीर में बना है, सही जरूर बना आपको छोड़ दो, दिस इज योर नाउ, दिस इज योर, ओके सेक्शन डॉक्टर फाइव सेक्शन वहां से आई फाइव सॉरी just very short this thing है, ज्यादा करेंगे ना, so if you do more the things will collapse, ठीक है? सेक्शन लगा दो है, ये रखें, ये भी दिखनी है अंदर रखो, बदल वापस, बस ये भी दिखनी है, बस शॉर्ट ऑफ मी आपके पास है, बोलो तो कोई पानी वाला दे दें इसको, डॉक्टर साहब को ये लगा लीजिए, just hormone brother, start वहां करके कर लो, कंफर्टेबल, चलो आपको ये थोड़ा सा बैंड रखे हो, क्या बात है, बैंड रखे हो तो लाउड सीधे नहीं हो तो कोई बात नहीं, क्या कंफर्टेबल सिस्टर एक सीधे दे देंगे प्लीज, चेक हो जाएगी, लोग वाले बर्तन वाले तो सोर्स वाले ठीक है, इससे कैसे हो रहा है, थोड़ा सा सडनली, चले ठीक है, चलो जी, तो ऊपर वाले का नाम है, करो से स्टार्ट करें, हाँ आपका हाथ थक जाएगा, आप मेरे साथ में खड़े हो, आपको उधर खड़ा होना पड़ेगा, चलो लेट्स स्टार्ट। Yes, sir. So we just want to start things. If somebody wants to see the some competition, this is the class. Once somebody is down somewhere, and yeah, and we can You can see that when I told moving, so this guy is where the question will. So I took a simple pack. Sir, we can hear you. Can you hear us? Good morning, sir. Good morning. We can't hear him properly. We can't hear him properly. एक बात सबको. I think he is able to hear us. We are not able to hear him.
Okay, so welcome you to plan.
Thank you, sir.
Please, please tell us whatever you want. Try our best to see that everything is up to your standard.
Valley is my home, sir.
Demonstrate.
Thank you, sir.
Over to your person.
43, please.
Tell me.
So you have an option to open the bladder either with the scissors or with this thing. So if you are confused whether this is bladder or not, so how do you be sure? ये पकड़ो. We'll fill it up with the.
Are you audible, sir?
Yeah.
Yeah.
We
Sir,
have
can you just
in our
throw light
control.
on your suturing technique? Yeah.
Sister, एक और वो दो.
You always go through the bottom of the spatulation, or you keep some 2-3
Something to
millimeters
fill.
away from the spatulation corners?
Dipshit दे दो.
No,
Dipshit दे दो. Can we have a drip set?
It is your preference, or you go?
it's the margin of error.
इसको लगा लीजिएगा. Then we'll fill it up. We'll see the bladder.
That is.
तब तक I just want to take this down.
So I'm just putting those
Sir,
two off.
I just wanted to make a highlight here is that there are some surgeons like who prefer to go 2 to 3 mm away from the corner of the spatulation, so that the spatulated end remains quite wide open.
Okay. So this is the
Posterior,
of the finger.
we can appreciate it.
And this is the posterior of spatulated value. So the and
Suction right. आरिफ साहब आप नाराज हो जाएंगे तो हम कुछ नहीं देख पाएंगे.
like this.
Okay.
This will be the final picture. And this is have the next time.
One more usually about fistula is that rather
So, what are small steps you take to avoid trauma to the ureteric mucosa, like your handling technique and all?
Yeah, we try to keep ourselves busy holding this area. Not to hold the baby.
सिस्टर इधर इसको प्लीज करेंगे इसको.
This one.
बस thank you.
Which one? Like I mentioned.
Should we fill the bladder to see where the bladder is? खुल भी जाएगा तो कोई problem नहीं है.
You performed the reduction. Was there any necessity of doing reduction in this?
See, there is this vessel going in and twist it on the
I can go here, but this is not required. This one what I'm doing is not required.
Yeah, you go on.
It's not required, should not be done. Because it doesn't make any difference. So my fistula is somewhere here.
So you're proceeding with the classical one.
हाय बेचारी मर जाएगी क्या होगा इसको. इसको पकड़ा यार. नहीं ये चलेगा नहीं. This is not good drip set. ये गवर्नमेंट का है ना. ये गवर्नमेंट वाला good drip set. ये मत चलेगा. ये चलेगा नहीं बेटा. This will not help. चल रहा है. करो जरा. ये लिख नहीं वो वहाँ चल रहा है यहाँ से फिर निकलता है.
Interrupted.
ये कभी नहीं चलेगा.
Continuous.
Also continue.
Yeah.
Both sides have been continuous switches on.
Yeah.
Let's say
This is the bladder. See, this is the bladder. नहीं ब्लीडिंग तो कोई नहीं यार. This is 4K. ये open में दिखता भी नहीं. So sometimes you are chasing the bleeding, so you should not chase the bleeding here in these cases, in these cameras. So if you look there, it will be different, and if you look there, उधर देखो, it will be different. Very good, fantastic. What you have done is excellent. Excellent. See, I always believe your assistant and cameraman can make you look like a hero and look like a fool. Good. बेहतरीन. So this is again. So what I'm doing is I'm trying to constrict that. This is the bladder. Now it is filling now. Can you see the filled bladder? So this is bulging bladder. So
I take this opportunity to welcome HOD Anesthesia Professor Ruxana ma'am to the auditorium.
भाई एनेस्थेटिस्ट के बिना कुछ भी पॉसिबल नहीं है जिंदगी में. सक्शन थोड़ा सा मेरे पास रहेंगे आप प्लीज. एक बार मैं खोल लूंगा ना इसको ब्लैडर को. ये ब्लैडर आ गया ना सारा देखा. Can you see the bladder? So we can open here also, but the only thing is if you are closer to the fistula, थोड़ी सी स्टॉट में कम होती है, जल्दी खत्म होता है, बंद जल्दी होता है और कुछ और कोई नहीं है. Fantastic. This boy is doing a great job. What you can do for me is, Arif sir, you can just keep it pressed here and do the suction also. That will suffice my both the things.
Can we switch over to OT1?
Yeah. If you are with us, let us know.
Audio visual team, kindly switch over to OT1.
The suction here. Yeah. So, can you see that this is the uterus? This is the bladder. We have filled up the bladder. Now the bladder is getting filled up. And there are adhesions of the bladder to the uterus, which is expected. And I expect fistula somewhere to be here. So let's see whether when the fistula comes. So we have two options. Either is we can open up the bladder and then go to the fistula. Or we are very close to the things and then we open up where it is exactly.
So you will use this harmonic scalpel energy source for separating.
Any energy source is good. We are all same.
Any experience about using this flow of water, irrigation water?
Not at all, not at all. I don't think it is quite available in a lot of the systems in India. I don't know if it is available somewhere. The static surgeons do use that, but for a urologist, we are not that privileged. And I believe whatever energy source you have, even if you don't have a harmonic, it's not deterrent not to do a surgery. So
when do you take a decision of opening the bladder while you are?
it will open up. Don't worry. If I am able to see these are the adhesions. I can see them very nicely.
Yes, sir.
So I have done a scopy and I think fistula should be somewhere here.
Appears to be.
So we're just progressing slowly to see where it is. And if I have any difficulty, then I open up here. No issues.
You will go all around the fistula or you will in the mid try to open it?
Yusuf syndrome, it is not important to go all around the fistula.
Okay.
No, that's all. Thank you. That's all. That's all. Thank you. Yeah. उसको clamp कर दीजिएगा सिस्टर उसको बंद रखिएगा. So I'll open up the bladder now here. Let's see where the fistula suction. Oh, but now I'm safe. I have the fellow. I welcome Dr. Atri sir here. He is our senior. He has been my registrar when I was a postgraduate. He is a fantastic laparoscopic surgeon, a true inspiration for all of us. So now I'm safe. I'm safe hands now. If I get stuck somewhere, sir is there to rescue me.
Doing wonderful job. Crystal clear dissection, beautiful.
These are bladder vessels.
So what all precautions you take to maintain the pneumoperitoneum now you are going to open the bladder?
No, we just use, we have already packed the vagina, the gauze piece, the betadine soaked gauze piece, and we just keep a pressure with a, what do you call this, as a sponge holder. That's all. I can see the bladder mucosa now nicely. So, and from above, the catheter which is placed, either I'll remove the catheter or you can just clamp the catheter with the Kelly's. That's all. So now I have opened up the bladder. You can see the fluid coming out. You can see the ureteric catheter there, the fistula there. Can you see the fistula?
Quite visible.
Okay. So now what this does is this makes me comfortable. The suction goes there. Countertraction. Suction goes there for the countertraction so that I can see and everybody sees. So now we clamp this thing. We have already clamped this thing, no? So good. That's good. That's good. That's good. That's... Yeah. You'll have to lift this up. If you are having difficulty, then I'll open this up. So there is a fistula. It's a big fistula. So we'll.
So you're planning to lay open the bladder till the fistula?
Yeah. We can open up here also. If we have difficulty, we can open up the bladder. Doing a cystotomy is never an issue. And I believe you should not feel cramped or space in any point of time in the
Yes, very true. Very true.
in reconstructive surgery. This is the first chance is the best chance.
Yeah.
So there is no issue about that. The space should be good. The visibility should be good. There is no doubt about that. The problem with the uterus inside is that, to find a plane, there are dense adhesions, the uterus is there. So things are not that comparatively that easy. I would not say that the VVF is easy, but comparatively there is nothing here. So this is all bladder and the vaginal space.
So to err on the side, you prefer to cut the blood rather than cut the uterus.
We have to find a fine balance. I can't say that because if you don't have a good flap of the bladder we are closing, then there is a high probability of recurrence.
Recurrence.
So the problem is that the bladder at the level of cervix and things like that is quite adherent. It's not that supple, and the finding a plane sometimes is difficult. Sister, we have a scissors. We'll start the scissor dissection now.
With the permission of the chairperson,
Sir, please.
I want to Professor Vidwana ma'am, who is our head of department of gynae ops, and one of the wonderful teaching that we led my very friend, my classmate, my colleague for so many years. Dr. Ajaz Rathur, who heads the Department of General and Medical Excel Surgery, State Medical College. Welcome up to all of you.
Welcome, sir. Welcome, ma'am.
Rahul sir.
Yeah.
Yeah. What's your sort of experience in dealing these VVFs and in which ureteric orifice was quite close to the fistula and you had to do simultaneous implants?
I have done just in 2 cases. I have not done much like that. God has been very kind on me on that front. Usually what happens is when you do a cystoscopy and you find it is very close to this, you be prepared to do a fistula, the closure, and you take a flap of the bladder. You do like a body, short body. You implant the ureter there, and then you can close the bladder nicely. The only thing is that you have to mobilize the bladder very aggressively in that cases. So once I did a fistula with a bilateral ureteric injuries. So that was the case in which we did we could get implant. I hope in some workshop if I present that case, so I'll just show you what we did in that case.
Any experience of augmentation being done because of large fistulas or cicatrization?
No, I don't have that. God, this I tell you, the bladder, even if it is having a fistula for many years, still you can find a good plane and you can do good job.
So in literature, is there any such incidences where
Yeah, why not? You can have the fistulas where you require augmentation. I have experience in that.
So there are bad obstructive fistulas. There's an indication, and we have done some augmentations. Cystoplasties.
Augmentation cystoplasty laparoscopically, yes, I've done. For this thing that geocox, but for fistula, I have not done. Right.
Can we switch over to OT3? Hello.
Yeah, right.
So you're almost completed the posterior layers?
Yeah. A few more pictures and then I'll put my send guy. We'll come back to some of the
So you're using micro 4O?
Yeah. So
No.
What's the size of the stent you'll put?
4.5 by 18 centimeters.
Thank you, sir. Thank you. No, please, sir. Please. Thank you.
So does it depend on the degree of dilatation or?
is it always necessary to put a stent pyroplastic periodic properly?
आप एक काम करो. You come on this side. I put any.
I have an announcement.
Let's just stand. I'll just close
Putting in a
it.
stent.
5 minutes.
The session stands closed here. This session 1 stands closed. I request the yeah.
We have all this now. I could your medicine, Dr. Rakesh.
ये दिवस आ गए. This is the vaginal word. So let's going into the. You have to go into the bladder and take it out. आप बच्चे रिटायर करेंगे अगर आप रिटायर नहीं आपका मेरे साथ लगे झगड़ा हो रहा है कि क्या नहीं सिस्टर
Welcome, sir.
इसको ऐसा रखो यार
I request Professor Ajaz sir and Professor Rizwana to felicitate our chairperson.
बच्चा था ना ये आप इधर आ जाओ you can come here
Ajaz sir.
आप फ्री रहिए
Professor Ajaz sir, Professor Rizwana ma'am. Please come onto the stage.
foliage निकाल देते हैं take out this foliage we'll use it afterwards
Ajaz sir,
deflate
please come onto the stage. We have to felicitate the chairpersons. Stage, please. First to come is Dr. K.C. Sharma. I want to put it on record that K.C. Sharma was the first person to come out to this auditorium today. Claps for him, please.
मेरे को दीजिएगा नहीं फिर वो ये निकाल लीजिए ये ट्रॉली पे ले जाइए बाद में डालेंगे गर्मी है यार पसीना बहुत आ रहा है
Dr. Kulwant Singh Bahu.
तो एसी चल सकता है चला यार थोड़ी देर के लिए एनेस्थेटिक से पूछ लो सिस्टर नाइफ एंड पोर्ट 5 mm का इसके पास है ना पोर्ट यार 5 mm का पोर्ट देना एक तुम क्या कंजूसी कर रहे हैं सिस्टर नाइफ चेंज कर लेना
Dr. Saeed Kiptia Khurshid.
नहीं तब तक हम अपना काम करेंगे विल नॉट स्टॉप आउट थोड़ा हल्का सा सक्शन कर लेंगे आप बिकॉज इसको ये बच्ची यहाँ रखेगी ना तभी मैं कर पाऊंगा इस पिछला गया तो क्लोज है आप हाँ आप ऐसे रखेंगे
Dr. Yasir.
ना इसका ये इम्पोर्टेंट है ये आप रखना इसको पुल करके रखेंगे हल्का सा बस आप चले जाए ऊपर भी इस बच्चे ने पुल किया है ना बस दैट्स ऑल गुड खोला चलो आ जाओ फिर ये सिस्टर ये ना देखो ये बाहर चला जाता है सीधा दिस इज गोन आउट ये जो का ना ये फिक्स नहीं है प्रॉपर्ली लॉक नहीं है सिस्टर ये
Thank
lock
you,
नहीं है।
chairpersons. For the second session,
I want to congratulate the whole team, anesthetists, surgeons, and the assistants all. Those done wonderful work and live demonstration, wonderfully, very well presented.
नहीं, ये
And now will be
अभी भी
again. I thank you because I'm a rural surgeon, and rural service.
Yeah.
See these things very rarely these days. So again, I
ये अच्छा नहीं है
congratulate the whole
चाहिए
team.
मेरे को।
Thank you very much.
ये अच्छा नहीं है ये मत दे दो इसको हैंडल में कोई दे दो
for the next session, I would like to call the chairperson,
ऐसे दे दो ये दे दो
Professor Ajad Rathar sir,
नहीं यही दे दो मेरे को ये मेरे
Sir,
को
please.
कंफर्टेबल विद दिस वन
with the chair.
लेकिन इसका वो हैंडल चेंज कर लो पीछे वाला
Professor Rukhsana Najib,
ये ठीक नहीं
and
है
please to the chair.
उसको बुला जरा ये स्टोर्स वाले को
Professor Ridwana ma'am,
लूज नहीं है।
Dr. Javed. Dr. Javed Qadri, please take the
ये
chair.
ये बेटा मैं आपको
Thank you. Thank you all.
You are going to-
Professor Ojesha would be shortly joining this session as a chairperson. So we are giving all this.
Can you see that? So you'll have to keep this down. या इसको बंद करके रखें. Just keep it closed. Just keep it down like this. ठीक है? करेंगे? छोड़ दूं मैं? चल मैं leave it. Because until you take it down close to me, I'll not be able to work and do the things.
Thank you for inviting us as chairpersons. It's an honor to be here at the place which has been my alma mater and where I have been trained, and along with my colleagues, Professor Rizwana and Professor Rukhsana, and Dr. Javed, my student and a good friend. So
Fantastic.
I pass on to Dr. Rizwana.
Assalamu alaikum. At the outset, I would like to congratulate the Department of Surgery for having such an excellent and wonderful conference. I think it's very good that they are having these conferences every year, and it helps in propagating knowledge and learning new methods. And at the same time, it is also a change from the routine. It is always welcome in
ये
our
आप सेक्शन करोगे ना?
this departments.
जैसे can't see ये वाला तो हो गया है सेक्शन आप अंदर आ जाओ जरा ये चीज नहीं उठी है अभी तक
Let me congratulate the Department of General Surgery who's doing an
Yes, yes,
excellent
yes.
job. There is no doubt about that they are doing advanced surgeries. It's not today, it is always. And what they are doing normally, they are reflecting that today. We have been witnessing a lot of, since last 10 years, advancement in advanced laparosurgeries. Like they are doing bariatric surgeries on a routine basis. We have 2 bariatrics per day. Initially, it was a dream come true for us. And then they have searched new methods of like making the redundant stomach there. They're not removing the stomach now, they are making it part of it redundant. So they are really doing advanced surgeries, advanced lapro in pheochromocytomas,
यहाँ
which
section
was very difficult from the
ये मैं कर
anesthesia
लेता हूँ,
point
नीचे आ
of
जाओ,
view.
हल्का सा
Advanced
हाँ,
intestinal surgeries,
This is always a-
advanced
Exactly.
surgeries
आप-
in hernias.
बस छोड़ दो
And we have seen, it's not that they're doing the surgeries, we have seen the outcome is excellent. We have close
Can you show me
association
this
with the Department of Surgery and all surgical branches. So we know what is happening everywhere, and I'm really happy and we
पूरा वाला तो चिपका हुआ है
proud to be part of this
Yes.
medical college where all the surgical branches are advancing. And At the same time, they are doing a lot of urosurgeries also, urological surgeries. So it's not general surgery and minimal access.
आप मेरे साथ
They are doing advanced surgeries, PCNL,
केबल को
so many
कैसे करेंगे?
different surgeries,
कैमरा का एंगल
PCNL and urological surgeries, vesicovaginal
anything. If I
fistulas,
can't
which are
see, I won't
really
be able to do
helping the common population. They're getting free of cost
नहीं
everything
नहीं
here.
लीड वो आएगा ही आएगा कोई बात नहीं अब इसको यहाँ रखो थोड़ा सा
Very, very
चलो इट्स बिकॉज आप जब तक मुझे नहीं दिखा पाएंगे मैं नहीं देख पाऊंगा
part of life
so we'll mobilize the bladder from here
shop. So at the same time, I will congratulate my department also
थोड़ा सा
for
नजदीक आ
working
जाओ
so hard to make this conference a success. Thank you.
एसी लगा दो यार
One thing I
On है?
must acknowledge here that the work which is being done by the senior professors like Mufti Mahmood and Dr. Iqbal
सबसे मेरे को दे दो
Salim and Dr.
नहीं, नहीं,
Shakil
सबसे
and
मेरे-
Dr. Ratri and
पोर्ट पकड़ के
it's
पोर्ट
worth
पकड़ इसको
mentioning,
पोर्ट
but
पकड़ के निकाल
the
दें
way
ये तो
they
पोर्ट
have
भरा जाएगा।
given a field to the younger surgeons, especially Dr. Zafar Khan, the way he's performing pyeloplasty, a very difficult transperitoneal approach with that big redundant pelvis. This is worth commendable. And all young surgeons, Dr. Javed Qadri, Dr. Arshad Kima, and others, Dr. Arshad, second Arshad, they are doing a commendable job. Congratulations to the department.
ये यहाँ से कुछ oozing है but that is not the issue we'll have to go in this plane हम लोग को यहाँ दिखा दोगे फिर मैं बाइपोलर से रेडी रखना मैं बाइपोलर ले लूंगा so I will take इस पे से रख लो हाँ यहाँ पे आ जाओ दो लोग हाँ no 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 this is not I have to go into this plane बच्चे create a plane between the bladder and the fistula no
Can you get audio from OT1?
सिस्टर सीजर नहीं अच्छा है प्लीज मैंने आपको रिक्वेस्ट किया था उसको मैंने कहा था मैं लेके आऊंगा या
Hi, Dr. Rahul.
हाय हाय हाय
Nice going, good section.
it's not a nice one it's all stuck here we're trying to do the things this the part of the vagina is usually very it is a very vascular structure but the problem is not that is not the issue so we are almost here this part of the fistula is done this is the part of the vagina we can see but everything is stuck on this side on the right side of the patient we're just trying to work our way out to find some plane here and then I think we should be able to go to do the suturing everything is stuck here badly it is expected not something which is unexpected but let's see
Sir, take your time.
so
We are just watching you.
I don't have any other option boss
We'll be just switching the audio to a different.
yeah no
You
issues
can
no
divide
issues
your
no
case.
issues bye
Can you get audio OT3?
ये bleeding है can you see this so you have to show me this thing ये पानी पकड़ लें
Dr. Zafar, sir?
Yeah.
Yeah.
So
We are
bipolar
watching your
footsteps कहाँ हैं?
beautiful steps of the surgery. You have completed the posterior wall actually.
very gently no very gently
Okay,
This
can
is the
we
bleeding point.
see the external surface picture in a larger screen? Yeah. See how the Dr. Zafar is placing the stent in this patient.
ready
Touch wood, the guy is going freely.
Okay.
So,
ready नहीं आप पीछे करें आप you're blinding me
Dr. Zafar, Dr. Ajaz,
Yeah,
Rahul here, you are doing a commendable job and I appreciate your skills.
thank
Is worth mentioning.
you very much. I thank my seniors, I thank the principal, I thank my HOD for giving us a wonderful opportunity to depict our skills in front of such an august gathering.
OT3, please switch over to endoscopic vision.
just very gentle
OT3 endoscopic vision.
अच्छा चल रहा है I don't think this is working चल रहा है चल 25 कर दो सिस्टर just section बस ये पकड़ो scissors to me sister हाँ आप यहाँ पे आ जाइए जरा now you have to go there like this I'll go like this and this bachchi will come
So you had clamped the catheter or it is not
अच्छा ये
clamped?
कोविड की है
Audio from OT3?
Yeah.
Yes, sir. Your guide wire is in the bladder?
suction just one
Yeah, inshallah.
Suction.
The bladder.
these are all vaginal vessels the sinus vessels which bleed yeah correct
Can we get audio from OT2 now?
आप छोड़ेंगे नहीं. When I'm cutting now, if you leave, then my cut will go wrong.
Is it OT3 here connected? OT2? Yeah. Yeah. Yes, sir. So Dr. Ajaz Rathar here.
सबसे परेशान आप.
Sir, may I know where you are
The cameraman.
the section is? I think you from
I'm
being seen from that side on the left.
If I go
Is
deep,
it?
you just come inside. I'm not able to find a good plane between the vagina and this thing. हाँ.
Right.
यहाँ पे section थोड़ा सा. कोई बात नहीं.
Right.
आएगा.
Right.
इसको pull कीजिए.
Yeah.
हाँ.
D3. Yes. Wonderful dissection. I think it is D3. You have completed the D3 dissection, is it?
There's an announcement. We are thrilled to have the presence of our worthy Principal Dean in the auditorium who has inaugurated this workshop just now. Sir, we welcome you to this auditorium. Professor Mufti sir wants to make some announcement.
Section.
Well, it's my proud privilege to welcome our Principal Dean, Professor Masood Tanveer, who requires no introduction as far as academics are concerned. An ace academician, he is always promoting academics in the institution, and in continuation to those endeavors, he has been kind enough to offer us permission to conduct this high-tech workshop. I am highly grateful to him for the kind of logistics he has arranged for us. And as you know, there are many difficulties in conducting such workshops. And he has been instrumental in facilitating the smooth conduction of this workshop. What you see here, it is actually his contribution to the institution. Ladies and gentlemen, please give him a big hand.
And when will do this thing?
I would invite Professor Tanveer to say a few words to the audience who have gathered from different institutions. We have faculties, we have students, we have postgraduates, we have DNB residents, and we have faculties from other institutions also. Sir, please.
Section. Section. आप यहाँ पे आ जाएंगे. Correct. Very nice.
Firstly, it's a proud privilege on
Doing a
part
VVF
of
is
me
very different from doing a
to welcome
improvisation.
you all to the opening day of UROSURG conference being organized by the
Can't err on the side of the uterus, and you cannot err on the side of the
Urological Society, Kashmir
That is the
Urological
issue here.
Society.
उसमें अगर हो भी जाता है थोड़ा सा दिक्कत नहीं होती है.
Professor
Sir, some wash please.
Ruxana, Professor
Script में आओ.
Ridwan, and
सही तरीके से करो बेटा.
Dr. Professor Ejaz.
At least we are able to find something. We are able to progress. That is more important.
Distinguished HODs in the gathering.
See,
and
like if you are doing a pyeloplasty, na, it's very neat and clean surgery. It's not a bloody surgery.
To all of you.
It is very like a laddu and you
It's a
can do
great
it also.
opportunity
These surgeries are very unpredictable because you don't know what is happening.
for all of us.
कौन सी चीज कहाँ जाके add
So
होगी?
we have for yet another conference to showcase the current state
आप
of
यहाँ पे आ जाएं. मेरे को ये इस जाना है. So this is the vagina.
technology
You have to now separate this from this
being
thing.
used. We are glad that our institution
Can't see.
has progressed
Can't see.
on the surgical front, like focus on surgical front.
Now I can see.
In the last,
Harish, you are doing a great job. Amazing.
we have
ये हो जाएगा ना तो तुम्हें ऐसा तुमने क्या किया मेरी जिंदगी के लिए.
there are a lot of specialties and some special
We'll stop it.
state of surgical procedures are being done, and the results are no less than the best centers in the country.
फिर assist करता हूँ. फिर assist करता हूँ.
And as all of you are aware,
Yeah.
we have had some hearings
क्या करेंगे इनसे?
urology.
Hold.
We've had kidney sparing tumor resections, transplants, reconstructive surgeries,
ऐसा.
And we have a host of
I'll take bladder away from the
procedures.
vagina.
Of late, I was seeing this laparoscopic Whipple's pancreatectomy,
No, no.
things like that. And
आज
we
हमारी
have been
जात वहाँ से
working
नाराज है।
enough to add more and more subspecialties of
ये
surgery.
sister.
And this is minimal access surgery for which we have been awarded fellowship.
आजा आजा
And which is a proud achievement for
में नहीं होती है नहीं
institution
होती
that we have
आप बेटा इसके नीचे रखो okay so I have to go in this plane between this and this this we have done get a plane here then we'll
sound the word of
आप
caution.
इसको हल्का से ऐसे रख दे
At the same time, while
ठीक है नहीं है तो बात है, चलो
developments in the field of medicine, all of which are directed to make the life of our patients better and to retain or regain good health. Never threats are emerging. We have started in November at Teleman,
Bladder wall is getting thinned down.
teleconsultation
It's not very
program
good.
for mental.
कोई नहीं यार I am happy
And till date, we have received
I am happy
14,000 calls in 6 months. And in this short period of time,
नहीं आप बेटा
you will be surprised.
keep it down and up towards you
More than 2,000 calls are related.
कोई बात नहीं laparoscopy is all about traction
So while
and
we're
contraction nothing
using the
else
state of
Section करने से
art technology
laparoscopic surgery
and innovations and research,
जैसे मैं push कर रहा हूँ अपने हाथ से you just find yourself again
people's
and
health
that's all don't worry you're doing a good job
faced with another challenge, that is the challenge of addiction.
may not
By the Department of Psychiatry, where in 10 districts they found around 69,000 youth are involved in
so we are
substance
पैसे रखेंगे ऊपर
use and abuse.
आपके प्रोग्राम
And
में
the commonest illicit drug used is
bladder को हम mobilize करें
and these IV substance users, up to 70% of them are hepatitis C positive, and maybe 12% are hepatitis B positive. There is an
We want to create this flap is one
those numbers will
give us mobility to close
Now this
and
is
two,
not a good
you have
sign.
to put a
When on one side we are making
If I do it, I can some-
strides in managing
This is second
patients,
momentum here
a new
and
threat
is for hypospedia
So I would sound a word of caution to all my students.
everybody here on this thing
That kindly be aware of this problem, be vigilant,
अच्छा अब आप
be
इसको छोड़ो
proactive,
consequence
educate the public about the menace of
आराम से आपका बहुत important
substance use,
is ये मेरा
ask them about early detection
Will go
and
down.
early warning symptoms which might suggest that
तो एक सेम वाला फोर्स से भेजना मेरे को ये वाला उधर
is involved in such activity.
not that one
So
मैं
I'm sure in the next 2-3 days we'll be showcasing
I ask you to because you're
technology
you're handling I think you can
complexity to see the techniques being
चलो आओ
used by some of the great experts
I'm
on the
just giving you
subject,
the best part
a variety of
like this.
surgical procedures,
up like this
or mainly
चल
general surgery.
अब आप मेरे साथ रहेंगे अच्छा
Hope the experience so gained will be of tremendous help to the postgraduates, to the
आप छोड़ो,
students,
टेढ़ा मत
and
करना।
even the faculty
Yeah,
who would like to practice such techniques themselves.
तो आप
You
निकाल
will-
दें
I wish the conference all success, and I will pray for the same.
सिस्टर
Thank you very much.
थैंक यू आप हाँ ऊपर हैं और मैं नीचे हूँ चले जी और ये बेजाना को सेपरेट करना मैंने यहाँ से आ जाओ यार आरिफ साहब इसको लिफ्ट करें हाँ
Professor Tanveer, we must compliment you for the commendable job the Department of Surgery is doing here, and next to none. And they are the international report, the way the surgeries are being performed, all sorts of surgeries, complex surgeries by our even junior surgeons of this Department of Surgery.
this goes fine we'll look like heroes सक्शन करेंगे बेटा एक बार यहाँ पे you suction and then you go up suction and you go up
Can we get audio from OT3? Audio from OT3? Audio from
आप
OT3?
आपका ट्रैक्शन कम हो गया है
Yeah,
हाँ।
madam wants to speak to you. Fine, master.
I don't do like such surgeries without music.
Department of anesthesia.
मजा नहीं आता है क्या गंद है यार ये.
Excellent job. We are noticing you on Wednesdays and Thursdays. You are doing an excellent pediatric surgery. We just want to know from the anesthesia point of view if some senior anesthesiologist is there. Yeah, yeah. So they make the audience wise about what is happening in these live workshops.
इसके section भी कर लो उसको ऐसा भी रख लो. हाँ, section interaction आराम से करो.
Dr. Fasil, can you tell us something about
जो केस आ गया है उसमें कोई जल्दी नहीं है. पायलोप्लास्टी होता है अभी तक खत्म हो गया.
pediatric surgery cases normally also? See, bariatric, we know it is a challenge for the anesthesiologist, but at the same time, pediatric surgery from anesthesia
Ask
point
me
of view has
practically,
challenges
for
for
how
us.
long have you used the energy source here? It's not for
Dr.
much time.
Faisal?
वो तो अवेलेबल है इसलिए आपने यूज किया है. देखो यहाँ पे इसमें कोई एनर्जी सोर्स हार्मोनिक वगैरह इसका जरूरत नहीं होता.
pelvic calcium system.
Yeah. Always sharp because if you are cutting something, you should be knowing what you are cutting.
No.
तो आप कहाँ हैं? आप यहाँ हैं. अच्छा आपकी गलती नहीं है. मैं आपको आप क्योंकि मैं यहाँ पे. Yeah, correct. Absolutely wonderful. You make a good surgeon.
Yeah, no, not much.
When I used to assist ना, तो मेरे को किसी ने बोला कि if you are a good assistant,
Dr. Zafar, the
that means you are understanding the nuances of the
too much
surgery.
dilated in this
If you
child.
understand the nuances of surgery,
Did
you will
we
end
scan?
up-
What was the
end up
function,
in-
renal function of this child?
कुछ गड़बड़ है.
Dr. Zafar, am I
उसके
audible?
ऊपर करना है यार. आप थोड़ा सा
Hello, Dr. Zafar.
थोड़ा सा लूज कीजिएगा. थोड़ा सा.
Yes, Dr. Faisal,
Yes, ma'am.
welcome. Good morning.
I think this is more than enough. So we can get the part of the sister खुलवाइए.
Yes.
Sutures खुलवाइए. 20 the lock. इसको ऐसा रखो.
Yeah.
अभी करेंगे सब दिखाएंगे.
Yes.
See, when I close this, I have a lot of area here. हाँ.
Yes.
Fantastic. अब इसको पकड़ ले बेटा. Yeah, correct. ऐसा I'll hold this one. Arif, यार, you do very good suction and washing. Huh? Good, yeah. I'm privileged to have you today. Because if you are not able to do it, I'm not able to work. Believe me, I'm not this thing. इस तरह को बस ये कट लगाना है जिंदगी का आखिरी.
Thank
इस
you.
कट में
Thank you.
डिपेंड करता है ब्लीडिंग आएगी कि नहीं आएगी. लेकिन
Dr. Zafar, we do always transfer to an approach loss or something.
somebody people, oh, bleeding हो गई यार, हो गई इसमें क्या है? काटेंगे नहीं तो जाएंगे से. So now here I'll put the mentum. So this is quite a good area, deep area we have gone. So now we have dissected this part. पीछे आ जाइए. And this is the part of the fistula. So the fistula is wide open. So we'll start closing the fistula from now. So this is the part of the fistula. कहाँ है fistula? ये fistula है. आ जाओ अंदर आ जाओ बच्चा. ये fistula.
Yeah, you get adequate space
Okay.
here.
This whole is a fistula part. So we'll close this part.
Difficult
यहाँ नहीं, ये है.
space you have there and you have
ये.
good vision.
आ जाओ दिखाओ section. अरे सब section करो एक बार दिखाओ जिंदगी में हमारे को fistula है कहाँ?
But only one concern is sometimes about the leak, urinary leak and
ये नहीं है.
peritoneal
ये
function.
fistula वाला part
That
है.
is the advantage of retroperitoneal.
कोई बात नहीं. So this is not much of a this thing. So we can just close it down very easily. एक मिनट पीछे आओ. आप इधर ही है. तो दिखे ना ये fistula close हो जाएगा. यहाँ पे हमारा momentum आ जाएगा and we'll close on the bladder. So can we talk to them once? Can we go on air? खोल यार. तो कंजूसी क्या करता है 20 में? तो बहुत कंजूस है 20 देने में. तो बहुत कंजूस हो. फिर जान निकलती है तेरी 20 देने में. अच्छा दिखाना तेरे कैसी बातें करता है. मेरे को बोलना है. तो हमारा दोस्त है यार. कैसी बातें करता है.
Ectomy side.
तेरे को पता है मैं लोकल आदमी को हमेशा प्रमोट करता हूँ. चलो can we put us on? So we'll show them the dissection nicely once. चल साफ कर लेते हैं यार. So एक टाइम इस सर्जरी जो सर्जरी होती है ना, इस सर्जरी में एक बार लगता है यार क्या गंद है, कहीं नहीं पहुंच पाएंगे. लेकिन सडनली गॉड इज वेरी काइंड ऑन यू एंड ये आप बेटा ये यूरेटर ये ब्लैडर पकड़ेंगे ना. किसको ये नहीं इसको पकड़ लें या दिस पार्ट ये जो डैंगलिंग पार्ट है ना और बंद हो गया. यार सिस्टर नाराज है, इसको चाय नहीं पिलानी आज. चाय इसकी करनी है बंद. इसको आज चाय इसको मिलेगी नहीं आज. This is a very good instrument otherwise.
Is it right extended or you're doing right hemicolectomy?
Just hold this bad part, not the good part, and just keep it like this.
Is it extended hemicolectomy you are doing?
ऐसे.
Right.
कोई नहीं करता है. गवर्नमेंट सेक्टर में कोई सर्विस नहीं करता. इसलिए I tell all the postgraduates, if you want to see good surgery, it is your responsibility to clean it. Unfortunate one.
Please take your time.
The word unfortunate.
I know it's very
but this
difficult
is
to
the
talk and
this is the
take time. It's very difficult.
official.
You have to concentrate. Please go ahead.
posterior wall of the bladder and things. Okay. So this we have mobilized it. To me, it looks we have done a nice job, and then we'll put some momentum there, and then we'll start
Yes, sir, we
closing.
can
the
appreciate it very well.
यार वो आएंगे?
Yes, of course.
ओ भाई तो हाँ मेरी जिंदगी में बाहर लाने के लिए
Yes, surely. Yeah.
interactive. I just want to show them the ureteric orifice, where the ureteric orifice is far off. So we are sure we are not taking that. ठीक है ना? ये नहीं होना चाहिए शाम को कॉल आना चाहिए रजिस्ट्रार का सर उसको आउटपुट नहीं है. Suction is not working.
Oh, you must.
नहीं हम सब क्लीन करेंगे. We will clean everything. Don't worry about that. कहाँ से आ गया ब्लीडिंग कहाँ से आ गई? नीचे का क्लॉट है कि ऊपर का क्लॉट है?
Right, clear. Yes.
ज्यादा नहीं कीजिएगा पुल बेटा आप ज्यादा नहीं पुल कीजिएगा तो बंद हो जाएगी. You can't do anything about it. तो ये बंद करूंगा ना मैं. क्लोज दिस अप तो यूजिंग बंद हो जाएगी. आप इसको थोड़ा लूज रख लीजिए थोड़ी देर जब तक वो आते हैं. हमें मोमेंटम दिखाएं. शो मी द मोमेंटम. एक सेकंड. थैंक यू. गॉड ब्लेस यू.
Right. Yeah.
एक ग्लास पे दीजिएगा सिस्टर मेरे को प्लीज. वन ग्लास पर प्लीज. मेरे हाथ में मेरीलैंड है. कोई भी ग्लास पे दे दे. वो जो आप मुझे दिखा रहे थे ना सिंपल ग्लास पर. हाँ ये दे दीजिए. नहीं इसके साथ वाला क्या कर.
So why do you want to do ICG here?
This is not good. है?
Yeah, it is very healthy gut. Yeah, that's what I want to appreciate.
ठीक है ना? ठीक है.
Yeah.
So ये बात होगा. इसको मैं थोड़ा सा ना ये एरिया को काट लूंगा तो उसको लिप बना लेंगे इसको. कट दिस पार्ट. हाँ टंग जैसे बना के.
Right. Sir, one word I would say here regarding the extracorporeal anastomosis in the hospitals also, we also prefer to that the samples are not being provided. So they have the luxury at as much as they can use to, as much as they can. We feel that since the specimen has to be taken out, we give a small pap incision and try to do the extracorporeal anastomosis, and it will be tracking well.
इसका ना ऐसे नहीं चलेगा ये. रात को वाजवान लेके जाना पड़ेगा मेरे को. नहीं रात को नहीं मेरे देर में ऐसे नहीं चलेगा. नहीं वो नहीं मुझे पता कहाँ जा रहे हैं.
Right.
तो जहाँ ले जाएगा हम चले जाएंगे. क्या कैन यू लिसन टू अस. समथिंग यू हैव कम आउट.
Can we get the 41?
Can you just give me a second? We have had just a bit of this thing. नहीं mop दे दो मैं इसको दे दो. Port cap system को दे दो. Yeah, just a minute.
Please.
We just this came out. नहीं we are reading the things. Also our main camera port just slipped out. We are back in. I just want to show where we have progressed, and with the grace of God, this is the momentum which we are planning to take in there. It will come easily. Sister, can you have a forceps? Suction दे दो. Give me the suction.
Doctor,
So,
very difficult dissection for you. We can see all adipitous tissue around. You are doing a very tough job, so you can take your time. It is not that easy.
Almost it is done, sir. I am just going to start closing the fistula. This is the dissection we have done. This is one of the ureteric orifices, which seems to be quite far off from my point of closure, and the other one is also far off. This is how the ureterics help. They make you confident that you are not, you will not be in trouble in the evening. So this is the dissection we have done for the bladder. So we have completely separated the bladder from the fistula, being sure that we are going to put omentum here.
Right.
So we need some space to put the omentum. I always put the omentum or some flap there if omentum is not available. And this is the vaginal opening. I'll just show you. आप ये छोड़ दें. Now because I'm just going to start the suturing now. Just hold it. I like it. So I'm just going to start the suturing now. So there is a fistula. That is the fistula part. So which is quite away from my bladder dissection. So I'll start closing this fistula part. This is the fistula vaginal part. So I'll close this and then I'll put a omentum between the bladder and this thing. And then I'll get back to you once I start closing the things. Any questions are most welcome. If anybody has any doubts, anybody wants to ask something.
The communication was between the bladder and the uterus. So
Yeah. We have opened up the part of it because it was close to that part. So we have, once you are doing the dissection, you want to be safe. So once you are safe, then it doesn't make a difference if the vagina also opens up. So we have to have a good adequate mobilization of the bladder. That is more important because you want to close the bladder. Fistula in some cases is very large. You can keep it open also. That's not an issue. The issue is there should be an intervening tissue between the bladder and the vagina.
Ureteric catheters via the peripeus as a routine.
Yeah. I told you I have I don't know whether you heard about Eklavya. He is a person who learned the archery just by watching the things. So to me, Dr. Malik sir is the person, and Dr. P.P. Rao, they have two been great influencer for me to start laparoscopy. So once I'm telling you, I was making a presentation, and Malik sir was kind enough to walk up to me and say, "Ki you have not put the ureteric catheter. Why?" So I told him, sir, it was far off. How do you know intraoperatively it is far off? While you're suturing, you're concentrating on suturing, and something goes wrong, what will you do?
Yeah.
I said, okay, fine. And does it cost the patient? No. Does it cost your time? No. Then what is the reason not to be safe? So that's the reason I put my ureteric catheters in all my patients.
I'll take it. Yes, please go ahead, sir.
चलिए बेटा
Yeah, we can see the green dye exactly
लाइफ
on
में आपके
the.
नहीं आना चाहता उसको छोड़ दो आगे चलो ये पकड़ो
Wonderful vascularity, sir. Obviously.
For the suture point of view, if am I on? What suture I'm going to use? I'm just going to show you that suture. Am I audible? Am I on?
Handling such a bulky tumor is very difficult in laparoscopy because you get less space. It occupies most of your.
सिस्टर इसको काट देते हैं नीडल दे दे मेरे को दे मर्जी दे दो तेरे पे राइट हैंड कोई भी दे दे यार ऐसे चल जा नहीं मिलेगा
Thank you, sir, for the nice demonstration.
am I on? I just want to discuss about the sutures.
Can we go to Dr. Zafar Khande's OT?
एक सेकंड उनको बोलो कि ऑन कर दें before I start the suturing.
Yeah. You,
I want to discuss a point. I want to make a point. That's one.
right.
ये यहाँ पे रखिए यार गिरना नहीं चाहिए.
Keeping it at till end.
Section in this thing.
Fix it first and then the anastomose. But is it for your convenience that you keep the written portion there? Yeah.
आ जाओ.
Exactly.
Section. This is the fistula. देखो you should be sure.
Right, sir.
And I'm about to expand it now.
Would you recommend a frozen section at the place where you want to excise the lower
This is the
portion?
part.
Or you
डालो
do
उसमें section
recommend
डालो.
it?
See, the moment I made a
ठीक है ना छोड़ दो. Leave it.
the normal block unit
छोड़ दो पीछे. आरिफ यार
saying that the new
सर्विस जैसा मैं कुछ हो.
structure initially, which was very well depicted to everyone, that was a normal looking ureter.
Right.
So this one down.
मैंने पूछा भी था. With our age, what happens is we become with fixed ideas. Fixed ideas means fixed needle hole.
It's a wonderful spiral anastomosis. You have very
Things
big
like that.
anastomosis here.
So I
It's a
use,
wonderful
I don't use
job in
the,
that.
this is a type of a needle holder, which is a, gun, pistol sort of things. I'm not used to all this. I don't like this thing from the very beginning. I use a straightforward thing. I like to keep my things very simple. So उसमें क्या है कि आपकी mobility आपको better मिल जाती है. So this is the one wall. Sure.
At least one thing we can say, Professor Mufti Mahmood will be leaving the Department of Surgery of some time, but he has trained a lot of people and he has kept a legacy behind, will be worth remembered throughout. So I should compliment him.
ना 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 ना
Confirming the sentence.
जब जिंदगी अच्छी चल रही होती है ना तो उसमें परेशानी नहीं लेते हैं. Enjoy life. And it is
Chairperson,
we've done
I'd like to welcome Professor Ghulam Jilani, ex-principal, Dean Government Professor. So kindly join the chairpersons for this session.
Can you connect me to them once, just for once? जब वो आते हैं तो बैठ जाते हैं. I'm going to
give a talk on partial nephrectomies on
We have pyeloplasty.
Sunday. है ना नहीं Saturday sorry morning में
Laparoscope.
All clear.
all of you are free to make any comments if you want to make sister का comment नहीं लूंगा उसने मेरे को दिया नहीं आज and there are ways and means to tell you I don't like you one of the ways is to give the instrument am I on
We have Professor Ghulam Jilani, who has been ex-head of the Department of Surgery and principal of this very college, and he chairing the session with us. Professor Jilani Sahab, you are welcome here, sir.
sir can I make a point I just wanted to make a short point
Yeah, please go ahead. Yes, Dr. Rahul.
yeah sir first of all Dr. Jilani I just my regards to you. You have been a very great senior, and we all adore you.
Thank you, Rahul. I know you. You have come all the way from Jammu, huh?
Yeah, sir. It's. I just wanted to show the more important part. Once you have dissected the thing, is to close the thing. Now, how do you close it? The V-lock is a suture from Covidian, which has made the life of marginal surgeons like us very good. Will make us look as if we are very expert suture giving people. But believe me, this suture is so good. The more important part is whenever you open up the suture, you should be knowing the length of the suture. A lot of time, and this is a costly one. This is going to cost the patient if your patient has to buy for 2,500 or around 3,000 rupees. So you can't open a suture and say I didn't want to use it. So that is not acceptable. So whenever you open up, you see what suture you want to use and what length you want to use. This is what I'm using is a Covidian 90. It is a 27 mm needle. And it is about 15 centimeters, which is an ideal size to work in the pelvis. This is what I believe. So even if you have to use one more, no issues. But if you have a very long suture, you are not able to, tackle it, then it becomes very difficult and very fussy. You don't look, seem comfortable. And the most important thing in a reconstructive surgery is to be comfortable. So that is one point I wanted to make. Thank you.
Thank you.
एक बार बेटा suction करना है. I think this is closed. The vaginal part we have closed. The cervical part we have closed, I think. एक बार आप section कर
This braided suture, unidirectional suture, whether it is stratification or it has made us all comfortable. Whether you are opening on the stomach or any diaphragmatic hernia, only I think here Dr. Zafar Khande has not used it.
Sir, the only caveat when I would not like to use this suture is on a ureter. On a pyeloplasty. This is not a good suture for pyeloplasty. There is no doubt about that. But if you are using a primary obstructed mega ureter, if you are doing that, then it is not an issue because that ureter is almost like an intestine. So it doesn't make a difference. But if you are using it for a primary pyeloplasty, I would not be comfortable.
Any reason is only a technical reason or there is some other disadvantage, maybe some...
This is a very rigid suture, sir, and you see a very soft structure.
Right.
Only the success will come out on how gently you have held the ureter during the dissection.
Right.
That is my take on this. So ureter, pyeloplasty, I would not use it. But for bladder, for primary obstructed mega ureters, this is a very good, fantastic suture to use for a laparoscopic partial nephrectomies. This has made a life definitely very easy, and this is a very good suture to use.
One thing, it does not come in different sizes. There's only, it comes as 10.
No. 20, 10, 30. All sizes are available, sir, and all lengths are available.
Right. Both companies, sir, or is only one?
No, sir. The Covidian is, I have been using Covidian, no conflict of interest. They have not sponsored me. But I'll give you a true opinion that I have used almost all variety of the sutures.
Right.
The strength, the needle quality of this Covidian is definitely better than the other ones in the market.
Right.
So that is why I'm 30. Simple. Block me. Simple. So now when I take a suture to put the momentum, I don't use what you call this as a. I will not be using the V-lock. I'll use a simple thing because momentum will not take the V-lock very easily. It will cut through.
If the tissues are edematous and they cut through, you still want a suture or you just put an momentum and leave it there?
Sir, I can get your question. Edema at what level we are discussing?
Just at the bladder, neck, and
at the level of this thing, the VBF?
VBF, I'm talking about. Yeah.
Usually, if there is edema, then means there is an error in judgment in us. Sometimes patient would push you to do it fast and early, because they're incontinent and socially ostracized. But I strongly believe that waiting for 3 months, whatever ancestors have taught us, if you're doing a retrovaginal fistula, it's not an issue because the gravity is always helping them.
Right.
If you want to do a VVF, I would be very skeptical to go in early. At least with my experience, whatever I have over period of almost now 10 years, I've been doing VVF laparoscopically. I would not like to go. If I do a scopy and I find edema, game over. I am not doing you.
Right.
You can get it done by somebody, but I am not doing you. And no catheter, no tube. This is very important. Perineal hygiene. The patient has to understand the first surgery is the best surgery.
Definitely.
With the permission of the chair, I would like to extend a hearty welcome to Professor O.J. Shah, who is a doyen of HPP surgery, former director,
15 centimeters.
dean,
Close the catheter.
for another department, surgical G. He has joined us. We are thrilled to have you here, sir. Welcome, sir.
चलो देते हैं फिर देते हैं अंदर मसला नहीं होना चाहिए तो लाओ जी नीडल होल्डर मेरे लेंस सिस्टम में लेफ्ट हैंड नहीं बेटा यू विल हैव टू कम लाइक दिस ओके और आपको सिर्फ इसको मोमेंटम को सपोर्ट करना है ठीक है यू विल नॉट फाइट विद अस यू जस्ट सपोर्ट द मोमेंटम व्हेन आई टेल यू ठीक है सो लेट्स जस्ट वेट फॉर अ सेकंड और आप ना कैमरा जस्ट डोंट मूव द कैमरा जस्ट कीप इट लाइक दैट दिस ओनली नथिंग मच इज रिक्वायर्ड इन दिस केस हाँ बस दैट्स ऑल व्हेन I tell you don't do it now because we don't want to injure that. You are comfortable with it? You are comfortable? नहीं कोई बात नहीं वो होगा ही. You have to make space for yourself and I'll make space for myself and we'll push it each other and find a balance where we are not disturbing it. अब आप इसको ऐसे रखेंगे. Take it up. Okay. So I'll do the things myself. चलो. Can we get in please?
Dr. Arshad wants to ask you a question.
अंदर आ जाओ.
OT1.
Fantastic. So I'm not holding the bladder. So I'm going from the perivesical space. So this is my first stage. I'm not using a V-lock here because omentum is a very soft structure.
Audio of OT1, please.
It looks very. ये जो होता है ना. No issues. So
Dr. Rahul, are you listening to auditorium?
Yeah, absolutely, sir. We are
There is a
getting-
question from one of the audience.
Sorry, I didn't hear.
Okay. Go ahead.
Come again. Can't hear, sir. Can't hear. Yeah.
Yeah, we will benefit the bulbs in these anastomosis.
Sorry, boss. We can't hear you. If the panelists can take the question and put it across to us. Sir, can the panelists please tell me what
will be narrating a question.
my colleague was saying?
On mic.
Hello, sir. Am I audible?
Yeah, absolutely audible.
Sir, you were listing the benefits of bulb sutures, but recently there have been some papers that have mentioned the rising incidence of adhesive obstruction with use of bulb sutures. What's your experience, sir?
With the grace of God, not till date. But if that is there, we will definitely look into that because we do VVF and I've been using it for last 10 years now. I have not come across this thing. For bowel or something, if somebody has used, I don't know. I don't use it for the bowel. But for urinary tract, I have not had any issues.
Dr. Rahul, if there is again a recurrence, God forbid, after the laparoscopic procedure, would you like to go third time also for the laparoscope repair or would you prefer to open one?
If it is the third time, I'll request my colleague to do it. If it is the first recurrence, I'll like to go back inside myself.
Oh.
You can go back, Mike. This is on the lighter note, sir. But if it fails, does not make a difference. You go open or laparoscopic. Laparoscopy, the vision that gives you, that what you can see with laparoscopy is absolutely different. Have I done it? Yes. One of my fistulas failed. I requested that person to go I'm very being true to you. I requested them to go to Chandigarh for a robotic closure. They, like many of our patients in the state, they can't afford, they don't know, they have not come out of their house. They said, no, doctor, whatever you will do, will abide by that. So I discussed with again my mentors. So they said, always go laparoscopically. Don't even bother about doing that. And with the grace of God, that patient healed nicely.
Thank you, sir. We welcome here Professor UROSURG, who has been a doyen of surgery in Government Medical College, Srinagar, and he has taught most of us here. Professor Zargar, sir, welcome, sir. Any comments from Professor Zargar? Dr. Zargar, sir, you are welcome here, sir. We want to listen to you, sir. you often attend the conferences, and we have seen you last time also. You have been our teacher, and we have all regards for you. We are all you are taught here, sir.
Dr. Ajaz, he jokingly says I am 88 and young.
The old age starts at 18 now.
Dr. Rahul,
Just start.
sir, you always place this position momentum flap before a bladder closure.
Yes, I do it this way. People have their way of doing it. I've seen people closing the bladder and then putting it, but I feel more comfortable this way, sir.
We all
Because
after bladder closure, but we do it in two ways. One is actually if you see that there's a good amount of space in the vagina, then you can do it after the bladder closure. But if there is some crowding, you can take a stitch in the vagina, but don't pull the momentum there. So once your bladder is closed, then get the momentum down.
Sir, again, I'm
critical point in repair of fistula is actually the bladder closure. So we should not cover that step.
I'll just show you when I close the bladder. Usually, I've not had any issues, so I've never felt the need to do it this way. The only thing is that whenever we take a suture of the omentum to the bladder, the thing to remember is that we should not be taking the bladder wall to pick the omentum there. We should always use the vaginal or a perivaginal space or tissue to fix it. So that is one of the points I would like to put across. Now, there are two ways of closing the bladder also. If you see Malik sir doing it, he always opens it transversely and then closes it. He strongly believes that by doing that, the bladder is mobilized nicely and nothing will happen. So I am not shifted to that, but I do it this way.
Malik sir has actually encountered uteric injuries by doing a transverse opening.
But he strongly believes, he says he has never done that and he will never go back to this way of O'Connor's, mini O'Connor's, or whatever you say, leave it better.
That's true. The only disadvantage, you become very close to the orifices once you get transverse hysterectomy.
Yeah, but he believes it. He believes very strongly in this.
That's true. He has converted from midline to the
So
transverse.
for him, it works. He says that because it is very easy. We were discussing the bladder closure. He says it's very easy to close the bladder without any tension. And if at all there is some problem, he can always mobilize, drop the bladder anteriorly, and then close it down.
Yeah, that's true.
So it is all how you learn, how you see your bosses do when you're, during your residency program. I strongly believe that has a lot of influence on your, practicing, how you practice a particular surgery. If you see your boss doing it this way and having good results, there is no need to change. This is what Dr. Mahesh Desai taught us.
Dr. Rahul, may I interrupt you kindly without permission? Professor Ojay Shah has a question for you.
He has been my teacher, sir. My regards to him.
Professor Ojay Shah, our first director dean.
Right now, well, I have got the generation. I know it's in
Mr. Scissors. Even a backhand लिया ना, pistol holder के साथ it is slightly difficult to do that. Please. Just one last stitch and Vlog खोल लीजिए sister. तो जरूर vlog और एक fracture खोल लीजिए. Typical government sector की scissors.
True, true.
Gently, now very gently. Don't have to do anything much.
Most of us, and today we're with us today, and I am so lucky to be individually sitting on his left side. He has been a great man,
यहाँ पे ureter हो सकता है.
a great human being. Finally, at the end of the game, even if you talk to any scientist, if you talk to any Nobel laureate, or those people who have created history, finally, it's to be you are a good human being or not. And I consider him a great surgeon. And beyond that, he is a great human being, Professor Zargar.
Thank you very much for the introduction. I'm here today. I joined this college in April 1959.
My apologies, Rahul. Can you allow Dr. Zargar is saying something?
Yeah, sir, please.
My apologies, Rahul.
No, sir, not at all. It's okay.
After 59, we served here for years together. Now, today I feel, pray to God, if there is a rebirth, I should again get born in Kashmir and start again as a student in this medical college. As I see my students here, doing fantastic surgery, liberating the people from diseases, the diseases which cause death. When I was here, PG or surgeon, they are doing a miraculous job. I am happy to see this institution progressing so well. I wish this institution happy years, especially those people who are managing it. I feel, believe me, I feel happy as if I am born today. I am 88, going to be 89. It is because of my students, their good wishes, well wishes. I live. I'm alone. I'm a yatim because I lost my wife 2 years before. Being single-handed, my children they are outside, and here I feel I am living in my own family.
Wash
Especially
section.
Jilani
Drain में ready
Sahab,
रखिएगा अभी.
Umar Sahab, etc. Salaam alaikum.
Thank you, Professor Durga Saab. It is a very compliment, and is a sort of a impetus for us to see how you can live at this age of 88. And I have been associated with you, sir. If you will recollect, when you became associate professor, I was your lecturer. And how we created that unit, I vividly remember, and I have been associated with you with all the love and respect, Professor Durga Saab. God bless you, sir. God bless you. Welcome again.
पानी बंद कर दो बेटा.
Yes, Rahul, you can continue.
Yeah, thank you very much, sir. It's an honor to have you here, sir. It's an honor to have you in this workshop. इसको थोड़ा सा ऐसा रखेंगे, हल्का सा. आपको रखना पड़ेगा. Just a bit of it, so that I can take one stitch as a good stitch.
66. Can we get connected to OT3?
Any.
Yeah, you are very well audible.
जो तेरे पास है.
Yes, please.
Sorry.
Nice procedure, dancer. We're watching it. And
28 ले लो.
Wonderful. Anoplasty dancer. Thank you so much.
क्या है? अच्छा ये. मैंने कहा ये क्या है? नहीं एक इसको ना इसको यहाँ
Can
निकालने
we go to OT2 now?
Sure.
Colon. Hello. Yes, please.
Yeah.
If anybody has an opinion, please let me know. Now. I'm free to suggest no issues about that.
Right.
Now I'm tired. Not inside or outside doesn't make a difference. इस केस में मैंने बाहर ली है, but अगर अंदर भी आ जाती है तो कोई प्रॉब्लम नहीं है. Because this is vehicle. More of a.
What you have decided now? Intracorporal, extracorporal.
आ जाओ अंदर आ जाओ. I have to see the tissue nicely because otherwise क्या होता है? Bleed करता है. So initial 1 or 2 stitches you take one by one. So you want to be sure there is no gap in between. Okay, it's not an issue of hurrying. It's issue of doing it properly. Doing fast automatically comes. That is not an issue. But doing it rightly, ये थोड़ा सा tissue गंदा है. But I don't bother about that. बस हम इसको यहाँ पे ले लेंगे बाहर. इसको मैं सीधे से काट दूंगा. ये जो tissue बाहर है ना.
OTV audio, please.
Yeah.
Dr. Rahul.
Yes, sir.
Some tips for the juniors.
Just go and do it. Someday you have to do it. See, when we are doing it, just have good, assistance is very good. This boy, Arif, he has done a fantastic job in putting saline and doing the things. He has made my life comfortable. He has made it look easy. But believe me, someday you have to do it. It's just not like that. You may have your failures, not an issue. Not everybody can.
We are always doing it laparoscopically, all fistulas.
I had learned my fistula from my father, like open surgery. But when I graduated to laparoscopy, so I found that this is much better way of doing it.
And this is better vision. You have better.
Yes, everything is far better than what you do or what you have in open surgery. So open surgery, you have to have a extremely good or competent assistant with you. In laparoscopy, I am fortunate today to have Arif with me. Otherwise, it becomes very difficult to do open surgery alone. Laparoscopy, you can compensate a bit here and there, not an issue, but not in the open surgery.
Dr. Rahul, general surgeons are afraid of doing the procedure because of the high recurrence rate. Any message for general surgeons?
They should not do it. Simple. If you don't do a surgery in your wife or in your sister, you should not do that for a patient also. This is my straightforward. I may sound a bit this thing, but if it is not their domain, because they can have more problems, and the patient, it's not good for them to have those.
100% right. We do agree with you.
Dr. Rahul, do you ever place a SPC in a patient?
Always. Again, coming to my mentors, they are not very happy me doing that, but I always do that.
Okay, so you are planning to place a...
I'll just place. I'm just closing the bladder. Once I come to that step, I definitely place. We have 2 catheters open. The sister is here. She has been very nice, and she has been kind enough to give us 2 catheters. So she will be giving us the other catheter also. She's kept it ready. At the start of the surgery, we checked everything, and it has been a great privilege and honor to operate here.
So how do you manage your ureteric catheters? You keep it?
I'll take it out. At the end of the surgery, they have done their job. They are no more required. So we'll just take it off. Just pull them out. That's all. So we have not been anywhere close to the ureteric orifices. So we can just, to be very sure, if you want to be sure, we can just pull it in and out and see whether we have taken the ureter like this. So if it goes easily, so it is easy. So similarly this way, if it goes easily, so we have not taken it out. And once my surgery is over, I'll just pull them out. That's all.
How long will you get the catheter in?
I keep it for 3 weeks. I'm an old timer. My bosses used to keep it for 3 weeks. I keep it for 3 days. 3 weeks, but some people take it out after 2 weeks. They say because laparoscopic and robotic has given you a better vision. But do it this way. I keep it for 3 weeks. I take out the Foley's first periurethral catheter, and then I take out the once I give a voiding trial and the patient comes smiling to your room. So I'll take out the SPC. That's not an issue.
Do you routinely do SPC?
I'll put it from the rent. I don't do an SPC exactly. There's already a bladder opened up. You just place a Foley's from there. That's all. So you don't want a clot or anything to block this thing. So you don't want any, other confounding factors. A lot of people don't put it. I'm not saying they're wrong. I do it this way. I want to be very sure. We work in a government sector. So sometimes, we are compromised. So I don't want to end up in having a, clot inside or something and blocking the one only catheter I have. And then, jeopardizing the repair I've done.
Dr. Rahul, I have a question for you.
Ji, ma'am.
Can this procedure be done by obstetricians in future?
Yeah, they can do it, but ma'am, the issue is about the ureter.
Procedure can be done by urogynec.
So, urogynec is now coming up with a number of people increasing. Somebody would subspecialize into the urogynec, and soon we may have again, the government is extending your things by doing one more degree into this thing. A lot of VVFs are being done by them. The only issue is the injury to the adjoining ureter.
They are also doing VVF by open surgeries.
Yeah, you can do it anyway. See,
by labro also.
Ma'am, the principle remains the same. What I've done is I've just done a standard O'Connor's repair. Like Anderson Hines, I am a believer not of a mini or something like that. I do a good opening,
good procedure.
Nicely, look for the fistula and close it down and put a momentum. That's all simple. That's not an issue. But laparoscopically, yes, you should attempt only if you have a good suturing skills. Because otherwise you may sometimes feel not very happy, and it may take time, and people around you may not be very, forthcoming.
Rahul, excuse me, can we go to OT2 now?
Yes.
Is the case.
Please.
My apologies. Dr. Rahul, I would like to add up a little bit of point. Now, the conception of using momentum in urology goes back to one join of urology with whom I had a chance of being associated for some brief period at the Institute of Urology, University of London. That is Mr. Taran Warwick.
Yeah.
You agree with me, Rahul?
Yeah.
He is the person who gave the conception that the momentum can be used
for this thing,
for these things, and even for the uroplasties, etc., because it is loaded with so many things. It's a God-given gift.
Yeah.
In general surgery, we used to call it as abdominal policeman. It will come immediately and take care of your appendix, etc. And similar advantage is that this momentum is loaded with lymphatics and all that. It forms a real good buffer and helps you to, in healing and,
I think the procedure is over in OT2. Can we get OT2, please? OT2, please.
I have a question for Dr. Rizwana. She wants to tell something about urogynecological.
Are we connected to OT2?
What do I want to tell? I mean, gynecology is an upcoming branch now.
It's an
And
upcoming branch.
hopefully, I may not be there, but our youngsters will definitely go and do wonders.
Almost done. 1-2 VLOC 20 acre.
Are you connected to OT2, sir?
It's an upcoming branch. Okay. Now we don't have to rely. Similarly,
पसीना आ गया यार.
radiology also. We don't now have to rely on the radiology. We can go and have interventional.
वाला है ना कि इसी मेरी तरफ करो.
Interventional. We have fetal medicine, everything, and
This is
I'm trying
almost we are done now.
to sort of
इसे दो
start
स्टेप्स लेंगे
that.
यहाँ से इस पे चलेंगे.
Can you go to
आप
OT2,
ये
please?
चलेंगे बच्चे.
Right
सिस्टर
hemiclectomy.
क्या दे
Side.
दीजिए मेरे को.
Is it connected?
कोई भी. थोड़ा सा स्पेस दे दीजिए.
SPC through the range.
Dr. Javed, we would like to be speak of the patient. Okay, ठीक है.
Next one, program.
कोई रुका है आपसे.
Next year, sir.
मेरे को एक वो दे दो ना क्लिप.
Yeah, it's OT2.
सिर्फ इसको निकाल दें बाहर आप. इसको निकाल सकते हैं. इसको सिर्फ हाथ रखिएगा ताकि वो लीक ना हो. इट इज गॉन डायरेक्टली. छोड़ो. इसी से ले लो. ये चाहिए.
Sir, can you show the section margins of the both large and small disconnected from you, sir? Yeah, this is one side and yeah, good.
Yeah.
Okay.
Yeah, that is the patient margin. This is the patient margin of the patient margin.
सॉरी क्या कह रहे हैं?
Right.
180. You're right. I'll give you a sister.
Right, sir. Yeah, that's
नीडल
right.
जम्मू लेके जाने वाला नहीं हो. सभी नीडल आपको देके जाने वाला हूँ.
Yeah, please. Okay. Yeah, somebody is saying.
Oh yeah.
It's audible. Ah, that's right.
Yes,
As Professor Gilani, I retract back to the previous discussion on momentum.
Soul of momentum.
It is enormous, and anywhere, in fact, in the brain also, we can use momentum. I have been associated with this momentum too, and right from the time of 25 years back now, with pancreatic surgery, I routinely put the flaps, momentum flaps around, especially the pancreatic gymnostomy, and I'm a strong advocate of doing this. Yes, and you see the morbidity and mortality, what we talk today, is grossly reduced once you use.
Sir, even
only thing what I would advocate is that you should have a good anatomical concept of omental itself anatomy. The vascular supply, vascular supply is of importance, and go back to the McGregor.
Okay.
Surgical anatomy. I was very fortunate enough to be one of the biggest series from the subcontinent on pancreatic duodenectomies with omental flaps, which we got published over more than 140 cases. That showed clear increase in morbidity as well as all the centers of the world. There was a great pancreatic surgeon from New York. He wrote to me. He was one of the reviewers. He was very, skeptical about the mortality part of it. We got mortality down to 2% that time out of 100. And that was a big thing for the region. Anyway, what I want to tell you is that I re-explode out of 140 odd patients with omentum dilatation.
Okay.
The only thing what I consistently saw, so they got a leak post-operative. Omentum was necrosed.
Okay.
So the importance of omental use should be in accordance with the anatomy. There are a lot of anatomical variants which you can see from McGregor.
Yeah, true.
Whosoever uses omentum, don't dissect the omentum roughly.
Okay.
This is very important for surgeons. If you want real omentum to work, if you see unusual use of omentum in pyeloplasty, he has clearly demarcated the anatomy of omentum. And variation, because you see, if you get a blood supply is not correctly within the omentum, you're going to have a complication.
In brief, what Dr. Javed, you want
towards synthesis.
Professor Shah, you want to convey is, if I am not wrong on your, that you should know how to harvest it properly.
Absolutely.
Proper harvesting and proper vasculature. It is something that you must know, be very clear about it.
Absolutely.
Before you use it for whatever you are using. Am I right to understand that?
Absolutely correct.
Thank you.
Regarding this Omental, I have read MacGregor. One word for this Omentum is, I am talking of American police and Indian
टिश्यू पकड़ ले
England police.
टिश्यू
Not the police of this. This is called the policeman of the abdomen.
Abdominal policeman. Yeah, I said so.
That you remember. Now, sometimes tonsil is the policeman of our throat. But one thing is, my teacher Zaidi, his name was, he used to say, once this policeman become infective, you have to remove them. That's what tonsil. But that's what momentum. Momentum is great. Unfortunately, it's still in old age. It is just in children.
See, a lot of things have changed. I mean, there was a time, Professor Shah would agree with me. Appendix, we would just throw it. If you are doing we have been doing a lot of Janissary before we switch to urology. But if you are doing, hold on, kindly.
We are almost done. 99% should be seen.
Yes, Dr. Iqbal, please.
Yeah.
We have Dr. Iqbal.
Give me 2 minutes only, 1 minute. What I was trying to share with Professor Shah was that at one point of time, we could open up doors for some whatever reason. And you just find around the appendix. We would say that appendix to be taken because one fine morning it may go into appendicitis and create a problem, so why not to take it out? Now, urology.
Up like this.
This appendix has so much of role. Professor, where is Professor Mahmood? He would agree with me. And Javed is there.
Yeah.
It has so much of role.
Just one gentle wash. एक
Any more out?
नीचे से ना बड़े साइज से फुल नीचे से
Injuries of all that. So appendix, now things have changed. Appendix has still a role which normally we don't take. I was just going to what Professor Dargar was saying.
move नहीं करेंगे. I'll do it myself. आप कीजिए.
Momentum policeman. Even appendix has its own role.
आ जाओ. Flush and aspirate. I think this is the last stitch I have to take.
Yes, Doctor. Yes, please. You are connected. Yes, please. You are audible.
दे दो गाड़िया का 18 नहीं बट 20 नंबर का है कुछ बड़े साइज का दे दो नहीं चलेगा सिलिकॉन नहीं भी होगा तुमसे लास्ट स्टिच है 2 मिनट देना मेरे को
Can we go to OT2 now? Yes, sir. You have made an enterotomy in ileum and colon. Can we go further? Yes.
ठीक है अब छोड़ दो you leave you drop it so I'll just put this pen ये क्या मेरा है अब आप पीछे छोड़ दीजिए सीजर दीजिए मेरे को एक सीजर रेडी रखिएगा 1 मिनट के लिए सिर्फ 1 सेकंड दीजिए मेरे को आप बेटा आप ये इन्फ्लेट करेंगे बच्चे एक मिनट मैं अभी आपको बोलता हूँ तो फिर
wonderful demonstration, sir. Thank you so much. Can we go to Dr. Rahul now?
Yeah, sir. I'll just show you what we have done now. We have just closed down everything. We have put an SPC, which is a 16-inch thing. And
Rahul, are you audible?
Yeah. Can you hear me? I can hear you. Can I have a scissor, sister? Scissors. Can you hear me?
Can we go back to Dr. Rahul?
Hello. Hello. नीचे ये दिखाओ पीछे.
Yes, sir, you are.
हेलो. एक मिनट आप इन्फ्लेट कर लीजिए डॉक्टर. You inflate it by 10 cc.
Right.
Now one needle in.
You are not using statistics here. A lot has been said by Dr. Rahul about the advantages of this.
करो 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 मेरे को दे दो जरा मेरे लिए दे दो
Take another one from other side will be a way.
Right.
This will be a treatment not that we take us from
Thing is not required. What suture I'm going to take is not required as such, but I'm just taking it because I want to be sure. No, never a clip. Urinary tract में clip is not a very good thing to have. It can migrate and form stones. This is vlog me. You don't need to do this. What I'm doing, but just because required. But I'm doing it because or I've gone across the things. You know.
I just it's change of God's current. No, you want to
बहुत सारे लोग
यहाँ कोई है नहीं इनमें खत्म मेरा नजर शाकुन
डाला आपने लाइट दे दीजिए डॉक्टर साहब को गिव लाइट टू डॉक्टर साहब आराम से डालना बच्चे don't push it too much and take out that
Rahul, are you audible, sir?
Sir, I can hear just I will clean it myself. Saline दे दो मेरे को saline एक ले लो clean saline हाँ फ्लैश के खुला छोड़ दीजिए that is flush it attach it back to this
very right
attach it back to this ये ले ये इन्फेक्ट किया आपने सर इसको लगाइए बैक फिर दीजिए मेरे को एंड सिस्टर यहाँ प्लीज अपने हाथ में ले लीजिए 2 मिनट के लिए 2 मिनट के लिए अपने हाथ में ले लीजिए देखो यहाँ से यूरिन आया यहाँ से ये सलाइन उसमें बोलो इसलिए आओ मेरे पास इधर हाँ इट विल बी इजी फॉर मी आएगा बच्चे सबर व्हाट्सएप नहीं है ना इमीडिएटली पहुंच गया और किसी ने पढ़ा नहीं हैव पेशेंस बिकॉज़ यू पुट जेली देयर नो फ्लश इट फ्रॉम द दिस इज poor quality jelly this is not a good quality jelly which comes to the government sector बस अब आप इसको एक्सपोर्ट कीजिए अब आएगा इफ यू आर इन ब्लड इट विल कम लगाओ उसके साथ बैक के साथ लगाओ यू श्योर और यू नॉट श्योर
Yeah, even still hands still on stapler does not make much difference. The leakage is same in both the cases. So it's just such reference and availability of staplers which makes the difference.
छोड़ दीजिए drop it down. It is coming freely. There should be no this thing. Look for the bag. Abhi recently I did one lap ureteric reblood with this thing, the trimming of the ureter.
Definitely.
So there was a hospital bag attached to that. The boy says, sir, output नहीं आ रहा है उसको. So
In government sector, it
drain
is
में आ
a
रहा है.
great rule, sir, because we have poor patients from far off place and so we can hardly use the adult staplers in those patients.
अगर ये चल पड़ा फिर चलेगा. इसको बंद करना चाहिए हमेशा. Always yes.
Can we go back to Dr. Rahul? He has finished the procedure.
Yeah, sir.
OT1, please.
Eurobag.
Can we connect to OT1?
Hello. I can speak, but they can't listen. Hello.
Hello, yes, sir.
Yeah, can you hear me?
Yeah, we can see, sir, your dissection beautifully done and a suprapubic tube also being put.
We have already put a tube, closed the bladder, put an omentum. I'm washing. There is no streak of blood. The omentum is freely coming there. There is no pressure. This patient is exaggerated lithotomy position. So once the head end comes up, everything will come down to normal.
So do you do a leak tests?
I don't like to do it, but if you want, we can do it. No,
we have full faith in you.
No, I don't.
We are comfortable.
It's a very fresh anastomosis.
Right.
And it has been done under vision.
Yes, sir.
And it has been done without tension. And it has been done without any bleeding.
Right.
So you have to be, the God has to be very unkind on the patient and the surgeon for this to have any problems.
No, God's always with the brave people like you.
God is very kind to the patient, and I always see that this patient should go home and come to you. Thank you so much. Thank you, and
thank you so much.
Great thanks to Mufti Saab for giving me this opportunity, and Javed, who has been working day in and day out to make a success of this workshop.
Thank you for your support.
Thank you so much. Thank you so much. Thank you. ये पानी बंद कर देंगे please? Can you stop this water?
I think it's a low.
Take out everything. 2 मिनट फिक्स क्यों करेंगे इसको? सर पकड़ो 2 मिनट I'll just tell you. कोई special ये पकड़ेगी. So एक vaginal pack ready करो. Let me see what is this. वो निकाला हमने. Can't see. And whenever you clean the vagina, you go on the posterior wall of the vagina. You never go and do it on the interior. Suppose tomorrow you are cleaning the vagina, somebody has to do it, no? नहीं, ये मेरा तेरा बहुत झगड़ा हो रहा है भाई. ये चलेगा नहीं.
Not wrong. I'm seeing the good old KC Sharma. Am I right? Hi. How are you? Evergreen?
पकड़ो. I'm
audience will not be knowing to whom I am talking at the moment.
Please.
He's Dr. KC Sharma.
Give me a clearance.
Evergreen district surgeon.
Clearance 28. दे दो drain दे दो.
Somewhere in Jammu. I think from Jammu only. He hails from Jammu. But he has been a surgeon and he has devised so many innovative procedures. He will probably, I'm sure he will be having a talk, that he has actually revolutionized that idea that in a district level surgery, you are handicapped because you don't have this facility, you don't have that facility. How he has managed the tips and tricks, as we call them, to do something. If I remember a couple of years back, 3-4 years back, you even said that, I don't know the word you used, 3-4 surgeries together in a patient. मुझे याद नहीं आ रहा exactly, Professor Sharma. Exactly. So, I am sure it will be a treat to hear him that how, in short, what I am trying to convey is how beyond the medical school level or the tertiary care level, more surgery can be done comfortably, safely, and I'm sure the person who is going to talk about is Dr. K.S. Sharma. You are welcome. I'm happy to see you after a long time. You are still alive. Thank you. Must be 65 or उससे कम क्या होगा 71 ज्यादा रिजवाना ने तो अच्छा कहा ना कि लाइफ बिगिंस एट 80 तो अभी तुम घर छोटे हैं
Yes.
Nilofer should not hear that.
Life begins at 60 and 80 is old age. That's old age.
Beginning of old age. 80 is beginning of.
At 60 that's
not old age.
the trouble is now we retire at 60 50 हमारे टाइम में 58 था वो सब आदमी को लगता है
अभी तक मेडिकल कॉलेज में can work up 70.
प्राइवेट तो मैं
हाँ,
I worked after my retirement out.
Yes, but I know now.
आगे तो जल्दी कहाँ थी तुम लड़कियाँ
There is no retirement in them.
चलो जल्दी
क्यों आना चलो दिखाओ ऊपर दिखाओ ना ये किसके हाथ में है तो एक्सप्रेस करो हाँ चलो मूव वेट गाइड मत बहुत पीछे लो on continuous
क्या उम्र
continuous
I told when I was principal, I told अपने साथ के सब तरह technical test वो सब shrewd disabled out तो
चलो गाइड मत पीछे लो पीछे लो गाइड मत पीछे लो छोड़ो दो हल्का थोड़ा हल्का निकालो गाइड हाँ तो गाइड है ना हाँ ये छोड़ो
सर एक मिनट तो बताइए
चलो दे दो मेरे को चलो दे दो ऑन को मैंने करना है ऑन हाँ छोड़ो चलो छोड़ो जरा गाइड कर ले बाहर ले ऑफ कर दो चलो कंट्रास्ट देना मेरे को
बाद में आऊंगी, साथ में होंगी, वहां से भागेंगे ना।
मैं करा इधर आओ। Hello. Good, good, good. Yes. Good. What? Hi, I will thank all the chairpersons. So for the next session, I'm going to call the chairpersons. Dr. H.U. Gargar, sir, please. Hey, Dr. Arshad. हाँ है वो तो आ गए यार एक प्रोफेसर ओजेश हसन जा रहा है लाइव जा रहा है बट मैं तो ऑडियो ऑडियो कहाँ चल रहा है हेलो डॉक्टर विकास हकीम डॉक्टर साजिद बजाज गवर्नमेंट कॉलेज बारामूला डॉक्टर जाहिद रोहतर जीएमसी अनंतनाग छोड़ दो सो नाउ कम टू द क्वेश्चन दिस साइड ना तो वो क्वेश्चन दे देते हैं तब तक सो इसको थोड़ा नीचे कर दो यार स्ट्रेट कर दो ये पकड़ो ये दो दे दो सर छोड़ छोड़ दो ओवर टू द चेयर पर्सन टेक इट आउट have a timing take it out वो वहीं पे रहने दो उसको नीचे कर दो कौन है आपको ड्रिपिंग अलग से दे देंगे ना और ये है आपकी मार्किंग जो हमने करके हैं चल उठाओ उठाओ एक मिनट दे उठाओ ये उठाओ 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 अरे कार्ड देने यार क्या कर रहे हैं रहने के फिर किसी भी आ गया उधर से भी आ गया नहीं मैं तो फिर भी जाऊंगा मैं तो जाऊंगा यार मेरे को काम हाँ चलिए दो ये नीचे कर दो उधर सर उसका कितना बेटा छोड़ा सा हाथ लग गया मेरा तो ये कार्ड दे रहा है इसका मान सा जी
यूरो बैग खाली कर
चलो बेटे रखो इधर पकड़ इसको हाथ से पकड़ के रखो आगे आगे आगे
हाँ मैं दूसरा टिकट किया ना ये हाँ
एक मिनट
है ना बस है एक मिनट लो आप इसके पकड़ो इधर से मैं वो करता हूँ ठीक है सर इस टाइम मैं ही चलूंगा सब कुछ कर चलो अब दो नॉर्मल लाइन की बॉडीज अच्छा आपको कहाँ चाहिए बोले नहीं आपको चाहिए क्या कर आप कहाँ डालते हैं इधर उधर के फ्लैंक के नीचे इधर अच्छा ठीक है सो बैग नॉर्मल सैन ले दो बना के वही बना के दे देना यार ऐसे नॉर्मल सैन स्लिप रहेगी अंदर यार पीछे तरह
We are watching right now.
अपने एलिवेट के दे देना यार इसको बना के दे देना पैच
Dr. Ali,
क्या लिखो तो
doing right hemicolectomy coming direct to you from Fortune Small Palace.
which was down from PGN and other positions it's how up to the boy तो ना बस सब समझा ऐसे शांत बने तो देखिए क्वेश्चन कर दो कच कच अब सर आ जाना मैं कर देता हूँ मैं कर देता हूँ
I need to. Oh, bhai sir, please give me a water bottle. Oh, my. Our saline
बॉटल बैलेंस चाहिए कि करके दे दे कवर करके कवर किया मैंने अच्छा खाली नॉर्मल बॉटल दो
सर आप लाइन है तो वहां से क्या कहते
बंद करो तूने बंद किया ऑडियो ये बंद कर ऑडियो बंद कर पक्का
Student. ये विनोद पवार was speaking. He has a car, 1 crore. Trustee go.
That adrenals.
In London also.
This is Dr. Anil.
One person to injection.
Anil.
Don't run.
So,
पता ना बंद रहता नहीं
hello, Dr. Anil,
इससे क्या हाल है
OT2. Are we connected to OT2?
feel disgusted. Sometimes people have been
Huh? No, connection can. No, it is not connected. I mean, it is finished.
Give me a moment. Scanning for
Huh? ठीक हो सकता है उसको देख Dr. Anil, can you hear us? 32?
Right? Right? Can be more.
I think the audio is not connected. Audio is not connected. Yes, yes. Yes, we can hear you.
So we are sorry, I'm slides. So basically, we are now completed what we have to do is you can lead to that.
Okay. Yes, but the incision has to be made. So then you have to decide whether. But then you have to decide whether you do an intracorporeal or you do an extracorporeal anastomosis. Dr. Anil, how are you going to? What orders are you going to give in the post-operative period? Can you hear me now? Hello, hello.
Can we lead for
Uh, we'll just check. Just bear with us.
every?
Hello, Dr. Anil.
Yes.
Now this is Dr. Vikar here. I was hi, how are you? It was nice to see you operating. You handled the bulky tumor pretty well. So the order is going to be in the post-operative immediately. When are you going to start the orals and okay?
And then you already
Okay.
taking.
So how long does the patient usually stay with you?
3 days.
3 days. Okay.
One more is that. Hello, Victoria. Can we see?
Yes.
Yeah.
Hello.
Any questions from the audience regarding transporting to them? Neutral skills. Okay. आज जो बोलो 43 adrenalectomy was professional structure one will be ectomy, two will be transplant skills, while two will see gastric bypass skills. Okay, sir. Yeah. Hello.
Yes, you are audible. Yes, we are audible. Hello. Hello, Dr. Vikas. I can hear you. I'm Dr. Arshid. I can hear you. You're all. You're.
Participant present in OT pre. We have a female patient. She is around 45 years old female with no underlying significant medical comorbidity. She presented to us as case of the last. She has surgical history. She has been operated to mouth. Total abdominal hysterectomy has been done with bilateral calculoprectomy for serous adenoma. And she has undergone pre-history anesthesia. On examination, she has been abdominal scar. There is a defect around 3 to 4 centimeters with scar is positive. It's not like it's not like a CCT abdomen was done. That is showing a defect around 3 to 4 centimeters in the midline with light outstanding. So this is the CCT. You can see here a defect showing the CCT. Momentum likely is the vertex. And
Hello.
yeah, we are going to laparoscopic I got the
I got
for my professor.
There is no.
We are not getting the name for.
What's this?
We are not getting the details for today.
You are not getting video.
I think somebody wants. That's all. I don't. I think somebody wants.
Hello, Dr. Rifat. Yeah, we got the video now. Hello. Good afternoon, sir. You're online now, sir.
Afternoon to everybody. And welcome to work which has been done over the years by them. And we have been given the responsibility to monitor this patient out.
Yes, sir. You are audible, sir.
My earlier want to see the specific external
Yes.
patient it has been external
Thank
Good
you,
job.
doctor.
Very nice job, doc.
Can we have audio from OT3?
Thank you. Thank you. Good job. Hello.
Hello.
Can we have audio from OT3?
Don't. Table down. Table down.
Audio.
Huh?
Hello, Dr. Atri.
Huh?
Hello,
What was it?
Dr. Atri.
मेरे को बता दिया. Hello.
Hello, Dr. Atri.
Am I audible?
Dr. Atri, you are audible. Can you hear me?
Can you hear clearly?
The doctor. Dr. Atri, this is Dr. Vakar this side.
Dr. Prasad, thank you.
Wonder. Thank you very much, and it's wonderful to see you there in action. So, can you tell us something about this patient and
Sir, this who has the block and then after got secondly done. One secondly done from the line. Yeah.
okay?
The camera person is getting ready. So this patient has a BMI uh, 52 and she is hypertensive. I have requested Dr. Cancer, consultant of anesthesia here, helping us, and Dr. Luthra to play. Point.
Okay.
Whenever we go from common point, it is point.
Yes.
Uh,
We're getting the video.
Dr. Atri, can you hear me? Yes, Dr. Atri, can you tell us exactly where do you enter at the Palmer's point? What is your preference?
Yes. Farmers.
Video नहीं आ रहा. Video नहीं आ रहा.
Okay.
Right.
Okay. Yes.
Then
Transport.
Okay.
And we'll be using a 0 degree telescope.
Okay. Yes.
So this is the Johnson simple Excel tool. We use that optical. It has a glass room. So it has a glass room which helps us in separating the muscle layer. We'll be going layer by layer so that thing is moving, so that don't cause any imbalance inside the ground.
Okay. Yes. Yes.
In the top, it is very like an half centimeter above the line. Then we'll be pressing before.
You will make direct trocar entry, or you will make. Okay. Okay.
Quick venous needle.
Okay.
It has- will be locking and giving them a good just
Mm-hmm.
now then will be going to. So this is the return of the patient is support the patient. So this is the
It was actually nothing, this thing came.
Sign the work to only 4 people will do it. And otherwise,
This thing came as a surprise. We were not expecting.
yeah,
Hello? Hello?
Yes.
Hello? ये ऑन कर दीजिए ऑन है क्या? हेलो ऑडिटोरियम am I audible there?
all without being a
हेलो देखो फोन कर रहे हैं उनको ऑडिटोरियम मैसेज
Yes. We are listening. Yes.
yes hello
Oh yes. You are as clear as you always are.
thank you sir so we are here very busy so we have a patient for supine PCNL. This is male 46-year-old with no medical comorbidity. He presented to us bilateral flank pain 15 days back. There is no history of any fever, hematuria, or dysuria, lituria. And this patient on investigation was found to have a right kidney which grade second hydronephrosis secondary to a TEL MM calculus at the upper ureter. Okay. And can you see the CT? This is the CT of the patient. She is showing an inferior. This is a stone in the pelvis and in the upper ureter also.
Yes.
So
But sometimes we may not get uniform liquid because of adhesions. Yes.
मैं खाली वेट पर मैंने बोल दिया चलो हेलो
just hold on.
Hello. Yes, Dr. Abhijit.
Carlos Paul here. The they should
The video is not clear, but the voice is clear. I
hello
can we have the audience volume in shoot? Anyone from the inside? Otherwise, they will not leave me after.
Okay.
Who's doing it? Is Salim doing it? Yeah. Absolutely, Mark.
can we have the audio?
Hello auditorium
Can you connect to theater one again, please?
hello
Is it Dr. 3 operating? Hello? Theater 1?
yes am I audible I am
Can you connect us to Theater 1, please?
sure
3.
That's it. You know, the thing is state change. Yes, it will. So, I think so currently I puts connect. I promise it still because still this if it gets through we'll go to skins otherwise they also done it to each other. Also we have so 15, 16.5 and 21. 3 sir. 15,
So you will do a single step.
21. Yes,
Single step.
Connect here.
Hello. So would you like to interact directly or should I brief them about the case first? Hello. Ajit. Hello. कनेक्ट नहीं कर रहा डॉक्टर अत्री मुन्ना सिंह से बोल रहे हैं कनेक्ट नहीं कर रहा
Dr. Asli, we are not getting your video. It is there. Okay, now it's there. Right. Okay, fine.
Hello.
Yeah, now, under. What is the size of the defect that?
Hello.
4 centimeters.
Hello.
Any loss of the image? Okay.
Hello. What is that? Since I like that, hello.
Yes.
So this is, you see, where my unit gone. This is what we want that. So you bring that. Now I'm going to change my currency. Sorry.
Dr. Atri, I am Dr. Zargar speaking. I am happy to see you operating.
So nice of you, sir. I'm
You are not doing excellent job with this patient, but you are doing excellent job with others. You are very famous in Kashmir. I must compliment you. People are, Atri Saab, you are like a author. Means,
I am so thankful, sir. I'm being blessed. When I get compliments like this, recently, sir.
you are an author of Kashmir, fragrant.
Thank you so much, sir. I feel so humbled and blessed.
I also support my professor's view. I am Umar, and I have seen you operating, and we are unbiased people.
So nice of you also, please. These are awards for me.
We are devoid of cause, reason, and other things.
I think that
Whatever, whosoever does good work for people, by the people, they will be rewarded here also and after here also.
so nice of you.
So, but we know our community. Just by the way, making a bit lighter mood, Professor Zagar, he knows Professor S.N. Ahmed Shah,
Right.
who was the legend and God bless his soul, has passed away. He was my neighbor, next door neighbor.
Right.
In last 2 years of his life, he was a friend to me.
Okay.
So every evening, I used to go and sit with him because he was a friend of my father. So my father would ask only one thing: did you visit Professor S.N. Ahmed Shah? I had to say yes, otherwise he would scold me.
Right.
So I was sitting with him for some time in the evening,
Right.
and he told me only one thing. Good.
जो है ना jealousies, idiosyncrasies, जो चार कुल है हमारे मजहब में, kindly keep it hanging, especially once you grow faster. But remember one thing, Atri, I have been telling Nageshwar Reddy also the same thing. You understand what I say? I have told Jagannath, all of them, they know it. Passion is good. Passion brings you piety. Professor Zargar is a legend here. He will tell you what I am speaking. But remember one thing, passion should not become pathological.
So nice to meet you. I repeat, we are not born for, we are born for. And I presume the people and even expanding or the relationships have made it is not from
Hello. Yes, Dr. Atri, I think.
the Mr. Park has a white foundation.
Yes, sir.
And the sky was off along the side of the head. So, these are can begin to see the brilliant flash is very on the left side. Cameraman shaking from and
Sheriff. Me, or party.
I am not called on the Ali. Hello.
Can we have audio from OT1?
Hello.
OT1, we are doing an spine channel. Dr. Shafiq from Delhi. Max Hospital is operating. Can we have audio from OT1, please?
Yes, sir. Okay. Sir,
Dr. Mandir, you carry on.
yes, we have a case, say young male, 36-year-old with no medical comorbidity. He is having a stone disease, bilateral stone disease, and he had bilateral flank pain, and on investigation was found to have a right upper aortic stone with hydronephrosis, with stones in the calyces, the pelvis. So this patient is planned for a spine PCNL, and investigations are all within normal fluid care. Can you just focus on the CT? So this is the CT scan of the patient where you can see the dilated system on the right side with few stones in the secondary stones in the pelvis and a large stone impacted at the upper ureter near PUJ. So this we actually push back the stone into the renal pelvis, and now we are planning. Patient is pushing into it on the spine PCNL, and we will shortly just relay this this will be made by Dr. Shafiq. Any questions from the audience regarding the case?
Can you explain to the audience the difference between the prone and spine PCNL?
So here actually, as all of you know that since long the PCNL standard PCNL with prone position is the gold standard, and even after doing in 1960s this spine PCNL came, but it came recently in again it flushed one. So you as you know that there are patients which are like very obese, and those patients, especially with comorbidities and history, in these patients actually position is a very important issue, which is not patient were not able to undergo such procedures. By doing this, this spine procedure became popular recently. And can you see
Final question, we can you cameraman show this to the patient, please?
Put one like this, another like this, है ना? इसको cover करोगे या ऐसे डाल दो, उसके एक डाल दो. Okay. मंजू मेरा शायद फोन बज रहा है. Just take it out and keep it with you, है ना? हाँ. Hello. मुझे साउंड कहाँ से आएगा? इसको बंद करो सर. डॉक्टर इकबाल, इसको बंद करो प्लीज. Yes, doctor. There is a compliment for you. Yes. Dr. O.J. Shah is saying that you look like Virat Kohli today. Your volume is dropping, Dr. Iqbal. Will you put it? Yeah, now it's okay. अभी आप ही है ना कैमरामैन, आपके साथ कौन है? आप ही अकेले? अच्छा, yeah. So what is the okay. Hello? Hello? Hello?
हम लोगों ने शिफ्ट करेंगे ना वहां से.
Oh.
यहाँ से कुछ नहीं हो रहा है, वहां से वो शिफ्ट करेंगे.
Okay.
कैमरामैन क्या करना है उसको?
नहीं उसको अभी तो I'll just introduce first.
Yes.
Okay, then I would like to show the position of the patient. Okay. So obviously your camera has to move around. ऐसे आएगा and will show what is the position. And then we will show the instruments. Okay. After the instruments, then we will start the case. So in the case there are surface view and there is a fluoroscopic view. So you have to show then according. I don't know. We have one single camera. How will show the both sync? ऐसे और ऐसे कैसे दिखाएंगे हम लोग?
कैमरामैन इस साइड आएगा तो तब दिखाएगा. पंक्चर भी दिखेगा और पोजीशन भी उसी.
Let him be here only. Let him be here only. अभी आपको ना मैं पहले समझाता हूँ कि what is the actual है ना please. So सबसे पहले मैं तो पोजीशन एक्सप्लेन करूंगा. So ये सरफेस व्यू
अलग है. उसका कैमरा भी है ना. क्लोज करो. एक मिनट चल रहा है ना वहाँ. वो भी क्लोज करोगे.
ऑन क्या वो बाद में करेंगे. नहीं वो बाद में करेंगे हम लोग. लेट हिम एक मिनट दोस्त. एक मिनट रुक जाओ. पकड़ो इसका कनेक्टर लगाओ. कनेक्टर प्लीज. उल्टा क्यों लग रहा है? अभी इसके ऊपर कुछ डालो यार. पाँव दिख रहा है. एक मिनट. थैंक यू वेरी मच. मेरे को ना सीजर दे दो. गिव मी अ सीजर प्लीज. Can we have the audio for both one please? इसको एक ना वो ले लो. एक ना Can we have audio from both one? इससे लगा दो. I think we are connected to skills. So, skills is audible or not? Sir, sorry for the interruption, sir.
Hello, so the permission of the chairpersons, I have insisted to make hello, I want to felicitate Dr. Emil Guru because he has to leave early. So I request Professor Odisha to kindly come on the stage and felicitate Dr. Anil Guru.
इसको लगाओ यार, एडेसिव लगाओ, ये नीचे पाओ, ठंडा हो जाएगा इसका यार। यार केस नहीं करना भाई, ये तो डेमोन्स्ट्रेशन प्लीज, है ना, होल्ड ऑन। क्या यार, वो मेरा स्टूल कहाँ गया? ओके ओके, हेलो, एम आई ऑडिबल प्लीज? हेलो हेलो हेलो, सीजर दो, हेलो
ना
यार करा दो, फोन आएगा।
Okay. Skills unaudible. Skills. Then, hello. Oh, we connect over. Nice. You want to audible?
Hello, am I audible? I am speaking from OT1. Hello, is there anybody? Hello.
Yes, sir. Hello.
Yeah. So, hello. Am I audible, please?
Yes, sir. You are audible, sir.
Yeah. Good afternoon to everyone.
Dr. Shruti. Yeah, Dr. Sajid here.
Dr. Sajid, good afternoon. Good afternoon.
Good afternoon. You are doing a spine PCNL.
Yes.
Can you explain to the audience what is the difference between the prone and spine in positioning the patient?
Yes.
And what advantage we have in spine PCNL?
Yeah. So if my cameraman can show us, the supine PCNL was a mental block for all the urologists, because the first time it was, reported by Dr. Valdivia in 1987. But over the years, at almost 2 to 3 decades, it didn't popularized as the prone was popularized. So if somebody can show me, the cameraman can show what exactly the position I choose, although there has been description of so many positions, starting from Valdivia, which was modified by Galdeco, and what I'm probably doing is a flank-free bar position. And this, the patient is basically just, shifted 15 degree slightly inclined towards the contralateral side. What we do is just to keep 2 500 ml bottles underneath the gluteal region of ipsilateral side, and 1 bottle under the scapula. So this gives me a 15 degree tilt of the patient to away from me. So if we had to do some simultaneous procedure from below, I have an access to get into the ureter via the ureteroscopy also. So this is the advantage which we do not have with the prone PCNL. So another advantage that, the prone PCNL is the most lateral most puncture to the kidney. So the bleeding complication where every surgeon is afraid of is very, very less. And what I have observed, because I have shifted from the prone PCNL to the supine, I feel that mastering the supine PCNL are way easier compared to the prone PCNL. If you can see our position right now, my ipsilateral leg is, slightly lower compared to the contralateral side. We can very well keep it very straight if we are not, intention to do any simultaneous procedure retrograde. So this is the frank-free position, and if the cameraman can show what are our landmarks for the puncture. Can you see the surface view, please? Dr. Sajid, can you see the surface view?
Can the cameraman come just behind you?
So, please, if you can show me, show to the audience.
Yeah.
Is it visible now?
Yeah.
See, whenever we had to plan our puncture, the first thing is most important are the landmarks and the position of the patient. That leads to a successful outcome always. So,
when we have to plan a puncture, we should know certain landmarks. And supine PCNL, the most important landmark is a posterior axillary line. We have to stay behind to the posterior axillary line all the time, because the reflection or white line of the told is exactly interior or just few millimeter at the axillary line. So our puncture should always remain behind. So here, if you can see, I have already marked the line. It's always important to mark the line when the patient is absolutely in the anatomically supine position, complete supine position. Otherwise, the axillary movement, the axilla, the interior and the posterior axilla will move, and we will actually put the patient into a 15-degree on the contralateral side. So the second important landmark is the 12th rib, because my working space will be between the 12th rib and the anterior superior spine or iliac crust. So the third mark will be the iliac crust. So the posteriorly, there are like your end-defined marks, but we always see whether I can actually, peep through to the posterior and see where my erector spinae muscle is, where is the lateral border. So this is where the area, this would be my working area. Although, there has been told that in supine PCNL, the working area, the maneuverability of the instruments is not as good as to the supine PCNL, but I don't think that is true, because you have enough space here to do the maneuverability of your instruments. So with this, I think we are ready for the puncture. If somebody, I can describe what I am going to use today. Since, as Dr. Manzoor described about the case, it was an upper ureteric stone, which was, badly impacted there. So while placing the ureter catheter, even we couldn't, opacify the system at all. So the guide wire was not going up. So what I did, I passed the ureteroscope and broken the stone with the help of laser, and I pushed back. And I'm very sure that my stones might have fallen into the inferior calyx. So I would probably, after opacifying the system, probably I may choose the inferior calyx.
Dr. Shafiq, was there any role of, can you have gone for an ultrasound guided puncture?
Yes, we could.
If the ureter was not going up, you could have gone for an ultrasound guided puncture.
Yes, that's the second way to salvage the situation. And in fact, we had a ultrasound intervention radiologist was on call, and he reached to the OT, and by the time he reached that the stone was already pushed back. So these are certain situations whenever the endourologist surgeon who is doing this sort of procedure, sometimes these upper ureteric stones are very tricky, and you must be aware if you stuck up somewhere, what is your second line of salvage way out. So of course ultrasound is one where we can go, or you can very well puncture blindly if the system is very dilated, and you can push some contrast. If you are lucky, then you probably can opacify the system and do your case.
Okay, Dr. Shafiq, you can proceed.
So I would for the audience, I would like to see the instruments which I am using, since the stone size was since the stone size is less than 2 centimeter.
Yes, Dr. Adri, we can hear you. Can bring the
Hello.
Yes. Then for the category old switching so yes. Right. Yes. You will store the figure. Yes. Then listen. Okay, okay. Take especially there will be time. Well, okay. Be back around. Okay. Okay.
Yeah.
Okay. Dr. Astri, you handled this adhesion absolutely wonderfully. I had to watch you doing this. It was it was that's absolutely what it's like. It is what you should done. Wonderfully done. We appreciate that.
Okay. थोड़ा सा वो कहाँ गए अपने सियाम वाले अच्छा अच्छा थोड़ा हम लोग नीचे कर सकेंगे इसको टेबल डाउन नहीं इसको वो करो हाइट करो नहीं रुको चेयर थोड़ा सा हो सकता है थोड़ा हो सकता है
थोड़ी देर आप ज्यादा
अच्छा लैग तो नहीं है लैग
इंटेंसिटी आने में थोड़ा सा टाइम
Can we have the hello?
Yeah, I'm comfortable. मेरे को अभी वो दे दो
After actually we are watching you, we will be shifting to OP1 for audio. We'll come back to you. Can we bring OP1 please?
Yeah, can you?
Yes, Dr. Shibri.
Yeah. So, my plan would be, if you can see my can we show the fluoro picture, please? So, are we having two cameras or one camera?
Dr. Shibri, can we have the PIP?
Yeah, so, I think we have only one camera in this, in the OT.
Okay.
So, I think this is my ureteric catheter, which is up, I believe, in the upper calyx. And there are certain shadows, if you can see, and this is one shadow.
Can we have a better view of this screen?
So, is it okay now?
Yeah, better.
So, the ureteric catheter is already placed up. I can see certain shadows there, radio opaque, but most probably this was a contrast leakage when we were manipulating the ureteric catheter while placing this. So, I feel that, I have already broken the stones. Most probably my stones are here in the inferior calyx. I would choose here to go through the inferior calyx after opacifying the system. The reason is my upper ureteric stones will fall in inferior, and if I had to, travel to the superior calyx, I would probably, succeed, because in supine PCNL, there is around 80% chances or even more that you can travel from inferior to the superior easily, contrary to the prone PCNL. So, with this, let's see whether my kidney is higher up or it is, well in my approach. I am injecting the contrast now. If we can see, so this is obviously in the inferior calyx. I would like to pull the ureteric catheter slightly below. Okay, so now I have pulled the ureteric catheter slightly below and want to opacify my rest of the system. Okay. लगाओ. Now you can see the inferior calyx is appearing in front of me, and this is a grossly dilated system. Okay, so give me the needle, please. So in supine PCNL, contrary to prone PCNL, we are working parallel to the flow. So let me place my needle, and this is my target calyx. Okay. If you can see the orientation of the C-arm, I always keep the spine straight in front of me where the original orientation of the kidney. So if I see, this would be probably my target of the calyx. So, Dr. Sajad?
Yeah. Yes, sir.
Do you agree with my plan here?
Yeah, it's okay. You have a ghastly directed system, lower calyx in front of you.
Yeah, that's fine. My only problem was that I couldn't actually locate where my stone would have. So my idea that it would have definitely fallen. So, if somebody can show where I will take a puncture. So please show where I will take a puncture. So I have taken straight towards the calyx. Absolutely head on to the calyx, inferior calyx. And how I will plan my puncture. So this is my posterior axillary line. So I had to work posterior to that. Now since I am slightly, below the 12th rib, if I will take my shorter part, then I will make my puncture from above the 12th rib. You can see I can enter into this also. But this puncture will go almost above the 11th rib.
Can we have the C-arm picture?
Please show the C-arm. You can see I am absolutely damn straight. This track will be shorter and straight into the inferior calyx. But I would avoid this because it's almost above the 11th rib. I am not scared of the 11th rib, but there is no necessary to land up in any complication. It's better that if I go inferior to the 12th rib, that is more safer. So this would be my approach. Okay, so can you please tilt it towards me because I have to puncture, and you can take your camera in this way. So with this, I have already placed my needle, which is looking absolutely straight. Now the idea is my C-arm is in the 0 degree. Okay, how you actually make the puncture? So that you deliberately go behind the kidney. So for going behind the kidney, I will probably tilt my needle facing more towards the floor. If I come from the floor slightly up, millimeter by millimeter, I would definitely be hitting or meeting my calyx of interest. Okay. So with this, let's make a puncture. So I never use a needle, and I have already seen the CT scan. My colon is way ahead. Now look at this. I am approaching the calyx, and my angle of my needle is more or less parallel to the floor. If you can see, the kidney is still moving. So probably I am not in line with the the calyx. So now I will deliberately go behind. So I tilted my angle and went behind. Now I will keep on moving my needle slightly if I see if my kidney is moving. It's still not moving. Now with this, I'll ask my technician to move the C-arm 30 degree towards the head. Please move. So looking on the fluoro, let's see where the needle will move. So it moved. Okay. थोड़ा नीचे लेके आइए. So it moves towards the head. It means that I am more posterior. Okay?
Yeah.
So now I will adjust my this thing, come back to the zero. This means that my kidney is slightly interior. So now let's opacify the system a little bit more, taking care that you should not land up in the extra position. I'm coming out, okay, and going slightly towards superior end. So go to the 30, please. There is some flickering in the C-arm, and okay, you please shift the C-arm slightly lower down. Okay. Well, Siddharth, have you noticed that this calyx is looking very lighter?
Yeah.
Compared to what I have contrast put in? Most probably this can be an interiorly line. Okay.
Exactly.
I may have to, change my plan. थोड़ा सा नीचे ले आइए इसको. Keep it to this thing. Yeah, keep it to this thing. Okay. So let me change it and see.
That should be. There's a question from the audience.
Yeah. Yeah, please. Give me one more needle. Give me a needle, and that should be a longer needle.
Dr. P?
Yes.
Sorry for the interruption.
Am I audible? Yeah.
Can we have the audio with OT3 for a while?
Sorry for the interruption, sir. We are blessed to have Professor Shaukat Jilani, sir, former head department of surgery, Government Medical College. Professor Nazir Salbu, sir, here in this on this auspicious of the conference. Thank you.
Can we have the audio with OT3, please? OT3? Dr. Atri? I know you. We have been watching you, Dr. Atri. We did not have your audio, but can you tell us you are using this particular suture with a double needle? Okay. This is a Swiss cheese defect, basically. Yeah. We always need to clone these defects in their smaller defects. Yeah, bigger ones, but I think yes, we could just put in a mesh and come on. Yeah. That's what I heard. 8 centimeters.
हाँ नहीं पंचर हो जाएगा बट आई हैव दिस नीडल वेरी वेरी स्ट्रॉन्ग नीडल है ना so I'm already in the system so हाँ प्रश्न ठीक है so I'm already in मैं already अंदर हूँ सिस्टम हाँ
Yes, that's true.
डॉक्टर सजाद हेलो
Sorry.
हेलो मंजूर
They know what to give. They know what to give to whom.
गर्मी बहुत get connected to us. डिस्कनेक्ट कर दिया तो पंक्चर दिया मैं क्या करूँ अब हाँ
तो हो गया ना कौन सी
वो नहीं तो गया क्यों
स्लाइड में डाल के रखिए
अरे नहीं तुम दिखाओ तो सही किया क्या हमने
हमने एडजस्टमेंट लेके घर में सीट पे वहां सफिशिएंट नो
अच्छा क्या गर्मी बहुत है यार यहाँ पे
तो हाँ चलो अगर तो गांव भी से गांव की सब
ये पसीना बहुत है, तो दूसरे किसी को बोल दो। हाँ आप हेलो, बस बस, ओके 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 ओके।
Yes. Yes, sir.
Yeah, true. आप इस मिश्रण में पानी डाल देना है ना, ठीक है?
ठीक है।
या डालो, पानी डालो।
Robotic suturing is very easy.
Can I push that normal side? Yeah, बस ठीक है। अबे यार दिखा दो यार।
ठीक है।
Yes. The dissection is too extensive in there. Dr. Atri, what is your pressure this time? Very. Okay, okay.
आ गया? हेलो। हाँ
फ्लो रेट बढ़ाओ।
Yes, yes, Dr. Atri.
अच्छा वो डॉक्टर अत्री के पास है। हाँ
Okay. On both sides. Yes.
कम पे बहुत।
I've Do you like it?
बराबर।
ठीक है। फिट है क्या? हमारा नॉर्मल जो वायर था वही दे दो।
वर्थ ज्यादा है।
वो वाला जो आपके पास वायर था ना वही दे दो। जो नहीं 3.5 का वायर था ना अभी आपके पास, वही दे दो। हेलो। अरे यार हाँ बस ठीक है, इट्स फाइन। यहाँ पे लगा दो इसको ना, जस्ट जस्ट हैंग इट हियर, हैंग इट हियर।
Yes, yes.
ये पर किस तरह निभा डालना? ठीक है। हाँ दिखते हैं तो हो गया, गट में तो हो गया। हाँ सोच पर
Sir, you are audible, sir.
Hello.
ठीक है।
Yeah. Hello. Yes, Dr. Atri. I think the audio is scheduled to the other one.
क्या हेलो? अरे दे दो यार, थक गया मैं अभी।
Yes, sir. Yes, can we have the increase of volume, please?
हेलो। Can somebody arrange the instrument? करो कैमरा रेडी करो, so we will just show the stone inside and let them go, then we'll finish up the case. Hello. इंस्ट्रूमेंट रेडी करो आप अपना कैमरा वैमरा का सब कुछ ना वाइट बैलेंस करके यू कैन कीप इट वेयर द वाटर इज ऑल हैंगिंग ना हेलो कैमरा
My camera is इसको निकालो टेक इट आउट कैमरा लगाया इधर से ठीक है
अब ये इसको ना आप 0 डिग्री में रखना at the time of dilatation we have to shift it towards slightly this because we have to know whether we are interior or posterior if there is any kink we can keep it straight साजिद बजाज कौन है Who's? The urologist. साजिद बजाज किधर प्रैक्टिस कर रहा है जानते होंगे कौन सा है अच्छा ओ साजिद है ओ मेरा वाला मोटू हाँ ऐसे बोलो ना मैं तो वैसे जानता हूँ सारे पर्टिकुलर नेम्स हैं हेलो साजिद है ना वो मैं सजाद बोल रहा है यार उसको बोल साजिद को क्या कर रहा है यार दिखा
कैमरा
हाँ यहाँ पे आप रख दो इसको वाइट बैलेंस वगैरह once I dilate then we should be having so Elkins है हमारे पास Elkin cannula है हमारे पास वो है सर नहीं Elkin cannula चाहिए होगा सेफ्टी वायर के लिए हेलो डॉक्टर साजिद हेलो 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 डॉक्टर साजिद हेलो
Can we have audio from OT1?
Yeah, Dr. Sajid, can you hear me now?
Yeah, Dr. Speak.
So, we line got cut. So, I have already reached to the inferior calyx. Now, I would like to show what is the lie of my needle here. Please, my cameraman, can you please show me the surface view, please? So, first you can see I am inside the calyx, in the inferior calyx, absolutely through the papilla. With a straight angle. Now, can you show the surface? Now, look at the, the lie of the needle. So, in supine PCNL, when your puncture is correct, it is always parallel to the floor. Neither it is deflecting down, nor it is deflecting up towards the ceiling. So, when you are learner, you should always come from behind and go interiorly. So, you will definitely meet your calyx somewhere on the way. So never go interiorly because if you go interiorly, suppose in a thin and lean patient or the patient who is chronically constipated, you may end up, touching the colon with if the colon loops are dilated. So always the safer is to go from behind and come interiorly. But mind it that you will always meet your calyx somewhere in the horizontal line. So that's why when you are reaching the calyx, you always see that there is a dimpling of calyx when you are entering into the calyx. So with the experience, most of the surgeons, they rather avoid puncturing multiple times coming from above and going to their target. So they keep their needle absolutely straight and then adjust the C-arm into the 30 degree. So while we are adjusting the 30 degree C-arm, it means that if the needle is moving up towards the head, you are under or behind the calyx. If the needle is moving towards the legs, towards the feet, that means your angle is more superior, you are interior to the calyx. Can you please, can you stop talking please? So the calyx is, that means your needle is interior to the calyx. Now my needle is
One, it is totally parallel to the floor. Another, it is actually pointing towards the contralateral shoulder when I'm approaching the inferior calyx. So with this, I will now try to put my wire. This one, I'm down in the posterior calyx. This wire should definitely go into the ureter. So that would be my ideal situation. Okay.
Dr. Big, there was a question from the audience.
So can you see the flow is absolutely clear, and that means it's in a free flow and atraumatic.
Yeah, we can appreciate it.
Yeah. So now I will take the question. Let me pick the wire. Let me pick the wire and see. Can you show the? So there is some issue in the camera. Okay. So my wire has actually gone to the superior calyx, unlike what I would have liked. But if I pass my guide wire either in the superior calyx or in the ureter, that would be a sufficient, anchoring for me. The thermo guide wires are very, very slippery, so one should pass the wires. Keep it in the center. Keep it in the center, please. थोड़ा और ऊपर चले जाइए. Yeah. Okay, so the wire has actually coiled. Let me coil it here only. I'm, thinking that probably this will give me a sufficient anchoring. So, to make the stab incision, I always keep my this initial puncture needle there so that I will not graze my guide wire. Okay, so that's
Dr. Vic, you are always using thermo or you use any other guide wire?
Always thermo, because this is the most atraumatic and slippery guide wire. It will definitely slip over most of the time. It's very difficult when the calyx is packed with the stone. It is very difficult for any other guide wire to slip either under the stones or over the stones. So only the slippery guide wires, these are the water-loving guide wires. So they are the guide wires which will slip, either from the side of the stones and give you the good anchoring. So, the problem in supine PCNL, the kidney is very much mobile. That's the main problem. So when we are dilating, we have to keep the C-arm slightly in the 30 degree or not even in the 15 degree. This will give you idea whether you are kicking the guide wire somewhere or not. So, the first thing I put is the facial dilator, because those are slightly sharper, very, malleable type, very flexible. They will not kink the guide wire. They will not graze the guide wire. Probably they'll take the course of the guide wire and enter into the PCS. So while dilating, you can always, push some contrast from below to opacify the system and see, can we have contrast in this, please? So I'm using 8 French. This is how much? I think this is an 8 French facial dilator first. And then if I have an Elkin cannula, I will go over the Elkin cannula. So please hold it here. Please hold it here. Yeah. So your assistant has to be very careful to dealing with the thermo guide wires, because when they will slip, nobody knows. Put a contrast please inside. So with the screw movement, never push it. With the screw movement, you go and reach to your calyx. So I would request, these C-arms should also be changed, because probably they are very old C-arms. There are a lot of flickering, and the images are not as it should be. I have placed my initial facial dilator into the inferior calyx, and I think they are giving me, what is the size of this now? What is the size?
It's 10.
This is 10. So do we have Elkin cannula? They are giving Elkin cannula, please. Elkin cannula. Okay. Brother, can you give me that? You don't know even the cannula. Give me this thing. आप दे दीजिए, वही दे दीजिए. Okay. So Sajad, what was the question there? This is rod. What you are giving me? Sajad, hello. Dr. Sajid.
Yeah. We are hearing you.
Yeah. What was the question? Any question? Any doubt? So I was telling that the kidney and supine PCNL is very mobile. Now, how to deal with that? The first thing is, hold this here, hold this, don't pull the guider. So the first thing is to use your facial dilator, and with the screw movement you enter into your system. Okay? And without pushing. The second thing is,
You are handling, sir. Yes, Dr. Atri.
hello?
Dr. Atri, you have closed the defect so nicely. I mean, yes.
इसको थोड़ा और कर सकते हैं क्या?
Yes, yes. Yes, yes.
So brother, you have to hold it here.
Yeah. Okay.
Okay, yeah, so that the wire should not come up. Please don't be stiff your hands at your hands. Yeah, don't be stiff at your hands. Don't be stiff at your hands.
Okay.
इसको थोड़ा सा Okay.
Yes.
Initial dilator, please.
Right.
Initial dilator.
First time. Transfacial sutures. Okay. Okay. Okay.
आप ट्रॉली पे ले आइए वो ट्रॉली के आप दे दो वो एलिफेंट्स वाले ना सो वी आर नाउ ऑफलाइन गिव मी द इनिशियल डायलेटर हाँ दे दो ये दो
Okay.
Okay. 30 है आप 30 कर लीजिए थोड़ा सा नी में सेंटर ओके ओके लॉट ऑफ फ्लिकरिंग पानी डाल दो आप
Okay.
पानी डाल दो
Do you use absorbable trackers or you use? Okay. Okay.
ओके इधर सिस्टम में ना काफी वो है सक्शन मिलेगा ना हमको
Okay. Okay. Right.
So never ever leave the wires from your hand. Never ever. If you leave the wire ना होगा उसमें आ जाएगा.
Designation for closing depends because we will be compromising the vascular.
So we इसमें ना single देते होगा. ये उसका वर्ड मिला ना. जो पहले दिया था वो अलग रख लो. ये सबसे ये मीडियम वाला है ना ये निकल रहा है ना हाँ ठीक है
Right.
अभी पानी मेरे हाथ में दे हाँ आप वो दे दो अभी लास्ट वाला छोड़ दे हाँ the wire did not go through
Right. Yes.
इधर लिखा एडिवेटेड
yes
Yes.
ओके
bye
Dr. Atri, Dr. K.C. Sharma wants to ask you what are he
हाँ
नाइफ दे देना नाइफ प्लीज
Yes, there's always something to learn from him.
yes.
He wants to ask you what is the mesh which you are using.
कंट्रास्ट डालो इसमें।
हेड से ही करना पड़ेगा। ये पैर करूँगा, ये मेरा प्ले हो, ऐसे भी कर सकते हैं।
शीट, इसके ऊपर शीट दे दो।
हो गया
शीट प्लीज।
शीट
ऐसे पकड़ो हाथ से।
हाँ यही वाला आपका। हाँ यही।
फोल्ड इट हैंड। यस
हमारे पानी में इससे जाते हैं। सो नाउ वी विल टेक, दे दो।
यस
हेलो कनेक्ट कर लो यार। हेलो 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 ऑडिटोरियम।
ओके,
Mic is there.
अब पानी डालो।
ऑडिटोरियम हेलो
Normal size.
सलाइन डालो।
Size.
अच्छा
Normal size.
ओके
डालो।
तो सब ठीक पकड़।
Got the medicine.
ओके, इसको आप इधर रखो। कीप फ्लशिंग, इसको ये रखो। अब इसमें लगा दो। ये इसमें लगा दो, वायर लगा दो, लगा दो।
दिखाओ दिखाओ कौन तुम।
अभी मेरे को बकेट चाहिए होगा। अच्छा अच्छा, ओके ओके, यू कैन गिव मी दिस। या दैट्स परफेक्ट, दैट्स परफेक्ट। अभी नीचे में बकेट रखा हुआ है क्या?
हेलो
इसको थोड़ा सा पीछे ले लो। हाँ, इसको पीछे ले लो। लाइट लगा हुआ है? अच्छा,
सब पीछे से चेयर ले ली वो।
हाँ कोई बात नहीं, बैठो। नॉट सेट।
Can we have the audio from Institute? Transplant is going on. The transplant is coming. Hello?
नीचे बकेट लगा के।
अच्छा, लगाया ना?
Hello, sir.
हेलो
Hello, sir.
हेलो
Hello. Hello, sir. Yeah. Sir, let's go, sir. You're audible in the audio time. The surgery is going on, sir. Please continue, sir. What is that?
Little plus on it. Ready?
चलो देखो, नीचे क्लास लोगे।
Look at last. So this is the photo.
या
हेलो हेलो Well, I just started doing the right lap adrenalectomy for a 4 centimeter myelomicron on the right side.
को बोला हाँ दो।
This
स्टोन दिखा दो।
this is the floor of adrenal myelomicron.
our procedure।
This is the superior wing of the scrotum, and you see these adrenal tumors tend to get deep into the nerve. Yes, now try to move the plan is
Sir, no. Sir, Dr. Sajid here. We were watching you from the bench, friends with after the when you were in smoke, but unfortunately, audio was not good, sir.
Thank you.
We have like nice anesthesia. You are, sir, about to.
Anesthesia पास है।
I'm Dr. Omar. Hi, how are you? All well? I'm sorry we could not connect you audibly, but visually we have been persistently watching you. I can. Yeah.
Be that way. I think only thing what I want to say, because as an professional working in that OT for more than 3 decades,
I'm trying to say,
you so that as
coverage.
no,
Can you
what we have achieved is
superior
from both
this is the point.
There
Yes, small
we wish them well. And we wish public well. The only thing what I observe is that you have a good team separate there. I'm team two in future six lines.
Is the cloud also?
You must encourage the youngsters.
Suction entrance play, but I need also so. Entrance dilatation. Construction बना I'm going to like that. मेरे को लगता है हाँ ये
Doesn't matter. Doesn't matter. You
Would you pick?
बस कनेक्ट करके तो स्टोन दिखाते फिर
Yeah.
I will call Manzoor sir. सर देखिए अल्किन्स पे आती है
Hello.
हेलो हेलो
आ गया होगा
हाँ ये
Hello, auditorium. Hello.
करिए
Auditorium is there. Anybody who can hear me? Go there. नहीं ब्लॉक हो गया
got a, you have got a class from the audience for that. All audience here is packed auditorium today, and they are all clapping at your feet what you have done, and we can see the urine flowing like a stream right now. What I say is that I doesn't keep a calendar. Nobody knows what's going to happen tomorrow. Speak going to the next generation, and speak now forever. We have the Dr. Mansoor Dar with us today. He was away for almost 30 years. He was doing the renal transplantation institute. I remember he got a professor from Tajammu. Tajammu is in the United States. Massive. Massive. Anyway, they did that time. But you carried on the legacy. Let me congratulate you today. You have brought more than 800 renal transplant, and I'm a witness to each and every transplant what you have done. Great job, well done.
Hello, am I audible in the auditorium? Hello.
Yes, Salim, go ahead now.
मेरे को लिथो क्लास दो
Little class?
Sorry.
Yeah.
So let's close the course.
Now we are waiting you. We didn't have this audio, but
ये होती क्या
not the audio. Now, no.
इसमें डाल दो
वहाँ से प्लीज हेल्प कर
Yes.
Just go. You snag that message. मेरे को वो दे दो फुट पेडल दे दो हेलो साजिद है कोई ओके
अभी आ जाएगा काम ना करने
फुट पेडल रेडी है
रेडी ना मेरे को में कुछ नहीं रहा मेरे को which one
राइट
ये वाला which one need sure
So should I hold it so that you can?
Yes, yes. Oh, it is biomarker. Okay. Yes, Sunil.
Good.
Salim, you have been you have got master hands now, I can see. But you have a giant in front of you, cirrhosis liver, I can see. And to do any surgery in such a patient demands a lot of what you call it as expertise, and you should have a big heart. And patients are prone to complications. Can you comment on that? Dr. Iqbal?
Hello, Dr. Bakar?
Yes, Doctor. Hello, Dr. Mufti?
Yes.
Yes, now we have your audio and we are watching you.
Well, thank you very much.
This is going wonderfully. I mean, control dissection.
You can see the tumor here.
Yeah.
This hump is the tumor. I have already made a pain between the liver and the tumor superiorly.
Yes.
I am dissecting medially. This is the IVC, as you can see.
Yeah.
I anticipate the vein to be somewhere here.
Okay.
And this is the medial part of the dissection. And then I have made a plane between the upper pole of the kidney and the adrenal tumor.
Right.
This is it.
Okay.
So I'm going to this plane. So this is it. This is the plane.
Okay. Yes, it's going very. We have been watching you. We didn't have your audio, but very clean and controlled. Dr. Bhasti,
yes, sir.
What tumor preoperatively you have diagnosed this as?
This is a myelolipoma, 4 centimeter in size. This patient was under our follow-up for the last 2 years. And of late, last 6 months, he has been complaining of pain upper abdomen and assessing the serial CTs for the last 2 years. We found that there was a progressively increase in the size of the lesion by around 1.5 centimeters for the last 1 year. So we decided to go in and remove the lesion. The complete evaluation has been done and this has been found to be a
non-secretory.
Is it soft and
You are lucky to have
you get a catch again. You get a
athletic team deserves applause. Whenever you do an analytical for tumor, it is the anesthetist and his team which manages the show. I remember Professor Wani, late Dr. Nazir Wani, doing adrenals way back in 86, 85. We used to do chromocytomas with Professor Merajuddin and his team assisting him in the anesthesia side.
Okay.
And we used to have fluctuations of blood pressure. We used to.
Why are you
Respect.
We could do here.
At the end of the day, once the veins and other tissues, you used to have follow BP.
Well, I have the anesthesia team here. For me, no problem with hemodynamics because this is a non-secretory tumor. And well, if there are any changes, I don't see any changes on the monitor. But Dr. Umeed is a better person to issues. Dr. Umeed, there is a question from the audience that do you anticipate any changes in this interruption? This is the close of the session. I thank all the chairpersons. This is valuable time. I request Professor Shakil sir and Dr. Laviam Salmo to come up the stage and felicitate our 20 chairpersons. Sir, please.
नीचे ले लो इधर में ले लो कर लेगा. Okay. All right. So इसको पकड़ो. Okay. रख दो उधर. रख दो कोई बात. Let me go language. Just लगा देते.
That.
Professor Verga, sir, please, sir.
Force दे देंगे क्या?
Force up.
So, and this is the IVCU. Can you see the IVCU here?
Force दे दो. Section लिया ना ब्रदर? Section. Okay. Section is ready. करो. फोर्स दे दो. ये फोर्स जाता है इसमें? ओके. नहीं जाओ.
I would like to call the chairperson for our next session. Professor Shaukat Jilani, ex-head Department of Surgery. Professor Naveed Ahmed Sagu, sir. Dr. Rahul. Dr. Umar Salim. Dr. Ashif Hussain.
ये करो ऊपर. Going.
लो.
नीचे क्लास.
नहीं ये दे दो. फोर्स दे दो.
Professor Shakil, sir.
Hello.
Professor Shakil Ahmed, sir. Kindly take the chairperson.
Hello.
Over to the chairperson, sir.
Hello.
Mess of
Hello.
Hello.
Salgu here.
Good morning, Dr. Silver.
Welcome, sir. We have been watching your surgery.
Sir,
Very nicely done. Very nicely done.
I am privileged.
I have to ask, should have we close those big defects like that? Always close them, or we can keep them open. Right, sir. Right, sir.
You are going to regulate this.
Such a section.
Very usual.
Very nice. Very nice.
Going.
Defect,
ये वाला फोर्स है क्या उसको हमारे?
and the mesh there is here. Very nicely done. Very nicely done.
Go ahead.
Normal just करनी है उसको.
बैच में पता क्या होता है? सो डेमोन्स्ट्रेशन के लिए आप अगर बोलते हो तो इट हैज टू बी समान भी होना चाहिए. दो इधर फोर्स दो. मंजूर वो अपना वो है क्या we have stores वालों का है forceps? स्टोर्स वालों का forceps है क्या?
Forceps stop करूंगा. Can we only to play? Forceps. Dr. Iqbal?
Part of it, no?
Dr. Iqbal?
Yeah. Yeah. What about this?
Dr. Iqbal?
What is this? Okay. How many? Services.
Hey, Dr. Iqbal? Yes, yes, yes. Okay. Okay. How much of stomach you are going to leave? Okay, how will you the capacity of that pouch you are leaving? Okay.
डॉक्टर सलीम हेलो मैं डॉक्टर सलरू बोल रहा हूँ हेलो सलाम कैसे आप ठीक है सो नाइस इट इज नाइस टू वॉच यू वेरी नाइस सेक्शन it is flawless no bleeding anywhere are you going to suture any bleeder there if at all there is a bleeder after removing of the stapler okay she must be a high risk patient with a cirrhotic liver and you had a lot of adhesions to break because of previous cholecystectomy. Yes, it was nicely done. Okay.
क्या हुआ? Go on.
Dr. Iqbal? Hello.
Huh?
Dr. Iqbal, can you hear us?
Yes, we can hear you.
Okay.
Hello. Yes, you're audible. Dr. Atri. Very nicely done. Everybody is happy with the procedure and they have applause for you with claps. Very nicely done. Thank you. So nice. Thank you. No question from audience now. We are satisfied with the technique.
Hello.
Thank you. Yes, sir. Yes. We could see a nice pouch made by you. It is about, what is the capacity of pouch now? Yeah.
Hello. Auditorium. Hello.
Yes, hello.
Dr. Mufti.
Yes, can you?
I'm Dr. Salru here. Okay.
Sir.
So nice.
Nice to see you there.
So nice. So we can watch you very nicely. You made a nice plane between the liver and the kidney. You are doing a tumor nephrectomy. What is this procedure? Okay.
This is the tumor and this is the upper pole of the kidney.
Yes, very right.
So I am going in the cleavage
Between the tumor and
upper pole, sir.
yes, sir. Yes. So we could understand. We could see that. Tumor is well separated from the kidney.
Yes, sir.
Yes, without bleeding, flawless. Very nice.
Dr. Mahmood?
Yes.
Assalamu alaikum, Dr. Shakil.
Walaikum salam, sir.
I see some greenish discoloration there.
This is the setting of the system. They want to show us that the system can differentiate between the fat planes and the other tissue planes. I am using a 4K system and they have made the setting so that the fat can be delineated more clearly.
Okay. Have you clamped the vessels?
I have identified the vein that is still there. I am just mobilizing a little bit so that I can push the tumor away from the IVC and try to get a plane between the IVC and the tumor.
Okay.
The essential part of dissection is section in close proximity to the IVC. So the more space you create between the tumor and the IVC, the safer is the plane of dissection.
So just one question I want to ask is for the beginners, how do you avoid the injury to the right renal vein? Because the way you are dissecting, the vein should be around there, only the upper margin.
Well, I am anticipating the vein somewhere here.
Yeah, that is what I'm saying. How do you avoid injury? Because if that happens, then it's a bit of tricky situation. It becomes bigger.
Well, there are two ways. Either the vein is avoiding me or I'm avoiding me. Well, to answer your question, I'm very close to the ground.
That is the point. Tumor.
That is very technical. You can see why and what in the closure safely and every person that is person.
Correct. Sometimes what I do is I just delineate the vein on that side and be very sure that you are not dissecting the vein. Because the good point is that hardly there are any adhesions there. So you can just take down that part of the vein and be very sure that you can always readjust yourself and see the vein constantly. Reorient yourself. Yeah. Upper muscle.
Actually, my take on this is that we should try to create the space all around. And that way you will be able to see any applied vessels passing plus any abnormal anatomy you can identify. Because if you try to in a only pores of the vessels and sort of temperature. And try to create a space. So this is not a very big tumor.
Sir, you are not using a fourth port here. If you put a fourth port and ask your assistant to.
I have a fourth port that is retracting the liver.
But this time, since the point of dissection is on the kidney and the liver is not in the view as of now, so you can, with your left hand, you can become free. Ask your assistant to put the grasper there and put the kidney down. So you'll have two hands to dissect. That will make your life slightly easier.
I'll do that.
But if you're comfortable, it's fine.
Sir, it is Dr. Ashok San here, sir. Sir, in your case, I feel the tumor is extending more medially, and that's why you are pushing the tumor slightly lateral. Otherwise, in any situation where the tumor is a bit lateral, is it wise that we go to the vascular pedicle first and control it, and after that mobilize the tumor?
See, as far as adrenal is concerned, depends upon what pathology you are doing. Suppose you have a photodermocytoma, the point of handling is going to disturb the dynamics and to sweat all around. So in those cases, we tend to really handle on the brain. So we try to first address the pain so that we are able to the hormones of the patient. When tumors are concerned, issues are not when this is and this is the vein, this is the IVC. See, this is the IVC. And this is the margin of the adrenal. See, space. And sometimes you have extra vein. That's it. So you have to be very careful in that account. Why it's stated by you. So all depends upon what sort of a dissection contemplating.
Yes, sir. Sir, like we do it in laparoscopic radical nephrectomy or a lap partial nephrectomy, we make two windows, just one window below the on the inferior side of the hilum and one window on the superior side of the hilum, so that we have complete control of the hilum. Is it so much, is it such any type of recommendation in case of lap adrenal that you make two windows, one above and one below?
See, in adrenal, you have only one issue. That is the vein. And if you do extra dissection around the vein, so it's better to create a plane and apply clips, and then you are safely sailing through. As far as radical nephrectomy is concerned, you need to have a three-dimensional view of the hilum. That way you can very safely address the hilum. Because if you go while the kidney is lying down in the stage, down the wall, and you can't just closely and some segments still do that, they try to look out for the T and D. And in the process, they sometimes enjoy testimony, but I'm not able to see it. So, in a surgical procedure, the best part is must be able to see the structures. And if you are able to,
Yeah, actually, Professor Mufti is speaking.
if you are able to see the structures very clearly around, you'll be able to control them.
Hello, yes, please go ahead.
I also do superior and inferior
Actually,
hilar windows. I also do the same technique. I feel safer with that. But in again, this should be shown together.
can we OT2 please? OT2. Hello, yes, please go ahead. Yes, sir. Which instrument are you using this time? Okay.
So, what you can do? Score see this way.
Slight traction. Hold it. Hold. Yes, please go ahead. Okay. Yes, we can see nicely. Okay. Yes, please. Okay.
Dr. Salim? Hello. I say, what is the experience about gastric bypass? Did you do some cases? Yes. It is sleeve or gastric bypass? Oh, sorry, I didn't watch from start. Yes, you left the pouch out. Okay. Very right. Sleeve.
पीछे में कुछ नहीं कर रहे
Dr. Salim? Hello?
Dr. Salim? Okay. Okay.
Professor Mufti Mahmood.
Yes.
Shift. Please shift to OT1 audio. OT1.
Yes, sir.
Professor Mufti Mahmood, am I audible?
Yeah. I can hear you.
Sir, this is Omar Salim. I'm a urologist, sir, one of your students.
Welcome there. Welcome.
I'm taking full advantage of being on neutral ground. And I just wanted to compliment the whole team. And I would like to just recommend that next year we change the name, make this an annual affair and call it the Srinagar Surgical Festival. Because basically we are having a festival of surgeries here, all types and all kinds of surgeries. And I think it's a wonderful day for the college and for the team and for the department. Dr. Ashik and me were sharing a thought on the dissection of the adrenal gland, and I remember that the principle that we were taught was that in adrenal surgery we dissect the body of the adrenal, and I think that that's what you're demonstrating very well. Rather than dissecting the adrenal from the body, we dissect the body from the adrenal, and I think that's what's being shown here very clearly, sir. Thank you.
Thank you very much for your comments. Your suggestions are well taken. We are the future of urology here. Probably future. And we are just trying to sensitize our future generation to the challenges ahead and offering some sort of facilitating the sort of we are only skilled. I have no doubt about that, but we are only facilitating, trying to create a platform where you can demonstrate skills, where you can show your and these are the ideal platforms we want to show rather than showing it on social media and Facebook. I am fully against you and please be please take active deliberations and think of us and help us as well.
Thank you, sir.
Sir, I would like to just add a point that whenever we talk of adrenal, everybody says go to the adrenal vein first. My take on this is that since we were taught these things, it was an era of open surgery. Now the things have gone from open surgery to laparoscopic surgery. That there is a lot of difference in the position we are operating adrenal in laparoscopic surgery vis-a-vis open surgery. In open surgery, the things were quite in hand. You could go directly on the vein, dissect and pick it up. But if you try to do the same in laparoscopic surgery, you are inviting trouble. And I'll tell you why. Because there is hardly any space where the adrenal vein is anatomically. There is a liver which is coming on you in when the patient is breathing on a ventilator. And the adrenal tumors are not perfectly solid tumors. They are solid cystic tumors. So you can't reflect them like you reflect the kidney, where you just try to shift the kidney away. So it is always sensible to dissect infero-medially on the part of the adrenal. And then I use the word climb on it. You just climb on the IVC slowly and slowly till you find the adrenal vein. Because
we have already found the adrenal somewhere.
Not yours, sir. Otherwise, see, if you look at the adrenal vein where you are now, and you just imagine you are trying to look for it without dissecting or lifting the adrenal gland, I'm really skeptical if you are able to find the adrenal vein like that. So if you have mobilized the adrenal like what you are doing adequately, that infero-medially you're lifting it from the diaphragmatic fibers and just climbing up, there will be adrenal vein sitting there and you just take it and that's all you have to do. But if you try to take it directly, you search for adrenal vein, then I feel that in laparoscopic surgery, you are inviting trouble in that case.
Absolutely. Fully agreed.
And sir, since we are living in the medical legal eras, what is your take on kidney injury? Do you take a consent for that for patients?
Regarding
Just incidental, just a passing reference because
that's more important than anything else.
This is for all the people who are
most important thing one should take before entering into any kind of surgery. In fact, there should be a transparency with the patient attendance. I think that's possible and all incident events must be explained to him. Still, but we tend to hold this back. We tend to sort of receive many times hearing that this patient might run away from us.
Had you try the EMS instrument? मैं irritate हो.
Hello.
चलो.
Hello, GOT2.
Hello, Dr. Shakil.
Ajay.
Are you getting me?
Yeah. Another Salim.
I'll just show you that we have detached the remnant stomach.
Yes.
Okay. Since you are not giving me time, I'm having to repeat the steps. Okay. So it's fully detached, right?
Yes.
And there's a bougie in the pouch. Now I'm going down. Can you see the colon?
Yes.
This is the TC. I'm lifting it. Hello, Dr. Shakil.
Where?
Are you able to get me?
Yes, please go ahead.
Okay, hold this. All right, give me the instrument. Now, there's a loop there, loop of intestine. I want to go to the DJ.
Yes.
Okay.
Okay.
I want to go to the DJ.
Okay.
And the patient is obviously nicely chosen by Sir. He keeps all the difficult cases for the conference.
Dr. Salim.
Yes, sir.
How far away from the DJ you will do the anastomosis?
Sir, first let me get to the DJ, then I'll show you.
Okay.
Suction. Security, huh? Okay, can you see the DJ now?
Yes.
Hello?
Yes, we can see.
Clearly.
Yeah.
Okay, so I'm going to follow this loop.
Slide. बस हो गया ग्रीन है ना
मंजूर दिखा दे यार जो ये PCNL तो मेरे को याद है जिंदगी में
लिवर ऊपर रखो.
So this is the loop of DJ, right? So this is 10 centimeter.
No.
कभी नहीं रखता हूँ.
I have it's not okay. This is now I'm vowels to you, sir. But sir, I have observed from police what I have 10 patients out of 10, 7.
At the same time, I'm shifting.
Yes, sir. I'm not general, but I don't know why, sir.
O positive.
Ji, sir. And 90%. Lekin machine.
Yes, because
software.
40.
Last time on the same game.
सर सीटी फिर उसके बाद कराया बाकी चीजें
it never happens. I do this procedure till आंख बंद करके. I don't know, there's a lot of many things you are new to this scenario. Instruments पता नहीं होता है. And there are so many things. मंजूर?
So 40.
Hello.
Please connect it.
50. 60. 70. 80. At the same time, I'm putting it in the left hydrogen drain.
Okay.
90. 100. Okay, gross value century is complete. But I'll not stop there. 110.
I could make out right.
120.
Sometimes
113.
injure the colon, then we have to put it in nephrostomy like that so that it gets for that.
Yeah. I injured once. Managed on table.
160.
also. And play.
150.
Tube in the colon, another in the PCS.
So I'm leaving the
That's it.
rest. We had to be a common challenge thing. Leave it now. Leave it now.
Just one nephrostomy, one tube in the colon.
Sir, checking sir, you are not audible to me. The mic is too.
मंजूर अरे पेशेंट को छुड़ाना है कुछ करो.
That is it. Sir, since you have almost that was over, do you expect any nutrition deficiency post-operative? Sir, this is the standard length that has been advocated in all the experts that minimum it should be 170 to 180.
So going here and
We now have 29 cases and we have seen that nutrition deficiency does not occur. And we are putting them on supplements. Okay, I have got Dr. Ryan, who is the first bariatric surgeon basically. She has been given this job.
इनको बोलो बाद में ले लो.
Can you please?
1 minute.
No stress on
उसको चेयर पर
stress on the
उधर तो जी.
we are doing an antibody. Can you please keep quiet? Tell them to turn on the. Okay, can we shift to like this audio? Okay, give me. OT1 is audible, sir?
Yeah. Yes. Hello. Dr. Sajid. Hello.
No, sir, it's Dr. Ashik here. Dr. Ashik.
Yes, please take your one saying something on that, how is doing and all. Okay. I just want to show the audience what is my exit result. So we are actually, this was slightly case.
Okay, Dr. Shafiq, sir, we are talking to OT1 first. I will be taking a question. I will be asking a question to sir first. Then I will be coming to you.
Yeah, please come because we have to close the case. This has been under anesthesia since long time now.
Yes, okay, coming immediately.
Yeah,
sir.
yeah.
No issue. Mufti Mahmood, sir, and you have actually gone incidentally have lifted the adrenal now. So can you make us now almost you are completing the procedure? And why is that now you are closer to vein?
This is the vein.
Right, sir. You have lifted it from the kidney. You have to show this.
Yes, I lifted from the kidney. Inferiorly, I have dissected. Medially, I have dissected. Superiorly, I have dissected. Laterally, it is still attached.
5 cent, right?
कोई वो कुछ केस देना था मेरे को.
Are you using
simple clips?
हाँ इनको पता है सारी handle it.
We want to shift to OT3 with a video.
Oh, well, by all means.
Yes, sir. Your voice is only audible, but we're not seeing your video anywhere.
Yeah, is it visible? I think he is focusing on the C-arm.
No, OT3, nothing is visible here.
No, I'm from OT number 1. I'm Dr. Shafiq here.
Yes, okay. Now we can see you, sir.
Okay. So thank you very much. Now we have concluded the case. You can see the fluoro. Hand, please. We can see the fluoro. This I have already placed the digestant.
Yes, sir.
I'm sure that I have cleared the stone. Okay, and let me show the inside view. If somebody can show the inside view on that,
endo view.
Yeah. So you can see the endo view. We have already cleared the stone. I have already placed the stent. In supine PCNL, since last more than 200 and 250 cases, I have never given a lecture on percount.
The PCNL. PCNL.
Yeah. Show this. Yeah. So, can you see it here? My nephrostomy, the sheath is inside. There's absolutely clear reflux. There's
not, sir, we're not seeing your video right now again. They have again shifted to adrenal patient. They are actually clipping the adrenal vein.
Okay, that's okay. That's fine. So, I have cleared the stone. My exit strategy is to place a GS stent without failing. But I never placed the nephrostomy tube. This has been my practice. I have never placed a nephrostomy tube. Rather, I have done 3 punctures in the kidney, 1 puncture whether I have this tag on or a very small pelvic stone.
Yes.
I never place a nephrostomy tube unless there are conditions that demands to place the nephrostomy tube. My belief is that if you are putting something foreign in the tract, you probably are hampering the coagulation or the clot to actually cement the bleeding. So I have never ever encountered in last 300 plus PCNL, supine PCNL. I had to, yeah.
Same experience here, but in contemporary times, what are the indications of putting a nephrostomy tube in your?
Yes. If you have freely perforated the pelvis, if you are sure that there is a lot of extravasation has already happened, then you should always place a nephrostomy tube. If you feel that their system is quite, what infective, you should always place a nephrostomy tube.
Right.
Second, if the third is if you are going to come back to have a relic PCNL and start on stones, if you want to come, you should always maintain your tract. Probably you will use the same tract. Otherwise, I haven't felt any, requirement for placing a new.
So more 95% needs
Advantage is the patient is totally pain free. And the whatever pain, because of the nephrostomy, the patient is not experiencing that. And plus, I feel most of the time, putting a nephrostomy, probably we are keeping that tract always, hampering the clot formation within the tract. This is purely my thinking. I don't know how the experts are thinking about it. I have given one lecture last time also. I think most of the people in the audience will agree to me that whenever you are putting a nephrostomy, the coagulation, probably the cementing into the tract actually get delayed. So if we are giving the blood clot to form in the tract, probably the clot formation will actually hold the bleeder in the tract. Yes, if there is arterial ooze, if you have got a serious arterial injury, interlobular injury to the vessel, then obviously it is not going to stop. If you put a nephrostomy or if you do not put a nephrostomy, you will end up having an angioembolization.
Yes, parenchymal bleeds always respond to pressure only and they get closed because...
Correct. Most of the time, these are the cortical vessels, these are small vessels. Because of the pressure, they always, collapses. Because we have achieved now a lot of experiences.
We are finishing case in OT2. We would like to shift to OT2.
Thank you very much. And thanks, Dr. Javed and Professor Mufti for giving me this opportunity. I am back home. I would like to name my brother, Dr. Parvez. He is in England. He was a consultant here. He would have been very proud of our influence too. Thank you very much. Thanks a lot.
Dr. Ibar? Dr. Shakil, sir, I am dealing with treatment today. No, नहीं कुछ है sir.
एक लोकल मिलेगा लोकल रेजिडेंट पेशेंट एक्चुअली लोकल में कोई नहीं चाहिए.
We were busy with the GOT one. Welcome sir, आपको.
बस ठीक है.
Now where are you?
लोकल दे दो थोड़ा सा.
You've done a very nice thing, sir. So, what can we do? So, continually what can we do?
Detached.
Okay.
मेरे को स्टूल दे दो थोड़ा बैठ.
सर को ये चेयर दे प्लीज. Okay. Which chair?
एक स्पाइन दे दो ना.
Spine. What is the sign of the suture you will do? What? 20. Okay.
ठीक है. दे दो लोकल.
Camera.
स्टिच एक लगा देते हैं. ठीक है. ओके. Thank you. Thanks a lot. Thanks. We took a lot of time. I think. एक ये निकाल लो.
हाँ सर ये निकाल दो पीछे.
माइक निकाल.
Yes, sir.
Hello? What may I open up? What may I open up?
Dr. Salim, are you completing anastomosis in 1 layer only or 2 layers? 1 layer only. It is anticolic isoperistaltic anastomosis.
The area where the
Okay.
wider area. Then now it's what I do.
It is wonderful to watch you. You are doing a fine dissection. Very good. Very nice.
Next, sir.
You know, single layer anastomosis was in vogue long back also in our career in 80s. Dr. B.K. Jalali, the then professor of surgery, he used to give single anastomosis with catgut. We didn't have anything like. Yes, we can. We can. We were using catgut for anastomosis, that too in a single layer, and the results were excellent. We didn't have any problems. No. But now it's rational. It is risk free. It was still risky because it may leak any time, but somehow he was very excellent in doing anastomosis. Shift हो गया.
Succeed करो, succeed. अच्छा दे दो, सीधा दे. इतना ये पैर पर let's put another tab.
But you know, you had a nice proposition with all the staff.
Give me one hemlock. You are LT paper लगाओ.
So nice to watch you, sir. Such a beautiful surgery you have done. Thank you. And we are shifting to OT1. I think Professor Mahmood is almost completing his case. Hello, OT1, please.
Yes, sir.
Audio, please.
Am I audible in the OT1?
Yes, please.
Professor Mufti Mahmood?
Yes, sir.
Okay. Can you shift the audio to OT1, please?
Suction. Please.
Professor Mufti Mahmood, am I audible?
Yeah,
we can see you have almost done. I think just hemostasis is left. Am I correct, sir? How much is left?
Yeah, just bit of tissue here, which I have to cut, and then things will settle down.
Right, sir. How do you extract the specimen, sir, in this case?
Well, we'll put it in a bag and take it out.
Okay, sir.
Obviously.
Right. Same port, it's of 2.5 centimeters. So you'll use the same port, the vertical port.
Slightly port size, and we'll take it out.
Right, sir.
Scissor. Roasters वाला scissor नहीं. Roasters पर खराब कर. कहाँ है?
Go in. Instruction पहले इसको दिखाइए नहीं बताइए नहीं कि कर कब है चले कर go in.
Is being cut. It is a pin drop silence. Nobody wants to know. Absolutely. I will let sir finish this procedure. Then I will tell you an anecdote of what I saw once. Whatever the company people may say, they claim that up to 7 vessels can be taken and you can take it directly and things like that. Surgeon's instinct is always better. You know, I've seen wonderful surgeons work with them, but at the time of coming to retinal vein, hardly I can count on fingers. I've seen people applying energy source. Majority of them would be safe than sorry. Just curative.
No.
Surgeons always prefer to sleep well at night. It's better not to take any risk with the vessels either.
Go in. Go in.
Suction दे दो. Hello.
Yes, please.
Hello.
Yes, please.
Shikit sir.
जी बोले.
Okay, we are basically closing those areas and meats that we have made both in the stomach and the good thing is that it's bleeding and we don't want to close it, this bleeder, because that's a good thing. That's a good sign for us.
Okay.
This is a non-self-writing needle holder, but it's not giving much trouble. Initially, I would advise youngsters to use a self-writing one that makes the job simple.
Go in.
I'm just pressing so that these barbs, they get stuck in the tissues.
Go in.
Then we will have uniform tension all over the wound.
Go in.
Suction, please, suction.
Okay, almost closed. Podcast.
Yeah, once you go there, okay.
I'm just checking to be sure that my suturing is complete. You can't have a leak. Sir, you always have questions. If you don't have questions, then how will we know that you are there? Only when you ask questions do we understand that you are around. Most of the times you are missing. Yes, I know. Yes. Yes. Sir, can you tell me what is the secret behind it? No, you know it. You just want to test my. Yes. Why not? It's just a matter of 16,000. Another 16,000. Another. No, sir, Aishman, that is something I would not like to talk about. We are not getting any kind of help for bariatric surgery in Aishman
response, no?
because they don't consider it for humans.
Somebody is already.
They think it's for cosmetic purposes, which is wrong. No, my God.
Hello.
You think I have not done it?
Hello.
We'd like to. Yes.
Auditorium. Hello.
It is. That is why.
Audible?
Ma'am, just one second. We'll just, Professor Mufti Mahmood has finished his case. We'll just.
Can we shift OT1?
Yep.
Hello.
The case.
Hello, auditorium.
Hello, Dr.
Yes, sir.
Just listen for a while, isn't it? Come back to you.
Okay,
We'll
sir.
be shifting to OT1 because sir has finished this
Okay, sir. We will wait for some time.
adenolectomy.
No issues.
See, just one point, sir has done an excellent job. Sometimes what happens is you see that some part of, as adrenal. So everybody starts and getting, oh, this is incomplete. It's not incomplete. It's a vision you are seeing. If you would have done an open surgery, you would have never realized that about a 1 mm or strip you have left behind.
Right.
So it is a 4K and this technology which has come in and which makes you, and hardly there is any bleeding. If you look at the normal 2D, if you look not in the 4K, you will not appreciate any bleeding only. He's done a great job, and that amount of tissue can always be, with the bipolar, you can always take care of it, and it is dead tissue.
Sir, are we talking to OT1?
Yes, sir.
Yes.
You have done an excellent job. We can say, let us feel now. We can find the dissection excellent done. Excellent.
Thank you, sir. Thank you.
Praise for you. Thank you.
Blessings from my teachers.
Thank you.
Sir, wonderful job. Nicely done case. Meticulous. No bleeding.
Thank you, Ashit. Thank you.
Thank you, sir.
Bhagat, take it out.
Dr. Mufti, Baldev Singh is on mic.
Sir. Welcome, sir. Welcome. Yes, Professor Baldev, sir.
Very nice job. You can clean the back.
I think he has not.
Sir.
Yes, Professor Baldev.
Hello.
Hello, sir.
No, I think you're not connected, Dr. Kadri.
Sir Baldev Singh, you can come here. You can play.
Hello, sir.
Yes.
Yes.
Thoda loose pump, check.
Professor Mufti.
Yes, sir.
Excellent job.
Thank you, sir.
Nice dissection. Nicely. Middle adrenal vein you have ligated very nicely.
Thank you, sir. Thank you. Blessings from seniors. Blessings from seniors.
Better than open dissection.
Thank you so much. Thank you so much, sir. I'm so glad you are there.
Thank you.
Can we shift to OT3, please? Audio.
Section.
OT3. Stress level is
Hello?
very high.
देखा
Dr. Salim? Hello? Dr.
How is
Salim?
the center, sir?
Dr. Ibar?
Just a minute, sir. Just a minute. Just a minute. I'll get back to you. पीछे चल थोड़ा सा. This is the
Must be a last one. Please ensure there is no leakage.
Wells too. Wells will. Thank you.
okay. Give me the clip. Give me the clip. Was a back here introduction. हाँ जरूरत नहीं ठीक लग करूस डॉक्टर साहब मिथिलीन ब्लू बनाइए 500 में 30 ml डालिए लिसन नीडल करने खातिर
Dr. Iqbal?
Yes, sir.
Well demonstrated. You are very skillful, very nicely done.
Thank you, sir.
But ensure there is no leakage. Understand?
But that is what we are planning.
Checked.
Dikha. Already on the card, sir. We are asking the anesthesia people to push in.
The bougie.
You have taken the bougie out, sir? Madam?
Session 3.
At the most.
Third Saturday.
No problem. Section देता मैं irrigation ड्यू कचो बजे अच्छा ठीक है
Dr. Iqbal Salim?
Hello.
Is Dr. Ruxana there, the HOD of anesthesia? I want to compliment her for giving an excellent workshop. Is she there?
सर एनेस्थीसिया के साथ हमारा चोली दामन का साथ है
वही कह रहा हूँ रुखसाना नहीं उधर
Now, believe me, I don't like buttering people, but they are doing a wonderful job. दे दो Give me the ball. My team seems to be hungry, sir. Nobody is looking after them. They are slow. That is why they are slightly slow. हाँ जी रुकिए give me two instruments पानी
When we switch on to OT3 where tap is going on to be there
वहां से नहीं आ रहा है कमांड कोई नहीं सर वहां से कोई रिस्पॉन्ड नहीं हो रहा
Hello.
हेलो
Dr. Rifat? Hello.
should I start
Dr. Rifat?
am I audible
We can hear you. Please go ahead.
Can you brief about the case in table OT3?
OT3 hello auditorium
Yes, we can hear you.
hello Shakil sir very good afternoon to all of you we are going to start our third patient from OT3 this is a patient he is 55 years old male patient hypertensive from last 10 years this patient had hemorrhagic stroke in 2006 because of which he had right side hemiplegia. However, currently there is no neurological deficit. The patient had complaints of swelling in both groins from last 3 months. The swelling used to get aggravated on standing, on physical activity and standing. But there is no history of any lower urinary tract symptoms, no history of cough or any constipation. Patient is a chronic smoker from last 10 years. On examination, there is bilateral groin swelling is present. It is around 6 to 4 centimeter on left side, and on the right side, it's around 1 to 2 centimeters. The swelling is reducible, and cough pimple is also positive. So, on clinical examination, our impression is it is a bilateral, primary, uncomplicated, incomplete, direct inguinal hernia. We also have done ultrasonography that's showing defect around 2.7 centimeters on the right side, and on the left side it's around 1.4 centimeters with herniated loops above. So our diagnosis is bilateral direct inguinal hernia. Our operating surgeon is Professor Dr. Mushtaq Chalku sir. Plan is bilateral TAPP. Now I am handing over my mic to Professor Mushtaq Chalku sir so that we can discuss this patient in detail. Hello.
Hello, OT3. Hello.
Yes, sir.
Oh, Dr. Mushtaq, can I talk to Dr. Mushtaq?
Yeah, sir. Just 1 minute, sir.
Hello. Hello. Hello, Dr. Mushtaq. Hello, auditorium. I'm Dr. Salru here. Assalamualaikum, sir. Assalamualaikum. Kaise aap? How are you, sir? So nice, so nice. Thank you, sir. Please tell us something about it. Yeah, exactly. This patient is with us, an old man. Dr. Rifat has already visited the clinical of this patient. So I was trying to look back at what could be best for this person. Now I would say that if we could do a tap or treat for this patient, that was a good surgical this for this session. But preferably I would probably do a tap on this patient because of 2 reasons. I would like that so stop from knowing the true suture because when people will not understand what technical. So I think that is. But the fact is, I can place same technique as in business practice. So we got so Dr. Rifat has done. The team to my team tested the first for space and surgeons, Dr. Abhishek, Dr. Horace, and all of them. And she still from instance what we were operating. Let's start with case confirmed. I prefer to discuss this would be common federal import, common protection, which is mainly but please believe that if you are using as a thing, you should not struggle with them and you should put in my thoughts. Second, prefer to working coach, which access I have shown it with Dr. Asif will be. So this is synthesis, it still stands around 3.5 to 4 centimeters from the root pins. So this is the pubic tubercle. If you go 1.5 centimeters lateral to you have pubic tubercle, and then always understand the anterior superior root spine. I will be doing putting my ports medial to the venous and urinaries. These will be my this makes a triangulation, the triangle to make it for suturing. Now we want to use ports.
Dr. Ibar, can you see the methylene blue? Yeah. I have closed both the inflow and outflow.
We can't find a leakage.
Hello, wonderful. And God forbid there is nothing, no leak.
No
All
leak.
right.
Yes.
Even the pouch has filled nicely.
Yes.
There is no leak from this, no bleeding.
Yes.
Sir, is the audience satisfied?
Very well. Everybody satisfied.
Sir, I am not hearing you, the wrong audience.
Claps for you. Claps for you.
Thank you very much.
You can suck it off. Okay, I'll be stopping the surgery now. You can go back, sir.
Thank you so much. OT3, audio to OT3, please.
So what happens sometimes we have this, this is called ingrowing umbilicus. Hello?
Yes, you can hear you. Please go ahead.
Okay. I would just say that sometimes we have an ingrowing umbilicus. So it is very difficult to put a suture, make an incision in the umbilicus. So what we should do, I'm using my left hand, I'm using an artery clip and opening this. Yes, you can see, you can go close to this. Always, try to clean the mud there. Most of the times, you all understand and know this is the dirtiest part of the body. So we should clean that. And then I will make an incision. The bottom of the umbilicus, it should be around 1 to 11 mm incision would be enough, because I will be using 10 or maybe 12 mm put for the 3D meshes we are using. So we to use a very needle, or we can do a direct trocar, depending on better would be to do a varese. So varese is in my hand. You can all appreciate to me the line. This is a varese. Professor John's varese. So we used it. This moving was not basically meant for pneumoperitoneum, as you all know. This was for some different thing for the chest. But he used this needle for pneumoperitoneum. So it is retained by then on John Osborne's needle, Professor John Osborne's. Yeah, I'm here in Professor. So you can see the direction, and we should lift this fat up. Make sure that you lift it quietly up, and the direction could be downwards towards the synthesis. Let's look at progress. So like that, take it out, and check it. Check it. This is the saline drop. You see, you can see saline is freely moving. You are in the abdomen. If it's outside, can you take it out? Or negotiate, don't negotiate much, take it out and reinsert. Now you will see there's a sign on the insufflator. If you can attach, can you show them the insufflator sign? The insufflator sign is very important because the pressure should grow from the normal abdominal pressure. 6, 7 rather than 10, 11, 12. And always keep the left hand, always. Otherwise it will touch and pressures will show growing. That means the roof is touching. So this is very important. So you can see your left hand has to struggle, especially in fatty patients. You will have to take that cable to make it safe. And then always check the memo. Can you show me the monitor, please? The insufflator. Can you show me the reading? I don't need this table, please. So you can see. The pressure is growing up. Can you make it 15? Yeah, maybe 20. Then should be 15. Okay. So you can see, okay, it will be from 6, 7, 8, rather than 5, 50. Please let the needle. This is a safer. This is called insufflator sign. There is another thing that happens. Sorry. That you should always percuss the abdomen to show if the needle is growing, uniformly. Sometimes there are pockets. So watch everybody standing uniformly. That's a very important point. If it's not, then you may probably reinsert or reinsert the need. And this is. So this is important is the varese technique. Or other techniques, you have open laparoscopic techniques where you have what you call is Hassan's technique. People go like that, but do not keep on changing techniques. Stay with one technique and be religiously a follower of that technique. So if you say that at 3 liters has gone probably, is it 1.4? So I think that would be enough to introduce safe, proper insertion. So at this point, you should be in touch with the anesthetist also. Many things can happen. You can develop a sudden hypotension, bradycardia. So be in touch with your anesthetist group. He will tell you what all has to be done. You know how to stop pneumoperitoneum and all. So just look this needle, and you can see this liver is here. You can turn it off if you want to turn off. This is not working. So I'm taking the 10 mm trocar in my right hand. And can you please show the how to hold? So femur eminence should touch the operator, and the guided should be by the index finger. So you will guide it. It will not be beyond this. Understand how to introduce it. Right. So again, you just first go. Do spinning, do not fast. Do spinning movements and slowly. Can you lift from this? Okay. Slowly lift. Hello, auditorium.
Yes.
Hello. Sir, my colleague said that this is a case that is demonstrated in conference, so it's better to take extra precaution. Can I have? So we have just hit suture.
Please tell me that time because I should not keep on.
Hello.
Can you see the?
Try to. Someone wants to say something.
Can you get the head down?
OT2, please. Hello, yes.
Are you getting me?
Yes, yes.
Okay, I have just.
Dr. Iqbal. Professor Iqbal, you have taken the second layer only on one side only? Okay. Hello. आप पूछिए हेलो डॉक्टर इकबाल हेलो डॉक्टर हेलो हेलो प्लीज 82 प्लीज 82 हेलो ऑडियो डॉक्टर इकबाल हेलो हाँ जी प्लीज गो अहेड Okay. 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 Okay.
Iqbal, we have done external anastomosis, but is using a drain should it cause no harm?
No, not required. Not required.
Okay, let us hope she doesn't leak. Okay.
Dr. Iqbal, how can you what is the chance of internal herniation in these patients? Okay, you take a loop around and it herniate, herniation can take place. So what that is in ruin by? Okay. Please mention a patient for hernia after. Okay. For those patients who are the capacity, it's not and you have to the test of time. The program that
Iqbal sir, I would.
any right to we don't put in name to
Dr. Iqbal Salim sir, I am Dr. Ashik from urology side, although it's not my topic to discuss your bariatric surgery. But one thing I would like to say, how much it is justified not to put drain in such a high risk anastomosis?
There was a time you put name
Right, sir.
No, but intestinal
Sir, my point is only one thing.
Intestinal different. Intestinal different.
Is it only the technique of the surgeon that matters? I think the patient-related factors also play a role. And do we need to take them into consideration because it is already a high-risk patient?
There's no harm in putting it right. No harm. Yes, you know nothing.
Okay, let us hope everything goes well. Thank you very much. Thank you very much.
Just before we end, sir, this is Omar, urologist, sir. I'm your student, and I just wanted to say that there are many people here who are younger and unaware of the struggles of the senior surgeons in this room in order to make laparoscopy acceptable to a wider population here. You were one of them, and the pioneers are here, and the chairpersons also. So I just like to congratulate you personally on this wonderful procedure and for this whole workshop, and all the best for the future, sir. Thank you.
Audio to OT3, please. Thank you, Dr. Iqbal. Thank you. OT3. Dr. Mushtaq.
Yes.
Please go ahead.
Yeah, sir. What I am doing is I was trying to just show them that we should always study the anatomy when the peritoneum is closed. So this you can appreciate. This is. Can you go to the midline? This is the median umbilical ligament in the center. This down is the bladder. This is the bladder down. All saggy. We have put a catheter, so it is now deflated. This is the median umbilical ligament, which is obliterated around twice. If you go around 3 centimeters, this is the medial umbilical ligament represented by your obliterated umbilical vessels. And this is the which is the best of the external country. This is the external umbilical ligament. So, which is you can see the paper. So we would call it a hernia. Even a paper ring is more than the norm. 1 meter, you call it a hernia. This is not hernia. And between this is the dip in the hardy back. This is the hardy back with the there. You can see there is nothing which probably has gone in. This is the hernia area. And if you parent to the medial umbilical ligament, you will have supraumbilical hernias. You will always watch this area for supraumbilical hernias, which are unnamed hernias. And down there, you could even an obturator hernia. So these are the different hernias which could be around this area. You can see the flow of the ring is followed by the iliotubal tract. This iliotubal tract, if you go 1.5 centimeter to 2 centimeters deep, you will have a saphenous opening, or the femoral ring. And here will occur the femoral hernia. So this is how we could say the direct indirect and the femoral hernia. Sometimes you are down there. Here you will and contents may be going. That is thickening hernia, which is usually seen in very Yankee and very thin females. Hernia seen here, that's the obturator hernia. So that was the area, the advantage, or the the concept by my Fruchard, that we are putting a one simple mesh to cover all these openings. He calls it an orifice, not an opening. Orifice means a defect. Orifice means an opening. So he calls it a weak area. So one mesh would be open for covering this whole myopectoral orifice of Fruchard.
Sir, no. Is it a bilateral inguinal hernia or just one side only?
Sir, it is a bilateral hernia.
Okay, what is the position of your monitor?
What is the
position of your monitor?
It is in my foot end. Foot end side.
Foot end.
Foot end.
Okay, you will keep the monitor on the foot end side?
I will always keep it. I will keep it on the foot end, and I will be on either side, or I can do it on one side only. But invariably, you have an option that the hands should be tucked in if you have an idea to start doing it, on either way. But we can do it on either way. We can do it on, on the same side. So what I am doing is lifting the peritoneum. Idea here is, as we are taught to hug the GB. Idea here is to hug the peritoneum. So the man is only lifting the peritoneum, and all the fat and all the loose areolar tissue should stay down. No, yeah, but this is a very fatty man. Here I would like to take a care not to injure the gastric. As you can appreciate, I am crossing the lateral umbilical ligament and trying to get into the Hazelback's area. Now I'm entering the direct, I mean the, so it is a very fatty man. Its idea should be you start your journey 2 centimeters superior lateral to the ring and do not open the peritoneum bigger. In the beginning, you will be doing a very big incision. It becomes very difficult because you may not be proficient for suturing. So it is wise to take open the little peritoneum and do a bigger dissection inside. So what is my point is here is that once you cross the inferior epigastric,
Dr. R.C. Sharma wants to pass some comments. Sir, K.C. Sharma.
it's a lot of fat. So this is very fatty. Huh?
Dr. Sharma, if you can speak in that mic, I think then only it will be audible. I think that mic is not connected to the theater. No, there was a mic there also. Another mic was there.
So I would not cross the medial umbilical ligament. I hope you can appreciate this vessel now. Can you go there? Zoom in the cameraman. Okay. This is the inferior epigastric, which is a branch of the external iliac artery. So make sure this makes your lateral umbilical ligament. This man has quite a good amount of fat. So we are going now from the left, cut the lateral. This is the medial now. So you should not cut the medial umbilical ligament, otherwise you will enter into the vagina and may injure the bladder. Sometimes in the direct hernias, we have seen bladder as the concern. That is also a reason we should not go beyond the lateral. You can see I will not cut the lateral umbilical ligament. I will just reach on the right margin of the bladder. Now, how to make the lateral, medial pocket? I always use my right hand for the left peritoneal pocket. I use my left hand for the right because it is convenient. See like this. For this space you use left hand. For this way, medium space you use right hand. That's what I will do. So I hold it like this and go up and tell my cameraman to drop me into this. This is very important. Lot of fat there you can appreciate. But give me kusheri. Roshi de do. You can see once we enter into the medial pre-peritoneal pocket, the care should be taken that you stay the roof, don't go below. The reason is you will have a bladder down, you are pushing it medially. So you can see this loose area and white tissue. This is the white house. There will be light coming from this. We call it light house or a wind house or a power house, whatever. So push it to create a middle space. Make sure that the middle space is important to make a good middle space. The reason is you have to split mesh. In the beginning, you will be afraid to make this space. And the first thing you should see, I hope you can appreciate this white thing. It is the Cooper. And this Cooper is very important structure because this gives you the orientation of the this region. So you always keep.
With this, we conclude this session. I thank all the chairpersons for your precious time. I request Professor Baldev to come on the stage and felicitate our worthy chairpersons. Dr. Sanu, sir, please. Professor Shakil Ahmed Mir, sir. Dr. Rahul, sir. Dr. Rahul, sir. Mr. Omar Salim. Dr. Ashik. I again thank all the worthy chairpersons. I will call you as chairperson for the next session. Professor Baldev, sir. Dr. Nazir Ahmad Wani, sir. Dr. Afaq Sherwani. Dr. Zahida. Dr. Abdul Rauf Malik. Over to the chairperson, sir. Hello, Professor Chalke.
Hello. OT3 is connected?
Yes.
Dr. Nazir Wani here.
Yeah, Dr. Nazir.
Nice to see you, sir.
Thank you.
Could you demonstrate what you are doing this time?
Yeah, I am just holding the sac. You can see this is a sac of the indirect. This is a composite hernia on the right side. We have both the direct component and the indirect component. So you can see this is the fat which is at the ring. So one of the ways we detect the ring is this fat. This fat we should be always removed. This could be the future source of lipoma.
Lipoma of the cord.
Absolutely. So what I am doing is I'm holding on my left hand, holding the the sac along with the spermatic cord and trying to lift it from the posterior structures. Make sure that we should not injure the doom down, which is important. You know, the vessel is there. So you can see my left hand is trying to grope down and I'm just holding the sac.
Or is like a postgraduate, should you start dissection from lateral or medial side for the cord?
I have done the medial side. Probably we are not in touch. We have done that part. You should preferably make a medial pouch first, then go to the lateral. We have made a medial pouch. I think Professor Nazir wants to see the medial. We have done the medial pouch.
Yes, that part is clear.
You are rightly said. I agree. One should conveniently go to make the lateral pouch first, and that is technically easy also. But we are doing a biological hernia, so probably it might not mean much here. So I am probably doing what I am doing is trying to lift the fat from the underlying structures. First, remove this fat. I hope you can see this white thing coming. That is a pseudocyte.
Shining thing.
Shining thing. So this white shining thing is a transversalis, which is a very important structure for hernia surgeon. And this is to be making the pseudosac.
Pseudosac.
That was made in Maryland. So they are married together. The crux lies in reduction of the indirect sac. The crux lies that you need to see the wire going up and the diaphragm coming down.
Please shift to OT1 for the time being.
So what we do is we are shifting it up and going down.
OT1.
Please connect to OT1.
हेलो हाँ यूरोप के में डाल रहे हैं ये डाल रहे हैं PCNL होगा ये यूरोट्रिक कैथेटर डाल रहे हैं
Hello, OT1.
OT1 hello
Who is doing this case? I think for the time being we switch over back to OT3.
Okay.
Please connect to OT3.
So, Dr. Nazir,
Professor, yes, you are
I am just trying to separate the sac from the pseudo sac. You can appreciate the sac is coming and the pseudo sac is falling. Along with the pseudo sac, you can appreciate this is a big sac of the indirect hernia, this one.
Yes, yes, yes.
So I will try to divorce the sac from the pseudo sac. The correct slides in going down as much as via the vas turnus to medial. So without opening the sac, I am just trying to tease the structures, not injuring the
Converting angular dome into triangular dome.
Absolutely, absolutely. So you can see this is the important point because the separation of this is important in a way that you should not injure the structures of the spermatic cord. You can see this is the plane where we have to spare these vas, vessels. This all has to.
Dr. Chanko.
Sir.
Baldev Singh.
Sir.
Excellent job. Excellent.
Thank you, sir. Thank you, sir. Thank you,
You are
sir.
taking care of was and both bladder also.
Thank you, sir. Thank you, sir.
Very nice.
Sir, your blessings and you are my teacher and I am honored to have you in the audience.
Very nice dissection. Clean and nice.
Thank you, sir.
Both laterally and medially both.
Boss is the boss. You have to take care of boss.
Yeah. Boss is the boss. Absolutely. This man has left to the age of boss, but still wish that doesn't mean
That doesn't mean still it is boss.
that doesn't mean that you will sacrifice because everything at every age is important. But in pubertic age group, I think one should really be very cautious because the mistakes of the past you and the present you will have to harvest in the future. So surgeon should be very cautious.
Please OT1. Shift to OT1.
You can see the amount of sac with.
Yes, a big sack, of course, huge sack.
Sac भी है ना?
Professor Chalku, will you keep the sack like this or you will ligate it? What do you do with the sack?
Audible नहीं. ये sac है ना? No, he's not audible. Audible नहीं. उसको तो अभी हमें पता ही नहीं. Official होगा क्योंकि stone है. X-ray देखा.
Can we switch over to OT1? OT1.
पीछे ना नहीं है. अच्छा पीछे में. कौन से सोची क्योंकि नीचे से कैथेटर डाल के रखा ना. ऑडियो में कुछ. वो उसमें आप डाई डालेंगे. There will be some big stone in the pelvis. देखे हो X-ray. अब मिनी है, कन्वेंशन है, अल्ट्रा मिनी है, अल्ट्रा मिनी है. कौन? यही कनेक्ट है बस. अब
क्या ये भी कनेक्टिंग जरा भूल रहा है. भी नहीं. ऑडियो की प्रॉब्लम. Hello, audio people. There is some problem. Not a single audio is working in all the OTs.
It starts now.
हेलो.
Hello.
यार यूज करो ना सर यूरोल देता है. पीछे ना है.
वो पीछे लगा है.
यार हम तो एक्टिव दिस विद 3 of us about what is going on. Hello.
किसी ने नहीं है और कुछ नहीं फोन कर रहा है वो भी
OT1. Hello.
किसी ने नहीं होगा अच्छा ये इसका
Hello, OT1.
बड़ा स्टोन था
Are we audible? OT1.
कोई नहीं है कोई कनेक्टिव नहीं यहाँ कोई नहीं है इनका कोई नहीं रिलेशनशिप हो रहा है
कोई भी करो connect यार. Audio is not working.
And this is the interval. Hello.
Hello, OT1?
Yes.
Dr. Manzoor there?
Yes, sir.
Come on here. Walaikum salam. Please tell us about the case, what you are doing.
Sir, this patient is a 50-year-old male with no medical comorbidity. He presented to us with left groin and left flank pain related from groin to groin for last 2 months. Dysuria, lithuria, or any previous urological intervention. Patient was subjected to investigation and was found to have a solitary left renal pelvic calculus causing grade 1 hydronephrosis. Patient has no other comorbidity, medically fit for surgical procedure and is planned for a standard PCNL. Standard PCNL, sir. Can you just consider the imaging? Can you consider the imaging? So can you see the imaging of this case? This is left PCNL with abstinence calculus in the left this piece, which is causing grade 1 hydronephrosis. Kidney is normal, left breast is normal. No additional calculus allowed in the left right tract is good. So beginners plan for the same left PCNL.
Can you do this operating surgeon?
Sir, actually, surgeons they are busy somewhere in the transplant skills. So that's the case.
Okay, nice to see you.
Thank you, sir. Thank you, sir.
What PCNL you are using? Standard port, standard PCNL.
Yes, actually, we actually do standard dilatation, which all depends on the track size that you use.
Which dilator you are using?
So we will be using equal dilator, sir.
Alchem dilator.
What is
Can we move back to OT3 for the time being? Hello, OT3?
Suction.
Hello, OT3?
Professor Chalku?
Yes.
You are connected now?
Yeah, I would like to say important observation, and that is now many times people have published this fact. That is that I would like to take your attention, sir. What happens that here the vas, when the vas is coming out, here it goes between two layers. We have published a video. I would request people to just watch this. There is a tunnel, we call it the tunnel of vas.
Okay.
This is secondary tunnel. It has been everywhere. I thought when I published this fact, I thought I'm the first person to report it. But then when I saw the literature, found it is already published. This tunnel is between the peritoneum and the fossa transseptalis. Now, why is important to open this tunnel? Because otherwise the mesh will curl on. It will fold on. Okay. You have to break this tunnel, this tunnel where the vas is going. Yeah, this is the tunnel. This tunnel I always break so that the vas will fall down and the mesh will not curl on. Okay. So what you are saying about the mesh, see the sac, you can see this is the sac now. Can you see?
Yes.
So you want me, what I always doing is suture the sac.
Okay. That's
I will do it a single hand suturing, which I keep on doing. I just put it because my ports are only 5 mm 2 ports. So I no, not this. White will, बस से उसको खींचना है. तुझे पता है ना क्या करता हूँ मैं?
You don't use a loop? Can you use a
No, I don't use a loop. Loop is costly. No, we take a vital. We can just do with a or a silica or whatever. Just put a tire. That is cheap also and it makes the dough.
Okay.
Can you give me the Vicryl? We'll go to the other side, these colors. So meanwhile, till we can go to the other side. Professor, you can see the ring on this side.
Yeah, nicely.
Yeah, this is the ring, and this is the inferior epigastric going up, which makes the external umbilical ligament.
Yes.
This is the cave of the direct defect. This is the cave of the direct defect on this side.
Yes.
You can appreciate.
Yes.
So, the pneumo has reduced the content. Other than the gut was going here.
Yes.
This is the healthy back area and the posterior weak area where your direct hernia will come.
Yes.
And this is the medial umbilical ligament, this one.
Yes.
This is the operator area or also called as the area of the bladder. This is the area. And if you go to the median, then you have the median umbilical ligament. So since we are doing a bilateral hernia, we have to find a way out from one side to the other side. So I will meanwhile start from the other side also. So there are two ways to do it. As I will ask you the question in the beginning, that Professor Shippy, that do you want to come on the right side or left side? I can do it on one side only, but conveniently if you go to the other side, that makes life comfortable. So I would probably go to the other side and do the dissection. So, okay. नहीं नहीं मुझे माइक्रो लंबा सा दे दो ना बस चलो इधर जाओ so I will start my dissection on the other side. Can you give me the harmonic? I stay 2.5 centimeters superior lateral. I have a thought observation that we should not open the peritoneum much because then you will have to suture the much. It will take a lot of time.
Yes. Yes.
Okay. Okay. Fine. So you see, I am going on the other side. So far, can you show? Okay. Can you give me the mirror, please? So for the beginners, they should not take the left-sided hernias. They should take the right-sided hernias. Left side it should be taken as you grow in experience. The reason is that we are all prone to do on the right side standing for gallbladder. No, so tuning has to be respected.
Sir, Charlie, do you change the position? Do you come on the other side or?
I am saying that we can do it on the same side. We can go to the other side also. But it doesn't. With experience, you can handle it both things. I have seen surgeons doing right-sided hernia on the right side only, standing on the right.
Technically, it will be better to come to the other side.
Agreed, sir. So what I'm doing is I'm pushing all the fat and peritoneum up, and I'm only hugging the peritoneum. So all this yellow should go up, only hug the peritoneum. And what I do is that I cross this, make a line all along, going all along to the from the to the lateral umbilical ligament.
You always start from here only, or you can come laterally also. What is your?
No. I think I always start lateral to medial. I don't start from medial to lateral. I always come lateral.
From lateral.
Absolutely. I mean, there is an ergonomics for everything, sir. So what I believe is that we follow and respect the principles of surgery to make life comfortable. We can do anything, but general principles of surgery need to be respected.
Lateral to medial.
Rest is all innovations. One can do anything. So here one has to take a precaution that one should not make sure you watch the inferior epigastric and then cross the left lamb. Yes. And my point is always go above the defect of the direct sac. Don't cross the defect here. Stay up. Now you can appreciate the left inferior epigastric is there. This is the left inferior epigastric. You always have a vein along with this.
Two veins.
Absolutely, sir. Absolutely. So I am in the Hazelback, entering the Hazelback pad. But I would always suggest that one should not cross the medial umbilical ligament. We are still far from the medial umbilical. Since we are doing a bilateral hernia, so this is the medial umbilical, this one. So I will now never cut this, never cut it. Stay medial to the medial umbilical ligament. That's the important landmark of the anatomy. And I always use crochet. See, I have changed the instrument. I ask it for crochet. I do not develop this medial pocket by dissection. I develop it by crochet. So you see, what my point was, I use left hand for the right hand pouch and right hand for the left pouch. That is convenient. You can see.
Yes.
You see, this is the angle of triangle of laparoscopy. This is manipulation and the azimuth angles. This is very important. This is 60 degrees. So you have to understand why port making. That's why I demonstrate the ports. Ports have to be in such a way that your triangle is respected. Because we will have to switch here. So you can see what I do. I'll just dissect with the crochet. Only with the crochet. And you can see the sac of, this is the sac.
Pseudo sac is
Yeah. So it is going up. This is going up.
Pseudo sac.
That is a pseudo sac. It is going up. I am working on the principle of laparoscopy, traction, counter traction, which is the rule. So I will develop this space by opening the crochet like this. And the first structure that should be seen is the Brooklyn's paper. People is not always fixed. Sometimes you have an inferior branch, pubic branch of the inferior epigastric, and a pubic branch of the creates coronal mortis. So it is not always safe to touch at this point. Always observe a dark pot. And then I am going literally, see, you can see I am sweeping the ruler issue down. My point is that I should see the window of the other side through this. See, I have gone across. I have going. So we have crossed the midline and we can see the show of right side from the left area. Can you rotate? Can you rotate? I lifted the citadel's peritoneal flap of the bladder, which is the only connection between the right and the left, and develop the most of the space. Kindly make sure this Bindavid circle is a pelvic circulation. This Bindavid circle is notorious to bleed. Do not rub on them. Just be very gentle. You can see here we try to narrow down. Just do not do. The problem is that if you injure it, even a neuropraxia will give a waddling gait. And next day in the morning, if you tell the patient to get up, he will waddle. And then you feel sorry. So I would say that do not get into this area. Do not see the nerves now. Dr. Nazir, you must be remembering in the conferences, they were fan of showing these nerves and all. Now the Sukuna's thought is that kindly let the snake sleep under the skin.
Yeah.
Sleep them.
Don't try to
Don't try to demonstrate them. It is better to stay idle. Then we have the lot motion. So what was my point is that tacking is also now not recommended much. Some simple tacks which should not be below the inner trap. So kindly avoid the tacking part. More so suturing would be more comfortable, especially in the lateral area. Tacking should be. Nazim is looking at me. He wants more of tacks to be thrown, but I'm sorry.
What more suturing?
I want more suturing. We should do it. We should do it. So my point was, what is your suggestion about this? So I would like to. I made a meeting there. Can you give me the left hand? So I was saying that. Can you give the harmonic? So the medial pocket is seen. You can
not bring the PIP. We are getting external view only.
Okay. You will just get the. Are we in the picture?
Yes.
Yeah. Now you can appreciate this. This is the sterile space. This bladder is down. We have to make sure the bladder falls down and only the pubic symphysis is seen. Why? Because it is important that you should not make that, there are reports that mass can migrate into the bladder. So unless you put the bladder adequately down, and this is the subpubic space where the prostate sits. So do not fiddle with these lateral pedicles. This is very, you may have some amount of bleeding there. So my medial pouch is made. Now, as I was saying, for the left hand, I will use my right instrument to develop the space. So you see, I am using harmonic for convenience because it's a very fatty patient, lot of fat. So we want to make sure that give me the crochet. Dr. Chalki, this is Dr. Apa. Yeah, okay.
Sir, what if you encounter a rent in the bladder? How would you proceed?
A rent in the bladder.
While dissection.
You should not do that. In the first instance, you should surprise the patient. We had one patient where we did that. That was a redo hernia. Please make sure. Let us first, before saying that we have injured, let us first avoid the injuries. So, avoiding injuries, you first take the patient for the proper technique.
Fine.
So, I would say first, technique is also important. This technique you are using. One. Second is that in an incision where this is lower down, probably go by a tab rather tap or e-tap. I would feel more comfortable. Second, always categorize the patient of a reduced surgery or where I expect there is a cystocele or bladder is a sliding hernia. You should have CT done first in such patients to rule out a sliding hernia. It's very tricky hernia. While you are rightly saying that you could injure bladder. Now, if you injure the bladder, for example, taking all the precautions, you should not put a mesh. You should repair the bladder. Hello?
Hello, OT3?
Yeah.
Sorry for the interruption, sir. We are thrilled to have with us Professor Mohammed Salimani, sir. After such a adventurous transplant surgery that we have witnessed in the morning. Thank you so much, sir.
Okay, you can withdraw the catheter. Hello? Yes.
Sir, there was an interruption in between. So,
Yes.
what will be next if the bladder is injured?
That's what I was saying. We got disconnected. Can you just appreciate this part, what I'm doing? I'm using more of dissection in the right place. So if you're in the right plane, you will have less bleeding. I would expect this is not a hernia indirectly on this side. Make always sure the policy should be respect everybody, suspect everybody. So what is that I mean to say that always see that there is a hernia. You can see there's no hernia, but it is just a funicular. The peritoneum is closed. The rest is only the gut. But I will always make point and suspect that there is hernia. The reason is occult hernias are the ones of funicular type which will not be seen at this time. So the mesh will reduce the hernia. Can you appreciate all the structures in this? This is the valve. This is the valve. The veins, suprametic veins. So make sure that what we do. Can you give me the harmonic? So I will just do a scalpelization of this, though there is no indirect path on this side. But I always, as I said, would suspect a hernia on this side. So I will reduce. So coming to your question that what should be done, I think we should do a repair of the bladder. We have done it in one case. We should do it, and then we did not put a mesh. Can you appreciate the RAS?
Yes.
This is the RAS. This is the RAS, and this is the paralyzation of the cord. This is the paralyzation of cord, what they call us.
Yes.
You can sacrifice everything, even the internet. See the internet, and this is the RAS and the artery with the RAS. So I would not, these are the domestic veins. I can sacrifice these veins. No issue. I leave the structures down and take the peritoneum out. So this peritoneum, everything will be sat. And these are the structures of the cord. I am playing them down and working on the principle of traction, counter traction. You see that is you cameraman down, cameraman show them down. Yeah, see. This is the now. So much of dissection of the harvesting the sac on my left hand is by traction and counter traction. That we have again learned this art. So this is the point where the vas will be on the left side, the vas will be on this side, on the right side, and vessels on the left side. And in between them, you can cut this flimsy layer, loose area tissue to convert it into a triangle. I hope you can appreciate triangle of this side we have vas and the vessel. On this side we have the vessel, suprametic cord. Going as much since 2005. So what we have learned over these around 20 years is that you should go as much down as possible. I don't know stop there. I will show you that preperitoneal fold of citadel. While the vast term is medial, stop here. And I would also suggest that one should take this all fat out, this fat. Because this fat sometimes creates the subsequent lipomas of the cord. So my guide is in the always make sure this fat should be clear. This all fat. This is the fat which sits at the deep ring. This should be clear. Can you show me the bladder, please? This always has some amount of vessels attached, so some amount of bleeding would be there. One should not be afraid for that. But I would always remove this fat. This fat should all be removed. See. So push this structure down. This could be bladder here and stay down. Just a lateral tilt to your left hand makes the job easy. And see, we remove this fat. This fat should be on. Then you give me suction. Fine. So we make the section of the cicatrization of the cord, which is important, and go as much down as the studies pro-peritoneal where the vast term is in a tunnel. that tunnel is between the peritoneum and the. You see, guide wire is in the base of transversalis. Can you just go a bit lower towards yourself? I mean, CRM towards you.
Towards you.
So there is one more point. You can see this bluish structure here. Now, okay. Can you appreciate? Yes. That is external iliac vein, and this is coming up as external inferior vein, inferior epigastric vein. You can see this vein is in the external iliac vein. So is true with the inferior epigastric artery. This will come down the external iliac artery, which will continue as the femoral artery in the Scarpa's triangle, right? So can you give me the section, please? Yes. So here in this side, I am more worried because both sides we have a composite, a dual hernia, rather than in the side we have a small in the. So that side there is a big indirect and also direct component. So we should not dissect. I would also take your point that this structure, which makes the flow of the ring, is the inner tract. It is going like this. It starts from the connect to one counters and goes all along this floor of the ring. And anything what is this inner tract important is that no tract should be put down. Every tract should be up. So this is why these structures are important to be understood. Right.
41, please.
Can you give me the section, please? Yeah, dear. Okay.
Could somebody connected to OT1?
Which is who is the? I mean, yes. Hello.
Yes. Dr. Manzoor?
Yes, sir. Yes, sir.
Connected, sir.
Actually, with the other big results.
No such technical problems.
You have put the puncture, now you are dilating the tract.
Yes, sir. I am dilating the tract. Actually, the puncture that I take is, I do always, what is this much doing?
अच्छा टेक्निक नहीं करते हो आप बुलाए टेक्निक
No, sir. That actually, so,
this is prone PCL, na?
Yes, sir, this is prone. So, second thing is like this dilator. Just near the stone. Can you see?
Yes.
Sir, this is.
Fluoro picture. This is already catheter.
Can you see the picture of the same, sir?
Yes. You have put the contrast. You have put the contrast.
Sir, can you appreciate the stone? Yes.
थोड़ा CRM को
Slow.
please correct the CRM. हाँ.
Sir.
Yeah.
Yes.
Puncture कौन सा? Middle calyces or
Calyx puncture.
Middle calyces. Inferior calyces.
Yes, sir. So this is actually going to be a straight path straight to the pelvis where the stone lies.
Yeah. You prefer inferior calyces, why not middle calyces?
Sir, I prefer middle calyces also, but here I thought this is straight in line.
Why you thought in this term?
Sir, it will be less variable case of this.
The middle would have been a lot more straight. If stone goes here and there, you have to remove from other calyces also.
So
why breaking?
I can go in the, go upper calyx of this straight path.
Achha. Okay.
So, puncture. Clear. Water आ रहा है?
आजा.
Dilator.
Not working. Not connected.
वो देगा. अर्षद दे दो.
Probably this, in this case, this gave me a straight path, shorter path to the stone. That's why I chose it. Otherwise, I could have gone to the calyx also.
I think middle calyces, people are preferring now middle calyces function. मैंने सबको बोला मिडल because you can
मुड़ी में जा सकता बट देयर कैन बी आई मीन वो अपर कैलोरी इसकी तरफ आ जाता है सुप्राकास्टल सो आई एम जस्ट पुटिंग माय गाइड फॉर अल्कल डाइजेशन ओके फाइन सीक्वेंशियल मैग्नेटिस वो आपका हाथ क्यों यहाँ पर रह रहा है
Which laparoscope you are using? Which number? Hello?
Sir.
Which number laparoscope you are using?
Sir, laparoscope I will Carl stores 20.
Hello?
20. Wolf 20, sir.
Wolf 20.
Yes, sir. Dr. Manju?
Yes, sir.
Oh, you said that you have chosen the inferior calyx, okay? And what Dr. Professor Baldev Singh is meant that if you would have come from the middle calyx, that is taking you more alignment with your pelvis.
Sir, actually,
like say for example, let me complete.
Okay.
So if you have chosen the inferior calyx, your scope is your direction is towards the superior calyx. Suppose if there are certain fragments which will migrate to the superior calyx, it is very difficult in a prone PCNL to travel through from inferior calyx to the superior. You may reach there, around 20-30%. You may reach. Otherwise, you will put a lot of torque. Probably, extracting fragments from the superior calyx would be very, very difficult. So in this case, a pelvic stone, the ideal punctures would always be either from the middle calyx or even more ideal if you come from the superior calyx. Because, having a successful PCNL means that you minimally traumatize the parenchyma, make 100% clearance without putting lot of torque on the kidney. So I suggest, I feel that this puncture should have been taken from the middle calyx. I'm sure that you will do a good job here, but always take a middle calyxal puncture for the pelvic stone. Much better.
I just thought this kidney through supracostal region. That's why I avoided middle.
No, please never hesitate to go supracostal. You will never have any problem. This is something which is very much hyped. If you see the reflection of the pleura, it is almost more posteriorly when we see the reflection along the 12th rib. If you are more lateral, as you said you are doing the descent technique, if you are more lateral, the reflection of the pleura with relation to the 12th rib is almost 50%. If you are taking medially, more posteriorly, then probably there is a chance, 30% chance that if you go absolutely paraspinal. But if you are going supra 11th, I have done punctures which are even supra 10th as well. And I have never even encountered the pleura. You can ask your anesthetist to put the patient in complete expiration so that the pleura will retract up. So then you can even take the puncture even supra 11. Never hesitate to take supra 12th as well.
Thank you, sir. Thank you for the peaceful advice. I mean, piece of advice.
Employees sheet number? Manzoor?
24, sir. 24.
Employees?
24, sir.
Okay.
I think we switch over to OT2.
OT2,
please.
Can I ask?
Sure.
Dr. Salim Wani here, Dr. Sahab.
Okay.
Hello, Dr. Manzoor.
Dr. Manzoor, Professor Salim Wani wants to
connect back to OT1.
Connect to OT1.
Harmonic.
Can I doctor operating doing PCNL at the moment?
Sure. Shabash.
T1.
Shabash.
Dr. Manzoor.
तो मेरे सवाल के सुपरकास्ट को तो क्या कर सकते हैं बेस्ट वन बताओ
Can I somebody connect to OT1?
Dr. Amir, you are audible? Yes, sir.
Patient of 35 or over. They know that hypertension and very treatment. Person to pain number 2 months.
Simple if you must come because they should constitute immediate restrictions. The important for audience. Audience should be. वहां से पानी आ रहा है, ठीक है, उसका पंचर ठीक है, हो गया, पानी आ गया, वो आ रहा है ना, वाटर इज कमिंग, क्लियर वाटर, प्रॉब्लम इंफीरियर से आप कैसे रिश्वत दे रहे हैं, ऐसे ही बोला मुश्किल हो गया कोई।
Okay, Dr. Hamid.
हाँ, इसमें रिएक्शन सेटिंग सब बोल रहे थे, कुछ मान नहीं होगा तो क्या करेंगे। वो मुश्किल से वो पानी आ रहा है उसको, उसने नेफ्रोस्कोप डाल,
हेलो,
ऊपर देखो ना,
चल रही है ना?
इज इन 24 फाइन नेफ्रोस्कोप डाल, नहीं जैसे पानी
Dr. Manzoor, Dr. Salim Wani here.
फ्लशिंग फ्लम लो।
Dr. Manzoor, is OT1 connected?
Sam. हाँ सर.
Dr. Manzoor? Dr. Manzoor, am I audible?
Yes sir. Yes sir.
Can you please connect to OT1? Dr. Manzoor?
Dr. Manzoor,
Dr. Wani has some point. Hello?
Sir. Yes sir.
I just want to know.
Dr. Manzoor, yes.
I just want to know what is the sheet size you are using at this point of time?
Sir, sheet size 24. 24.
Okay, and what was the size of the stone?
Scope is 20.
The size of the stone.
Stone size is 17 centimeters. 17.
So you are doing the standard PCNL.
Yes, sir. I'm doing standard PCNL.
So why not mini PCNL?
Sir, this was actually processed in a standard PCNL in this patient.
Okay. So we could use a smaller sheet, an 18 or 16, and do mini PCNL for
Sir, you have not given me audible.
I say that we could have used a smaller sheet like 15 or 18 rather than 24.
Hello, Chetan. Hello. 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 Hello.
Hello, Manzoor.
Yes, sir. Yes, sir. Dr. KC Sharma here. स्टोन निकालना तो हम सभी हम सारे स्टोन निकालते हैं, कोलेस्टेक्टमी भी करते हैं. आई एम कलेक्टिवली requesting everybody sitting here, let us find a method with which stones are never formed. Can we do that? Let us think it over, and we have got some simple solutions for it. That stone will never be formed.
Well, let me get that question. There is no technique, no method, no medicine in this world which will prevent the stone formation.
Yes.
Renal stones will not form only if there are no kidneys.
Perfectly true. But the simplest method is that since God, you take the more fat twice a day. It contracts all the time with polycystic system, and then stone will never be formed. Please try it on your patients, and you will have no regrets about this. Very simple treatment. My treatments are always very, very simple, cost nothing, and take little bit of fat so that once you take a fat through cholecystokinin, gallbladder will contract twice a day. Stone will never be formed. Thank you.
I hope you was talking about the gallbladder stones.
Yes.
No, we thought we are talking about kidney stones. Okay. That's what Professor Wani said, that there's nothing.
What is going on?
Yes. We got confused, sir.
Excellent, sir. We're talking about gallbladder. Not about kidney.
Hello.
Hello, Dr. Manzoor.
Yes, sir.
So, if you enter after, a good puncture, you had a clear efflux, clear urine or the fluid, and you have dilated the tract. When you enter, you find that there is only blood, you cannot see anything.
Yes, sir.
So, what exactly you should be doing? For me, you should see outside the PCS, or there is a big clot sitting in front of your scope. Take some time, do some suction, okay?
Suction.
Have an idea on the fluoro where you are exactly, and then analyze the situation. I feel that you may be slightly outside the system. You will very soon reach to the stones. Okay, just take little time, do some suction, take out, clear the clot, and you will be there. Okay.
Yes, sir.
Okay.
Sorry.
Back to OT3. Go inside.
Dr. Mansoor.
Yes, sir.
Good afternoon, sir. This is Makhdumi here.
Yes, sir.
How are you? How you are doing? But for the youngsters who are watching you and who will do it one day, please inform them and tell us the management of the unknown and unseen complications and challenges you feel in this CNR and how should we manage it? Throw some light, please. Hello. 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 Dr. Manzoor?
Yes, sir. Yes, sir.
Sir, good afternoon, sir. Sir, can you throw some light that in case of PCNL, what are the other challenges and what are the other exigencies and emergencies which you face in PCNL, though it looks very safe? And how do you manage it? This is only for the youngsters who will come, who will change. Yes, thank you very much.
If we don't find it because of the bullet, we should,
Can we go to the hernia, please, now?
we should check whether we are in the system or not. That is to be checked.
53 now.
So if you are not in the system, we will try so if the other variants so where's it?
सर आपने कहा पीली पर्सन
खुल गया जरा इसको सिस्टम नहीं खुल रहा ना
ये ऐसे आप ही मार्क लिया होता
हेलो
बैक to OT3 please.
Connect to OT2 or OT3.
तो दोनों बोल रहे हैं ऐसा नहीं चलेगा यार ऐसा नहीं चलेगा अपने चले के अंदर से कोई आइटम ये पकड़ो हाँ ये है नहीं इसका है नहीं पानी पिलाओगे प्लीज पानी तो लगाओ ये वाला पानी लगाओ छोड़ो छोड़ो
Yes, yes, we can see.
पानी लगाओगे प्लीज माफ कर दो वो घर में दे चलो वो घर पे वो था चलो ये पानी निकल रहा है यार यार ये तुम्हारा पानी मारो को ये नीचे खाली कर दो तो खींच दे यार खींच घर पानी लगा हेलो
Hello. Hello.
वो तो फिर से बोल
Hello, Professor Chalku.
so वैसा
Which you are using?
And which size is it?
Which mesh you are using and which size you are using?
ये बता दे रहे
Hello. OT1, am I audible to auditorium?
Yeah.
Hello. Hello.
Yes. Hello, am I audible? OT1?
Hello.
They have this size only, 15 by 10.
Yes. So go. Rasa go go ras. Hello, Palas.
Can you play OT1?
Yeah, Palas. Chalo go. Go. So go.
Hello? 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 बोले हुआ तो आप बोला उनको स्पेस पर फोन करो ना उनको हेलो हेलो कर बात पहले ये कौन से केस है सर नेक्स्ट यूनिट कौन है सर OT1 कनेक्ट करो फिर हेलो एम आई ऑडिबल OT1 हेलो
Hello.
एम आई ऑडिबल
Hello. OTC.
हेलो
बोलो बोलो यार वो वहां से डालो हम लोग कुछ आपको यहाँ से आप
हेलो
Hello. We are running from OT1. This is a 60K pre-male male with no medical comorbidity. And the chief complaints of the patient was left flank pain for the last 7 days. There is no history of any hematuria, fever, constipation, or dysuria. On examining the patient, the general physical, he was a thin patient. For abdomen, there was no distension, no mass, no tenderness. And on examination of the inguinal scrotal region, it was within normal limits. Investigation and all within the normal limits. We did the imaging of the size into 3 centimeters. MRI slide of the patient. Cameraman, please look at the MRI slides. MRI slides. Are you able to see? We are starting the case. Are you able to see the MRI slides?
Yes, we can see.
Yeah. What the beginning of the case?
I think we switch over to OT2. Hello. Sir,
जब बोलेगा मैं लगाऊंगा
लेके आओ
Hello, are we audible? OT2? Hello. OT2? 02, yes. Professor Nasir.
Could you please demonstrate what you are doing right now? You are using ICG. Okay. Yes. How is it? How is it? Nicely demonstrated. Okay, nice, nice.
Routinely using this ICG or in specific cases where we anticipate some. Hello, sir, are you routinely using this ICG or in some specific cases where you anticipate some?
पहले बोलो माइक लगाना है सर
अच्छी तरह करना बंद हो पूरा ज्यादा कट क्या
ठोकर लेने सर
हमारे पास क्या ठोकर है हेलो ठीक है मेरे बेटे को रखो ना साइड में
ले ले ठोकर
कौन सी ठोकर से
सर एक एक्सेल का कोड
एक्सेल दे दो बाकी वो दे दो चलो एक्सेल यहाँ दे दो
एक्सेल 5 है ये
वो साइड में टाइम दे दो ना
एक्सेल वाला 10 नहीं है हमारे पास
तो कौन सा टाइम है ये कौन सा
एक्सेल 11
है क्या
11
बस ठीक है वो ठीक है ना
हाँ सर
मैं तो मैं तो कह रहा हूँ जल्दी निकालो मैडम आप 5 दे दो ना उनका 5 ले लो छोड़ दो चलो बेटा मुझे दे दो फाइनल रिपोर्ट तो कार शाजा बेटा आप थोड़ा मेरे साथ यहाँ रोजे पे रहो ना चलो 5 मैम 5 बस बचपन मिलिटेंट 5 थोड़ा बस जो है ना ये वाला इसको निकाल दीजिए इसको चलो बाउल फोर्स अपने हारमोनिक कर लिया पकड़ पकड़ चलो उसको बोलो मुझे ऑडियो देने के लिए अच्छा ना बस ओ हीरो
सर बोल रहे ऑडियो दे दो
स्पीच होता नहीं यार अच्छा चलो हेलो
टॉप लाइट ऑफ
चलो टॉप लाइट ऑफ हारमोनिक Yeah, good afternoon, Dr. Nazir. Elderly patient who is having the primary central carcinoma of the distal ureter very close to the region. Yes. So my procedure will be two-part. I will do a mastectomy laparoscopically, and then he has to undergo distal uretectomy, and that will specimen will be removed for brain incision. Okay, sir. Okay, sir. So first, my first, yes, sir, is a transperitoneal route. So I am using this time a three-port configuration. In a diamond configuration, we have a on the right hand, there's a 10 port, left hand 5 port, and the telescope is a 10 port.
So my first step will be colonic mobilization so that we can enter the retroperitoneum where I can see where is the kidney and what is to be done. Yes, sir. No, not VJ mass. Whatever cystoscopy, the blood is absolutely normal. It is almost a centimeter away from the vesico-uteric junction. Is it distal uteric mass? Yeah. No, no, we are simply done a cystoscopy and the distal ureter we have done some scopy and that was showing clear cut TCC mass. So we didn't try to go proximally because sometimes it can just simply induce infection in the obstructed system and then your procedure becomes difficult. Yeah. No, nothing like that. That's a protocol where we can do a kidney screening. Like we do a distal uretectomy, then we do an implant. But keeping in mind the volume of the disease, I am suspecting that it may be high-grade TCC and keeping in mind the age of the patient. So best option for the patient is to go a nephrouretectomy with the excision of the bladder cuff. So we know that no biopsy has been taken. No biopsy. I've had an uteroscopy where confirmed the malignancy on visual inspection. So it was quite imaging features, cystoscopy features, everything is clearly showing that there is a malignancy in the distal ureter. We have initially done a CT urogram, then we have repeated an MRI. Okay, MRIs revealed that the malignancy is confined to the ureter, there is no external extension and there is no local lymphadenopathy. But the longitudinal extension of the tumor is quite long. Okay, sir.
This biopsy, the final sort of early report comes when a don't get malignancy.
Shafiq, actually, I'm excusing for this thing. So let us focus on the procedure itself, I think, sir. That will be much better, actually.
So, do you think that even taking an overnight mass or definitely would have been the ideal price?
Yeah. Okay.
Should OT2? OT2 please.
आगे चलो. Okay. It is not helping me actually. It is not helping me. Maybe in critical scenario it may help. We want to see is the fat, whatever it is, but for a routine procedure which we do, I think we shall do.
चल पीछे आ जाओ
Can cover both sides. You can come just behind the median ligament. Median ligament.
मूव हेड आगे चलना रे
Yes. Yes, yes, it fits to the contour. They are meeting each other.
आगे चल बॉस पीछे पीछे आ जा पीछे आ जा फिर बड़ा हुक लगे मेरे हाथ में हेलो which been colonization now are now yeah just a minute बेटा ठोकर निकला आपने निकल कर दिया ऑब्जर्वेटर just a minute the trocar is out
Okay.
madam actually highly questionable ultrasonic surgery is always a hook. I can dissect with it, I can cut with it, I can coagulate with it, I can control bleeding with it. So the bad part of using hernia is actually they fuse the layers. And sometimes which makes your procedure difficult because you are not able to get the planes. I think surgery has to do a lot with the planes.
if you're pulling the right, you can see the two different types of fat. This is peronephric fat and this is colonic fat. And this is a mesenteric vessel you are seeing. बेटा किसी का भी हाथ कर वो नहीं करेगा यार बॉस मेरा हाथ हिल रहा है ना when it at a critical point ये गड़बड़ हो जाएंगे जो पीछे बॉस we're following this line huh okay
Yes, yes, listening. Yes, yes, we are listening to you, sir. Yes, nicely demonstrated. So that means you see fruits which was only going to the government and lifting the government one third government liver back. Yes, yes, nicely done. So this patient has given how much checking. Patient has small vestibular implant.
कर दे इतना रखा कर दे
Now
आराम से कोई बात चलो 7 बजे
चलो बोलो देखिए चलो स्टार्ट करो आप लोग चलो बेटा अरे वो बंद हो गया
बेटा मुझे डिस्टर्ब नहीं करेंगे
अरे सर ये लाइट बंद है इसने मेरे को तंग किया है इसने मेरे को बहुत तंग किया तो ड्राइवर ने जान बोल के दिया मेरे को सर बस दबा है बस खत्म मतलब शायद वो कारण को तो बड़ा मुश्किल होता है मगर ऐसे ऑपरेट करना ये बड़ा मुश्किल है ऐसे ऑपरेट करना हम्म और
थोड़ा
हाँ जी पहले पहले नहीं करो देखना नहीं है Yeah.
hello okay sir I think you are connected to a different button okay गॉज भी तैयार रखना बेटा close section
Oh, radiation. Only section. The colon. Show the colon. बेटा इंस्ट्रूमेंट निकालते हैं ना उसको पकड़ना होता है आर्टरी बंद करो ना इसको शायद बी अटेंटिव मैं दे दूं ना बॉस नहीं ये वाला नहीं स्टोर्स का नहीं है हाँ इनको जरा इधर बुलाओ स्टोर वालों को इधर बुलाओ बेटा इनको बुलाओ ना इधर शो मी एट 6 o'clock बेटा इसलिए काम नहीं कर पाऊंगा मैं इससे काम नहीं कर पाऊंगा
You know, only that line or that yeah. Otherwise, there are more than 1,500 meters.
You also follow me
What do you want to believe?
yes sir yeah
What are you doing here?
I am this time I reflected the problem I just now want to locate where is the ureter and the pelvic calcium system so that I can reach the hilum and then do an effectomy actually.
So Jani,
Yeah, yeah, please.
so Phillips, what's your plan for dealing with the urology? And are you going completely total laparoscopy? You will take out the bladder cup from a steel arm.
Because we have to retrieve the specimen through some opening in the abdomen. So it is always better to make that incision in the lower abdomen where we actually dissect the distalmost part of the ureter and excise the cuff and remove the specimen. And do coexisting lithoscopy if you are interested in. This is a dilated pelvic system, I suppose. Yeah, this is a ureter actually. You are touching my instrument. So you can see how flimsy it is. The wall is very thin actually. बेटा आगे कार स्टोर के लोग
What do you want to do? Please, correct.
Harmonic. Harmonic. हार्मोनिक मैडम शाहजा बेटा थोड़ा यहाँ फोकस करो ना इधर से वहां से नहीं हमारे पास दो आदमी है ना एक वहां से बात करेगा एक यहाँ से करेगा बेटा
Yes, yes. Very nicely demonstrated. ICC nicely demonstrated and critical level safety.
चलो आगे चलो
Very nicely demonstrated. You want to put it through or not? No, no. I hope you might have heard the class from the articulate whatever.
section
Thank you. Thank you.
Raj Pisudi
Professor Baldev sir.
अच्छा जाओ increase the pressure clip ready clip ready unlock चलो जल्दी unlock section level आगे चलो
Hello. For the next session, for the college year person, Professor Mohammed Srinagar, Head Department of Ministry, State Trainer Medical Science.
unlock hello
Professor Mohammed
section
Professor Dr. Urology Director. Yes, Professor.
harmonic
Mr. Akash.
पानी पानी ना रहे पानी ना रहे प्लीज मुझे मेरे सेज के हिसाब नहीं है हेलो आगे चलो
मंजूर सर मंजूर सर मतलब ये मंजूर सर से काफी मिनट सर
इससे बताओ आगे चलो हेलो हेलो मॉर्निंग मॉर्निंग क्या है
When you check the house and clear stone, hello, it's audio चल रहा है तो मैं वही बोल रहा हूँ मेरा जो कैमरा मैन की तरफ दिखाता है मैं दिखाता स्टोन क्लियर है इधर जाता हाँ मेरा कैमरा कैमरा दिखाता है की तरफ आ जाए से आ बैठते हैं हेलो
चलो क्लीन कैमरा
सर हेलो yes sir actually I have done my best the story
बाहर निकाल दो
one year Siam
10 सेकंड को बाहर रखो
you can see that this is the kind of identity my choice in the see always culture to do a program so after seeing the program we will phone at the other African is also can you see straight alignment I think not very clear sir here we can see this is
काट के उसका फिर है ना प्लीज इंस्ट्रूमेंट आपको
ये लगा हुआ है
आगे
कैमरा वाले को देख लो प्लीज कैमरा से so this is why I'm just going straight into the after paralysis of the kidney
forceps
so now I have cleared the area like a stone this is the stone area this is the pelvis we have cleared the stone and we have just put in a stand here
show me screen.
So can you just show the CR image? The CR image will tell you the stand in place and no radiated shadow now.
I'm not comfortable with this instrument in the left side. आगे चलो आगे बढ़ो
That's it. Thank you, sir. Thank you, sir. Thank you. Thank you. Well, से बोलना चाहेगा मुझे क्यों बोल रहा हूँ नहीं तो
एक बंद करो ये बंद करो इसके मैं
ये कुछ लोग ऑडियो बंद
करे क्यों
हेलो कुछ चलो come good yes sir thank you so much sir sir I have done colonic mobilization I have mobilized the spleen because the size of the kidney is quite large due to the hydronephrosis so we had one issue during the procedure one of the vein actually blood which we managed and now we'll target next thing will be the hilum so I want to approach the hilum in a better way sir actually during the procedure I changed 2-3 instruments it depends actually what are you trying to do you are trying to develop the planes use the hook you just want to do the resection with no bleeding use the energy and sometimes you have to use a bipolar you have seen that Mufti Sahib use the bipolar for the coagulation of the adrenal so it actually depends what you are feeling at what is the best energy source for that there is nothing like the person starts using harmonic for all steps of the procedure yes, there are some situations where we use a suction cannula for the dissection, but usually there is no recipe suction cannula. If you are dealing with the veins, the usually small veins tear and where field can sometimes go bloody. It's always better to see and cut rather than do it blindly. Seven, please correct me, Mike.
Walaikum salam. Fine, sir. Yeah, please go ahead, sir.
With an energy source, you are working within the connection between the pole and the unit and the electrical. And we are all operate a pole in services and information. You should be a process there. Somebody. Second thing is what I was not knowing what is the residual capacity of the kidney level. Though the tumor is right at the luminous part of the ureter. How much kidney is left over? Or is it only a simply a hundred kidney which has remained now? Now we are going for the liver being affected. That's the question is on.
Sir, with respect to user, sir, please.
Communicate with the field. Who is asking the options like proper. So, after
Touching me.
you want to give the point, you can let your feelings in the PCC or the campus. Then they have to value or the area. That time we have to be the natural irritating at the top of lights. Will this be functioning or not? So then, leading back to the point and the status of this, 50 lights are going or not, that's not the right. Regarding the function of the resource, that was very well great question. Because when you are using an resource, give it Bible or not or whatever resource can be there, you need to put why you can with the surrounding structures, especially the landscape. The research about what the reason we thought is that those who have been given Bible have some fully time before stacking the base to the
Rajan. Rajan. Rajan.
These are not competitions where the not some of the meetings can not happen, and here they operate with obvious caution.
Yes, sir. We are touching each other. Should not happen. Clean it. Clean.
Otherwise, should not be part of the extrovert training part of the activity.
Yeah. Good afternoon, sir. I will orient you, sir. So my camera is actually just at the umbilicus, sir. This is the abdomen. You can see the left level floor. The mobilized spring, sir. Okay. This is a mobilized colon. This is a sphenic flexure of colon. And here you have a kidney proper. And this is a dilated ureter, serpentine type of ureter. And here also is a pelvis. Okay, sir. There is a colon going in the pelvis. Left colon going. And दोनों चीजें पकड़ इसको मुझे फोर्सिप चाहिए बाउल वाला उनको बोलो बनाने के लिए काल सुधन को
So I give you the order of the Thank you so much.
Move ahead, move ahead. यार को बेटा अभी नहीं आप खोलो उनका बाउल फोड़ सकते हो नहीं आप खोल सकते हो उनका चलो चलो you can wait approach this point you have a hug huh? So let it dissect it बट नहीं हम से क्यों खड़े हुए
And the most important thing is that it is not mobilizing from inferior to inferior. Keep going here, mobilize the supreme quickly. Drop the supreme more clearly, and then you will have your agenda and you are able to feel better. If you are sparing the agenda, maybe you can have a very
Sure.
so it has to be flat in front of you rather than confidence areas. The second thing is when you are approaching to the time, you should trace the gonadal gain. So the gonadal will take you to the gain, and then once you are completely sketched the view again, go to the diagram. The first thing I should see the significant and medial aspect of this diagram. Then you can actually jump onto the arches. That will lead to a safer procedure to me.
and Kadir
Okay, I think God will blame for
I get it
and
sure
yes, we do not need episodes. But Professor I first mentioned, if you do not believe that force, it will just give a person.
बेटा फुट मेरा
If you are using force, something you are the experience in the audience of culture, because this is ultimately for you guys. We will be there, your making our persons and operations from what
Sure.
is here.
I get it
How to use these characters. We remember our time when the Danish football came there. We were never treated as cookies. Now we are doing
और कोई मुझे धक्का नहीं देगा धक्का नहीं मुझे देना कोई चलो
this stage, you can see the colon is still attached with icon towards the height. So I would like to make a note, which will be,
चला के
system will go in the that you will be able to give a good fraction and resolve or to push it up.
report
Out study. Yeah, this is a gonadal going to be female bone, sir. This one the tributaries of emotions. Thank you so much, sir. Nishajan.
quality of your life with the loss of happen fear is we will not be done I want to go to or I'm very again. It's very important that once you're writing how
She was.
we words and see that clearly the part of the knowledge again clearly you're going to create a space in the third you're not sure that you don't get that it's clearly
Scissors. Okay, okay. One there. So what section are in the hand?
Such a sun.
Oh, go. Focus here. Camel ready. And then. Hमारे land. मतलब फिक्र है मुझे जो मैं मैं करनी तो ये मैं इसमें जैसे आई कैन फंक्शन पेंट है इसका आपको तैयार करना है से पद इंस्ट्रूमेंट गो come back come back come back आप यहाँ रहो ना बेटा मुझे नहीं करना चाहिए आप बेटा आपको नहीं पता ना थोड़ा सा इसको बारे में छोड़ा
hormone. Actually, the fat part sometimes it is having some rupturing vessel in it. So I have a very difficult anatomy in front of me, so I have to take all the step very cautiously. Come back. Suction. Yes, sir. I have the 4K system, sir. टच नहीं कर मुझे टच नहीं कर वास्कुलर स्लिम बॉडी ऐसे नहीं करो हेयर क्यों कर रहा है So it is not a straightforward uterus, it's a serpentine type of uterus. So it's very difficult to lift up. There is only chance that if someone lifts it, it will open up. That may happen with me also, but yeah, we can do it. The point at which I will feel that I really need it, I will definitely put it. Look. Look. बेटा सब खोल चलो आराम से करना Yeah, please.
So you can, for the sake of demonstration, you can put it one port and give it to your assistant. Probably.
Sure.
You also see how the thing changes after putting it.
Actually, almost 95% of procedures, even also 99%, we would always do it on the 3 ports. Suction. चल पीछे आगे चलो
Surgeon need to operate from both hands. The left and right hands both are very important. I always give a
अच्छा से चल
one. He has past one day according to I as good as the right that thing. So I think this example across to every time if somebody is looking at my next to me, this is
चलो
more important than
यहाँ से दिखा यहाँ से देखो ऊपर से ऊपर
and your assistant is even more important than So you have to have an assistance always,
चलो
attraction equal
अपने समझो हाँ सर ओके ओके सर sir, that's how you manage a difficult situation. So let me show you how I'll be connecting down to 3 ports. Section, please. Gauze, please. चलो आगे चलो आगे चलो आगे Battery on monopolar Maryland. Section. Maryland ready, huh? Maryland ready. Fine. चलो आगे पीछे से रोल पीछे से Don't touch my forceps here. Yeah. Go. अच्छा अच्छा चलो आगे हाँ चलो आगे तुम कर रहा है यार ये रोज अच्छा दिखा रहा है चल टच नहीं करना मेरा इंस्ट्रूमेंट टच नहीं कर टच नहीं कर रहा मेरा इंस्ट्रूमेंट कर रहा है तेरे मुंह पर लिख रहा है तेरा नोट तो नहीं यहाँ स्टूल रखा था हमने बैठने के लिए
The transition was very good.
हाँ थोड़ा सा लेट सिक लाओ
The teaching has been that the laparoscopic teaching has been that a person should walk onto the laparoscopy only the edge of the referee.
बेटा वास्कुलर स्लिंग चाहिए मुझे आता है रखना चल 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 ये मेरा कहाँ रखा था अरे कार्ड स्टोरेज के लोगों की तरफ ना हमारा सामान की तरफ सर सबके सूटकेस में कार्ड स्टोरेज का बाउल फोर्सअप होगा खाली बाउल फोर्सअप निकालो चलो बेटा चलो बेटा हाँ रुको रिसेप्शन में खोलो उसी के तो पैसे हैं बाकी क्या है हाँ सब गड़बड़ किया है बस ठीक है कोई आउट ऑफ फोकस है ना मुझे कुछ समझ नहीं आ रहा चलो बेटा मुझे दे दो ना मैरीलैंड अब अटेंड करो बेटा अब मैं चलेगा नहीं ना कॉट नहीं मुझे चल पीछे आ जाओ चल बेटा आ गया Bauer split. Split is the answer for all pathologies. There is section beta.
Now,
ज्यादा आगे हो पता क्या कर रहे हो आप खेलते हो ना जैसे कोई आउट ऑफ फोकस हो जाता नहीं गड़बड़ कर जाते एट वन टाइम ऐसे
better eating utilities and one important surgical principle. The same surgery for the children because that surgery is nothing. You will learn they will tell surgery you will not work.
टेंशन हो जाए पूरे मजा क्या आएगा एंजॉय आपको हमको कोई देख रहा है छोड़े मेरा उसको से अच्छा तो गौर नहीं करते ये तो नहीं करना है मुझे नहीं डालना है आपको डालना होता है बात कर दो सीवर तैयार रखें डॉक्टर साहब पेशेंट लाइट है क्या दिया सर सक्शन कहाँ से ब्लड कर रहे हो ब्लीडिंग कहाँ से आगे चलो आगे चलो चुप कर लो नहीं कहाँ से आएगी इसके लिए फाटक पड़नी पड़ी अच्छा अच्छा थोड़ा सा सीजर मेरे हाथ में ठीक है, जल्दी 2 बार काउंट करूंगा। चलेगा। हार्मोनिक हार्मोनिक ये आपके दिमाग में होना होना चाहिए ना, ऐसे नहीं करो ना थोड़ा टाइम। चलो suction. Yes, sir. Yes, sir. Keep artery in front of you, sir. Yeah, sir. This is artery which was dissected. Thank you so much, sir. तो इसको ऑटो फोकस में कुछ प्रॉब्लम है। हार्मोनिक पीछे 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 मुझे मुझे हिमलॉक पीछे चलो। मैरीलैंड मैं इसके साथ ही इसको खत्म करता हूँ। मैरीलैंड वाली चलो तैयार। section. लोड 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 क्लिप 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 है यार। क्या हो गया आपके जो दिमाग में मुझे वही कर दे रहे हो। आप ये पूरा सुनो, मेरा सुना करो मैं क्या आपको बोल रहा हूँ। चलो आप तुझे क्या दे रहे हो, तो मैं इसको शफीक है इसको बात कर देता हूँ। यासिर भाई अब आगे कर पाएगा? ये सीजर 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 उनकी सीजन की तरह है वन फोर में
नहीं ये अपनी है हमारी
वो नहीं थी वन फोर वालों की
मैंने खोल लिया अभी
आगे तो आगे तो आगे मैंने क्या बोला क्या Atri sir, you are with us? Atri sir, okay, you are with us, sir? Dağ başı main but Sharif. Caesar. मैं तो कहानी कहना भूल गई चल surrounding the blessings of so many people who are auditorium praying for me. Harmonic. Okay. क्या कर रहा है सुनिए यार क्या कर रहा है सुनिए यार मैंने निकालना होता तब पकड़ना होता है समझिए पकड़ के नहीं रखो section section vanilla clips sir actually where you have 4K system there are some settings whenever it will be fat it will glow just like bile you are seeing the color so it tells you it is fat तो मैंने क्या बोला आपको मुझे क्या चाहिए क्या बोला हाँ देखो फिर so that's what I'm telling you I'm seeing bile in the kidney sir at this point we should not relax sir sometimes there are excessive arteries and you should simply start cutting and you have your day so you need to sir luck is the bro Maryland clips आगे चलो थैंक यू सर again sir unlocks क्या उल्टी क्लिप लगा रही है उसमें डॉक्टर साहब और क्या ये भैंस लेनी चाहिए ना ये जो होता है ना ये फ्लैप ये उल्टा रखते अब आएगा ठीक है दिखाऊंगा आपको मैंने क्या बोला तुम्हें पहले मैंने तुम्हें बोला ये गड़बड़ करेगा मुझे दिखाता ही नहीं बॉस सर
Also, we have LiverSure, we have Thunderbeat, we have three harmonics. That's what actually I am trying to cover in the artery which is inside. Sometimes there is an artery in the LiverSure does not help. So this is the best way to actually manage this fatty tissue. You are doubly sure. So you have clipped it, now you can divide it. Even if there is something inside, it will not bleed. The bipolar तैयार रखना. चलो हेमलॉक. अच्छा अच्छा. आपने देखा हम कैसे कर रहे हैं हम. सेक्शन थोड़ा पीछे जाओ. Actually, there is no point in removing the adrenal. Though taking the adrenal make the job easy, but हेमलॉक. हाँ बोलो. आपको कुछ बोलना है? आगे चल. आगे चलो आगे चलो. स्मोक निकालो बस. स्मोक निकालो. चलो आगे चलो. There is some pulsation somewhere.
Essentially, this is more handy and tournament things because when you are using the number of ends and if you try with the defective or even easy and fly your economies. If you are applying some hits on the
हेमलॉक. हेमलॉक. अच्छा अच्छा.
that's something that maybe that's the advice of some things on me on my way of saying.
हेमलॉक. अपना गंदा हमको यहाँ दिखेगा ना. इससे गंदा उनको भी वहाँ आएगा.
I can do surgery with assessment in mind, but they will get a poor picture. है बात समझ में? इसलिए साफ रखना इसको. चलो पीछे. चलो सक्शन हो जाएगा. आगे चलो. आगे चलो आगे चलो. सर क्लास खत्म तो नहीं हुआ. सर थैंक यू सो मच सर. थैंक यू सो मच सर. थैंक यू सो मच सर. Sir, all this I owe to IKD Ahmedabad actually. This is how we are doing the donor effectiveness. So, almost 90% procedures in IKD are simply assisted by the sister. There is no doctor available. Because in IKD, you run almost a dozen tables simultaneously. So, everyone is responsible for his table. Only donor effective are done by residents. So, that's where I find to my these reflexes set. चल आगे चलो आगे चलो आगे चलो आगे चलो ऊपर 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 आगे 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 चलो आगे चलो.
And you go to see something, or you just don't give it up this and this speak anyway. I'm trying to. So the volume to do it can just be up to expecting. It's not a component. Score of the hazard one is 1 years. It's right now leader did.
पीछे जाओ पीछे कर. ये दावर पानी लेके गया था. वो पानी लेके गया ना.
You can dissect out all the lymph nodes, all the lymphatics around and make them bare. So,
मैडम आपका हमने क्या क्या मिस किया?
I think
वो दीदी ने
come in.
Yes sir.
I think endovision is lost. Okay.
I mean, like we have telescope actually. चल 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 ठीक है मुझे लॉक वाला नहीं चाहिए मैडम दे दो मुझे आ गया चल शो मी द किडनी खोलो खोलो
I just want to ask, was there any different arrangement of force? Yes, for this case. Just.
are you the standard ports because I was forcing it's like a difficult case. If the sort of India strikes the case, I think my ports would have been a bit in such a way so that I can tackle the distributor. Since I was knowing that my difficult part of the surgery will be dissecting the hyaline, dissecting the water, so I have not changed my ports. Same ports which are used for radical partials, same ports I'm using. Here, I'm ready. Yes, sir. Sir, actually, I will after completing my nephrectomy, I will dissect the ureter. And after dissecting the ureter, I will see up to what level I can do. My target will be to reach the visa. Then I get a small incision in the lower abdomen, increase the specimen, dissect at the fujo and the blood succession also. Yeah, definitely. Yes, definitely, sir. And the same will do it. No price we're doing a good nephrectomy, but actually not addressing the malignancy itself. So we have to deal the nodes in this patient. It was not only external disease of the nodes, but still nephrectomy in the form of limited nephrectomy on the left side will be done, sir. चलो आजा पीछे थोड़ा पीछे आजा ये पीछे आजा क्या चल रहा है पीछे आजा आजा पीछे 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 आजा आजा कल भी आपको इधर ही होना है जैसे लगा अच्छे से हो रहा हूँ तो मैं सर इसमें तरावत से पीछे आजा थोड़ा सा पीछे आजा पीछे 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 चल 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 चल
Insurance department, he said 50 plus. I asked where are they? I count hardly 10 or 15 in the audience. There nothing else is going on in anywhere in the SMHS hospital at this point of time, except for the doctor on duty, which could be handed over to a junior person at this point of time and come back. Because, believe me, watching this case, it's not so elegant. So, and they should have it here. Trying to ask them into asking questions.
I put ready to try.
How do we stand up to ask the questions? I think this is the weather is very perfect outside.
Look in the boss. Which way they go? तो फिर गलत लगाई ना चल ठीक है आगे चलो आगे चल अच्छा जा पीछे 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 पीछे
They go in place, you have to have a particular leading point, particular point of time. And you have that jersey, you have that right, close it up.
क्या क्या ओके section आगे चल स्प्रिंग के पास स्प्रिंग 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 पीछे कहीं कर रही हूँ स्ट्रेसेस मुझे बोल रहा है चल आगे चलो हमारी दिक्कत है What happened to the gas? चलो इधर दिखाओ कैमरा क्लीन कर यार कैमरा क्लीन गर्म पानी के लिए मंगवाओ फिर गर्म पानी मंगवा पहले जाकर वहाँ देखो ना वो पीछे क्या देखना है हार्मोनिक
Small and that's doing ways that, and so.
Thank you, sir, for your many words. And all we got.
Thank you so much, sir.
I thank all the chairpersons for their valuable time. Now I request Professor Mufti Mahmood Singh to please come on the dais and please administrate over the chairpersons.
बेटा ओपन ट्रायल क्या रखो उसको स्पेसिफिक निकालना है ना उसको पोजीशन में रखना है पोजीशन नहीं देनी है
Professor Mohammed Salim sir, please.
आपने टेलीस्कोप साथ किया तो इसमें क्या हो गया फिर से
Professor Arif, please, sir. Yes, sir, Bajaro sir. Thank you all. Some very good cases lined up tomorrow, and some faculty who is prior to the helping them out. So inside also and access it. Please, without you, there's no workshop, there's no fun and fun there, there's no or having sense of workshop by individual not. Then there's proactive audience and solve when people want gratitude. And this is actually good for our students and postgraduates. You will not believe. When I went on I saw a huge line of medical students. He basically learning the future. And they were so excited. And that is what we intend to promote here, to sensitize our new generation, our students. Thank you very much.
ऑनलाइन ही चल रहा है ये सोशल प्लेटफॉर्म पे यूट्यूब बंद नहीं कर रहा है उनको बोल के रखो हाँ यूट्यूब पे ट्रांसमिट हो रहा है ना इसमें क्या है बेटा यूट्यूब पे चालू रखना बंद नहीं करना कोई ये रिकॉर्डिंग हो रही है ना ऐसा कुछ नहीं करना है रिकॉर्डिंग के लिए हमने यूट्यूब पे यूके बाकी जगह पे हमारे डॉक्टर्स हैं जो जाना किया है तो इनको देखना ये इनको जाने की गलती होती है तो आप मुझे पूरा ओपन करना चाहिए उसमें कोई चीज ओवर लेंगे बट अभी वो सारा हमको करना चाहिए इसलिए केसेस ओवर ऐसा कुछ नहीं है आप ही कर रहे हो कि कोई और आ रहा है? हाँ, आप ही आ रहे हो, आपके साथ ही हो रहा है?
Yes, sir.
अच्छा ठीक है, चलो होता है यार।
Ready.
तो तुम हारमोन तैयार करो, हाँ? और मैं फिर अलग से फोटो उठाएंगे, घबराएंगे आप, और मैं अलग से फोटो उठाएंगे, टेंशन नहीं है। बस मुझसे दिखा रहा सर। आगे चल। सीजर्स, पता नहीं क्या होगा, अब तैयार है, वीडियो भी बंद है। हाँ दिखाऊंगा, दिखाऊंगा। वेरी नाइस। थोड़ा दिखाता हूँ, मुझे सीजर का स्टैंड नजर आ रहा है। चलो आगे चलो, आगे चलो। अच्छा चलो चलो, अच्छा या mass fixed mass.
चलो बच्चा लोग ओपन तो अब निकालेंगे इसको नीचे से, इसको स्पेसिफिक को निकाल लेना। चलो बच्चा हार्मोनिक हार्मोनिक चलो बच्चा लोग हो जाओ पीछे 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 चलो कैमरे को दिखाओ। चलो बच्चा लोग उठाओ सारा ड्रिपिंग वेपिंग, इसको पेशेंट को नहीं ड्रिपिंग करनी है। चलो सारा लैब सामान उठाओ बेटा, खाली में ठीक है, देख ले एक बार, देख ले देख ले देख ले, मुझे पे भरोसा नहीं है ना, देख ले नहीं, देख ले देख ले देख ले देख ले, सेक्शन है थोड़ा सा बेटा, फ्लोर के पे मुझे दिखा। मालिक है यार, पीछे चलो, ये सारा ठीक है बस, ये सब रिविजन किया, मेरी टेंशन। चलो बच्चा लोग जल्दी, डॉक्टर साहब ठीक है नीचे साइड से बेटा, हमको ना इसको सुपाइन करना है क्योंकि जो स्पेसिमेन है ना वहां से निकलेगा, सो कुछ हाँ हाँ हाँ, वहां से हमको यूनिटरी और टफ हाँ गाड़ी में नीचे तक करेंगे, अब तो एक ही बात है ना सर, वैसे करके तो स्पेसिमेन निकलेगा तो वाकई भी निकलेगा, निकाल दे क्या करना इसका, फिर गैस से निकल रहा है, गैस से निकल रहा है, इंसिजन मत जाएगी। अरे टॉप लाइट ऑन करो, ये निकाल दो बस मेरा। हाँ,
3 मिनट रखना चालू और जाएगा।